Just wanted you to know we came early in case you needed us.
Joint Committee, Oversight Committee to order. Just a couple of housekeeping note, well, maybe just one housekeeping note for the committee. Just a reminder, if you are going to email your recommendations to Connor, please do it before 10 o'clock. That's when they're going to start trying to get everything printed up for us. So just if you have a recommendation that you would like to send to Connor, please do that before 10 o'clock. Everybody welcome this morning. We do have a full agenda, so we're going to get right into it. First up, with us virtually, we're going to have a presentation on KanCare. Michaela Whipp is with us. She is a private citizen. Michaela, welcome to the committee. Okay, so we're going to skip over that one. She's not with us yet. We're going to skip to, we had United Healthcare was going to do a presentation yesterday, but we had some technology issues. So we are going to welcome them now. And Kevin, welcome to the committee.
We're going to try to do a little bit of in-person as well as remote. So I have two team members on the phone, and we're going to talk to you about a program on transportation for the IDD population. Yesterday we talked a lot about work. We talked about the IDD population, and we talked about the needs to be able to get people work. And I think you're going to be pleased with some of the results of the program partnership that we have. On the remote with me, I have two of my team members, Dill Marcico and Corey Stoltz. Dill has had 30 years of transportation experience, and Corey actually came to us recently at United Healthcare. Prior to that, she was working with the Johnson County Community Mental Health Center. So with that, I'm going to turn it over to them. I'm going to do my best Vanna White and see if I can advance the slides for them, but I think we're ready to go. Dale and Corey.
Thank you, Kevin. And good morning, Mr. Chairman and members of the committee. I am Dale Marcico, and I'm beginning a part of our presentation. As Kevin mentioned, yesterday we did hear a great deal of discussion about many of the problems that affect individuals that we serve, especially in the IDD population. That's been made worse by COVID. It's also been made worse by some members having to relocate during the COVID crisis home. Some have older parents. Altogether, they raise different kinds of mobility challenges, but we are mostly concerned about the mobility challenges it raises for our IDD members who are in fact working or being trained. Our project was really an outgrowth of a project that we started several years ago with Johnson County. You may have remembered that we did testify here about it before, but we created a project with Johnson County that used peers in the behavioral health system to provide transportation back and forth to our members and provide them with support services and trained into the network that they could reinforce communications with case managers and caseworkers working together to reinforce those individuals who were going back and forth to work, making sure that that was going well, and if they were having any difficulty, to let us know through the case management system. We decided that looking at that situation last year with COVID, that we should consider trying to expand that service by including our IDD members who we hadn't served before, because they were having many of the similar kinds of challenges our behavioral health members did. And Corey will say a little bit about why and how this was accomplished. And Corey, if you don't mind.
I thank you for letting me testify this morning. Let me just quickly tell you what a SPEAR specialist is. That's where I came up with the idea of using actual clients of the mental health center to provide transportation, as that is one of the top barriers Should I have the next slide, please? Yeah, and it's, like on here, these are all the barriers that I found out that the IDD was experiencing. And the biggest one was they'd find a placement, and then when they tried to utilize the public transportation, it was either a 30-minute walk to a bus stop, they were out of the catchment area, and, their hours weren't the traditional 9 to 5. They might need an evening pickup, which I was able to do because I was able to staff a fleet of drivers that ran from 6 a.m. to 11 p.m. And next slide, please. I'm nervous, sorry.
I think this is definitely mine. So Corey, what we did was, as we said, we had an infrastructure with Johnson County to provide some transportation to behavioral health patients. With the help of our corporate leaders, we found some additional funds to expand that service. And we did it by employing some additional peers for behavioral health patients. We also added in some additional vehicles. And then we began a process of working with case management, both at United and at Johnson County, to establish a working relationship with the members or their guardians. And as I mentioned previously, some of these situations were very difficult because we did have individuals who were IDD folks moving home. And they were moving home, but they still needed transportation back and forth to work. There were conflicts with that because some people in the family couldn't provide that transportation every day because they were, in fact, working at different hours and different shifts, as Corey mentioned. And in addition to that, a significant number of the people that we were working with had very much older parents who were, not able to provide that regular service back and forth every day. The other thing
Yeah,
I'd
and
mention too is that we did take into account some of the challenges of the COVID situation, and we did use some vehicle modifications so that we had separate compartments so that we could protect the passengers as they rode, as well as the drivers. And we did that in conjunction with our friends at Johnson County, and we also worked out a way to account and bill for the services. Next slide, please.
And I'd like to say too, a lot of the IDD population using public transportation is something very new. And a lot of the family members and the guardians were very nervous about putting their loved one on the public transportation, as some of them would be on the bus for almost an hour and a half before getting to their site. And some of the people, they only worked a couple hours, and there wouldn't be another pickup available for 4 hours. So there was that time where they were just being, nothing to do. We have a couple of success stories I'd like to tell you about. John, he's a member of the IDD population, and he had no transportation whatsoever. And what makes it really difficult for him to utilize the public transportation is that he was mainly nonverbal. I mean, he could talk and stuff, but he was not able to understand and answer questions like, is this your street? Is this your house? Or whatever. So we were able to provide him a chance to go to work, and it's turned out great. I mean, he's made it to work every day. There's some challenges. It takes some extra coaching to get him in the car because he has, some of his symptoms is OCD, so it takes him several minutes to undo the door. But having a peer pick him up, they are used to those special effects that were the special care that it takes. And sometimes it's the peer driver themselves that has come back to the office and said, hey, I've noticed that when the radio's a little loud, this person becomes more anxious. And then can you put it in there so if I'm not there to take him, the next driver will know. And so that's been a real plus because they're an extra set of eyes and they are really keyed in on when someone isn't exactly doing well, and they're the first ones to tell. Well, they would come in and tell the dispatch what they saw, so then a case manager could be informed to check in on them. Another success is Mary. Now, this shows we had to collaborate with the public transportation on this one. Um,
Next slide.
she, oh, thank you, Dale. Mary got an internship with the IRS, and it was located down in Kansas City, which is outside of the catchment area. So, and she was 3 miles away from the bus stop. So, what we would do is we picked her up in the morning, got her to Johnson County Community College, and we had the driver stay with her as it was at like almost 6 a.m. in the morning. And so the driver would stay until the bus got there and picked her up. And then she would go down into the IRS building. And it was the same way on her return trip. She would get home. The bus got her back around 5:45. We'd have a driver there that would then take her the rest of the way and get home. So we realized we can't do it all, you know, all by ourselves. And so the collaboration has been pretty good. I mean, we're able to take a lot more people. I think in the last year, in 2020, we took 100 IDD individuals from Project Search, and they were able to work. And most of those were 4 days a week. So I'm pretty proud of that. And it's just thanks to the consumer drivers. We would never been able to do that without their assistance. Dale?
Thank you. And one thing that we'd like to add in particular, even though it isn't directly in transportation, I want to make a comment about the employers that provide job opportunities for IDD members, particularly in Johnson County. We are very fortunate to have employers in the private sector who have experience and worked with us in the past, worked with Johnson County, that do a phenomenal job in creating opportunities for particularly IDD individuals to have good paying, even part-time or full-time jobs. So that's also part of the partnership, I guess, that Corey mentioned, that the employers play a significant role, the family members and guardians play an important role, and the peer that provides the service is often the bridge between all of those elements that make our project a little bit smoother. We have some questions and answers that we worked up to try to address what we've learned. I'll take the first one, and Corey's going to take the next one. But in this case, could regular transportation to employment for IDD members impact employment possibilities? One of the key things that came across in our work with the private sector was making sure that individuals, especially IDD folks, got to work on time, weren't late, didn't miss days. And what we think we got from that experience is making sure that people are on time is a key element to helping IDD members continue to work in the private sector. So in this regard, it's very important that you have that continuity. And again, in reference to the peer drivers, they know how to handle issues that arise with some of our members who have special challenges between when they get picked up and when they go to work. So in fact, it does make a lot of difference, and it isn't something that exists by riding the bus, or if you don't have any other way of getting there, any other mechanism to get you back and forth. Corey?
Dill and Corey, I appreciate we're at the 15-minute mark, so I'm going to go ahead and stand for questions. I like the Q&A pieces that you have in the deck, and they have that in front of them. I'm going to stand for questions, committee.
Okay, committee, do we have questions? Senator Gossage, then Representative Ballard.
Thank you so much for being here. The question I have is in slide 9, it talks about the IRS and their estimation of travel expenses. And then the next statement says the project costs for members average $3,000 for those working full-time. So how is this payment made?
I'm going to go ahead and defer to Dale.
Okay.
We obtain funding from United Healthcare and their corporate structure to pay for the demonstration. One of our goals is to try to figure out how we can take that number forward and try to find ways that we can work with both Johnson County and with United to share the costs in the future. But that we started by using a grant to make sure that we could provide the actual cost of service. And we use the IRS comparison because it's, what it really does cost to take a person to work. This is also at the same time employing peer drivers. So that money that we're spending here does go directly to other people with disabilities who provide the service.
And two other questions. So then I'm assuming that these peers are paid. And
That's correct.
then you can look at, so that's their job, right?
Right.
So you're helping them get a job as well as the other members, the 35 people that are participating in the plan, or does that include the 35?
No. One thing I'd say is, look, Johnson County, as everyone knows, is a fairly well-established economic community. The number of peer drivers working in our program who are people that have special needs is almost 52 people. So that's 52 people in part that provide these services that wouldn't have employment opportunities otherwise. Sometimes they receive part-time payment, sometimes they receive full-time payment, which increases the quality of their life. So I hope that.
Yeah, Dale, I think if I could prompt the senator's question as well by just saying that the model we're talking about with other counties as well, do you want to maybe talk about the expansion possibilities?
We think that we've been looking at what happens on the subject of missed appointments, and we heard a lot about that yesterday. When we hear about physicians and clinics not making enough money, one of the things that's really involved with that is if people miss appointments. Unfortunately, for a lot of the behavioral health and IDD people, it's harder for them to get around. So we've been exploring the possibility of how we can take the same model and use it in community health centers and other community mental health centers to help finance it by not losing the cost of that person's trip because they have some special need and they can't get there. So we've been examining that, and I think that we're going to be trying to expand that notion into the other couple other areas. The other thing is, as we mentioned yesterday, there are major employment shortages, and part of our goal here was to figure out how we could use people that had behavioral and other challenges and get them back in the workforce to help us provide services to themselves and to others. So we're trying to address both of those issues.
So then to conclude, I add up 35 that are being transported and then 52 people that are working full or part-time doing this. So basically you're helping to employ 87 people through this program.
Yes. Go ahead, Corey. Why don't you address that?
Yeah, actually, it's a little more. That 35 people is just the IDD population.
I see.
We do approximately, the Johnson County Mental Health and Consumer Drivers Program does approximately 160 rides a day. And we figured that we actually have 140 people in a month going to work.
Thank you so much.
And just to remind the committee as well, I know that we talked about this earlier in the presentation, but when you're talking about behavioral health or IDD special needs, the job full-time means different and part-time means different. And so it's not necessarily a 40-hour week that we traditionally think of. It can look a lot different than that.
Representative Ballard.
Thank you. Thank you, Mr. Chairman. This really is, I would say, an unusual program, and I'm sure other states have it, but From what I hear, they really have it well organized. How are the drivers trained?
Corey, that's your wheelhouse.
Okay. Yes, the drivers, when they first apply, they go through the same background checks and everything that a regular county employee goes through. And then when they come in, we give them defensive driving. We do a shorter version of the MANT system, which will help them with de-escalation skills. So if a situation happened where, you know, their passengers started having some issues, they would know how to act. We give them HIPAA training. We do hands-on driving tests before they're let out on to go on the route themselves. So it's pretty in-depth training. And if we get like someone says, that, a person, they saw a car going too fast, like if someone were to play, then the supervisor would drive with them. But and this is a proud fact that in 2020, when we did almost 483,000 miles, and we had 0.01 accidents and issues. So I'm pretty proud of that.
As you should be. That's really outstanding. Let me ask, what's the average age of your driver? And a curious one for me, because of a study I'm doing, is do you have more women drivers or men?
Right now, I think we have a few more women, but it's really close to being 50-50. And I say the median age is about 35 to 40.
And maybe I missed it, but what do they get paid an hour?
Right now, my driver, well, they're not my drivers anymore, sorry. I still consider them my drivers, but the drivers, they get $7.25 an hour.
All right, thank you very much. Thank you, Mr. Chair.
Representative Reese.
Thank you so much for the presentation, and I came late to the committee. I don't know if anyone, or if you covered how this is billed, or if it's billed at all.
We set up a system on billing with Johnson County, which we pay based on the cost per trip. And the cost per trip is controlled in some respects by how much a driver is paid, the cost of fuel, all of those things that come out into a trip cost that we use as an average. Johnson County bills us for that after subtracting out some of the stuff that they provide us without charge, because they're already doing some of this work. And then we've been using grant funds from United Healthcare to pay for the service.
Okay, thank you.
Okay, I do not see any further questions from any of the committee. So, Kevin, thank you very much for the presentation. Committee, we're going to back up. Michaela Whipp is now with us online. Michaela, welcome to the committee.
Can you hear me?
We can.
Okay, sorry, I'm trying to get to somewhere that has a little bit of quiet here. I'm up here in the hospital with my daughter currently. Okay, I'm here.
Okay, Michaela, you can go ahead and proceed.
Okay, I apologize in advance that I am not more prepared. I thought I was going to have more ability to get something wrote up and presented to you guys. Sorry. My name's Michaela Whip. My daughter's Ivy. She's 8. Her primary diagnosis is spina bifida. She has a lot of other things going on. Yesterday, she had her 7th invasive brain surgery, and we are currently up here sitting in the PICU. And I'm so sorry. It's distracting. I want to thank you for the opportunity for us to get paid as parents. It has really meant a lot over the last year while she has been at home for school. I have instantly become her teacher and responsible for all of her education, as well as being, her full-time caregiver. And it has made it possible for us to continue doing that. She is currently, however, still not back at school for obvious reasons. She's got some health stuff going on. And for the rest of the school year, we don't plan on her going back to school, even to the extent of part-time, which again has left me this year as her teacher. Once again, I do apologize. I have so much content that I have a hard time expressing to you guys about this.
Michaela, you're doing a fine job. So, do you still need to continue, or?
Connor, I didn't get the my little speech printed off before we put it up here. So I'm not really sure what else to add to that.
Michaela, the committee does have your testimony, and on your very last line, or very last paragraph, I think you probably want to touch on maybe and I'll read it if you don't have it in front of you. I beg you to take a serious look at making parent pay permanent. Without it, parents like myself are in an impossible position. It truly has been a life-changing blessing to us, with most of the benefit going directly to our children with extra needs and their siblings that also pay a great price for having a more expensive family member. Thank you for taking the time to hear our story. Michaela, would you be okay if any members of the committee had some questions for you? I don't know.
Yes, that would be great.
Okay, thank you. Committee, do we have any questions for Michaela? Representative Ballard.
Thank you, Mr. Chair. Ms. Michaela, your testimony is very compelling. I have read it. And our chairman just mentioned that last paragraph. And what struck me when you say it is a price that the rest of the siblings pay in your family. Would you like to just talk about that a little bit, please, and how you handle that?
So Ivy, who's 8, has a 12-year-old sister. She was 4 when Ivy was born. We were almost immediately forced to move so that we could have access to health care for Ivy, which essentially uprooted Violet from her friends, her family, her school. Things like dance lessons and extracurricular activities are extremely, they pose a huge challenge for a family, not only because I am gone so much dealing with her little sister, but also the money side of it. When we are home, when we do have time, we can't afford that extra money to pay for things like that on a regular basis. So she has really missed out on a lot of extra opportunities that she would have otherwise had, that she did have before Ivy was born. And she's been, she suffers with a lot of emotional trauma, also that is directly related to Ivy. She has watched us do CPR on Ivy several times, and the money has been a great help. I sent her to summer camp back in Nebraska this last summer that was something she had been doing, and it was very therapeutic for her to just kind of get back to that.
I want to thank you very much for that. I think we have a verification in many ways of what all is happening within the family. And I would agree that it is very difficult on the other members because of all the attention the other one is getting, but because they're not. So it sounds like you're doing the best job you can to try and help the other one feel that they're very important within your family as well. Thank you very much. Thank you, Mr. Chairman.
Senator Petty.
Michaela, this is Senator Pat Petty, and I just want to thank you for taking the time at the hospital when you were with your daughter there. And I know that your trips to the hospital are multiple, but taking the time to work your testimony in for us is quite helpful and compelling, and we appreciate your taking that time.
Thank you. It is very important to me that we are heard and understood.
Michaela, again, thank you very much for taking the time out of your day, your busy and hectic schedule, to testify before us. It was very meaningful to the committee, I believe. I do not see any further questions, so we are going to go ahead and move on to our next conferee. So thank you very much.
All right. Thank you, everybody.
Committee, now we'll turn our attention to a presentation on the Kansas Kids Mental Health Access Program. With us virtually is Dr. Rachel Brown, an MBBS professor and chair of psychiatry and behavioral sciences, University of Kansas School of Medicine. So, Rachel, doctor, welcome to the committee.
Thank you. And my name is Rachel Brown. I am a physician. MBBS simply means that I got my medical degree in the United Kingdom in London. I'm also a psychiatrist and a child and adolescent psychiatrist. And I'm here presenting today with my colleague, Dr. Carrie Harris, who is a pediatrician. And both of us are here at the University of Kansas here in Wichita, where we see patients, teach our residents and students, and also work with the Kansas Kids MAP program. So thank you very much for the time and opportunity for us to talk about Kansas Kids MAP. You have, I think, our testimony. We'll be spending a little bit of time reviewing the need. Our presentation and testimony includes some examples of individual children whose primary care physicians called us for advice through Kansas Kids MAP and who have therefore benefited from the program. And then we're going to talk a little bit about the way in which the program is set up. We are very proud of the work that we have done here in Kansas. Our program improves access to the highest levels of expertise for children and adolescents and their families who are experiencing mental health problems across our state. Kansas Kids MAP is funded by the Health Resources and Services Administration, so it's a federally funded project that partners KDHE and the Departments of Psychiatry and Pediatrics here at the University of Kansas in Wichita. Our program does not directly treat children. However, what we do is to provide ongoing education, consultations around individual cases and children, and support for the physicians and clinicians who are working in primary care all across our state. And in that role are seeing and treating children and adolescents with mental health problems and their families. Our view is that if we can help one physician learn how to help one child, we know that that physician's skill set and expertise will grow so that that one physician can help so many other children and their families in that physician's very own practice close to that child's home. The goal of our program, and we believe its achievement, is that it provides increased access to care for mental health problems without compromising excellence. Kerry's running our slides. If you could run to the next one, Kerry.
There we go.
Yep. So this information, this is actually you didn't run on, but I'm going to talk a little bit about the prevalence of individuals, youth with mental health disorders. Many youth who have mental health disorders receive no treatment. Just over 10% of U.S. youth receive any treatment at all, far fewer than the number who have mental health disorders. Treatment wait times are very extensive, often as long as a year, and many untreated youth are significantly disadvantaged compared to their healthy peers. Our Kansas youth report experiencing depression and suicidal thoughts at a rate that is above the national average. This information isn't news to any of you. I've worked in 5 US states and in 2 countries. I specialized in the care of children with mental health problems for more than 40 years. I've never worked anywhere where the services provided come anywhere near meeting the need. It's no longer a surprise to me, but it remains very distressing to me to know that there are so many of our young people who suffer from treatable conditions that can be life-threatening, that interfere with their ability to function, and may have impact that extend for many years. We miss so many opportunities to do more. We know that if we treat early and provide expert care, that psychiatric illnesses and the individuals who suffer from them, the outcomes will be better. We know that 50% of adult psychiatric illness starts before the age of 16 and 75% before the age of 21. The earlier and more effectively we can treat, the better the outcomes. So this is little Kylie. I'm not going to go through all of the details here. He's an example of a child who's been served by KidsMap through his primary care physician. If we were going to go the route of providing specialist care for all those children who need it and their families, it would take many, many years to develop our workforce and much investment for Kansas to close the gap in the provision of mental health professionals who have the ability to work with the children who need our help. And of course, the mental health professionals that we need come from many different professional backgrounds: social workers, psychologists, behavioral health technicians, all kinds of people. But just as one example of the state's shortage, our testimony includes the data for child and adolescent psychiatrists, which is my specialist background. My professional organization will tell us that we need about 400 child adolescent psychiatrists in our state to provide care simply for those children and adolescents who have severe emotional distress. And that leaves aside many children who don't make it to that designation. Our state has 60. And of those, the vast majority are in the top right-hand corner of the state. And there are 5 of us here in Wichita, Kansas. And then west and south of here, we have nobody. So the shortages that has, as you all know, been made worse by the pandemic. Many of the children that we see and children in our state are really struggling because of the additional stressors. They had problems prior to the pandemic, and their problems have been exacerbated by the stressors their families have experienced over the last 2 years. You've already heard me talk a little bit about the workforce challenges facing Kansas for mental health care. As in any field, it takes a long time to train an expert. We believe that while we need to work on workforce shortages at all levels, including more spots for the training of those with the highest level of expertise, child and adolescent psychiatrists whose training takes upwards of 12 years, that we need to take action now. So Kansas KidsMap, which has been a project that's been up and running now for 2.5 years. In that short time, we've already begun to impact children's lives and the lives of their families in a very significant way. So in order to say a little bit more about the program, I'm going to turn it over to Dr. Harris and have her describe the program and how it's structured.
Now you can see the slides?
Yes.
Oh, sorry about that. I was advancing them to myself, apparently. Well, thank you all for having us, and thank you for handling that, Dr. Brown. So yes, like Dr. Brown said, there's a huge shortage of highly trained experts in child mental health. And as she also said, I'm a primary care pediatrician, so I've spent 10 years of my career treating children, often with mental health issues, having had not substantial training in my historical traditional pediatric residency program. And that is true for primary care. There's a lot to learn in a primary care residency and not not a ton of time historically has been devoted to pediatric mental illness, but we know, like Dr. Brown said, that pediatric mental illness is increasing. Certainly, it was prior to the pandemic, and it definitely has been since the pandemic. One thing that is unique about my career is that I have been blessed to have mentors such as Dr. Brown and other child and adolescent psychiatrists who have kind of taken me under their wing, so that I've had significant continuing education in pediatric mental health. And that is what KS Kids Map is designed to do. It's really to equip primary care physicians to step into that void. We know that it's going to take a long time to train those highly trained experts. And so we really want to make an impact now. And so we've designed KS Kids Map to meet the PCP where they are at. Central to the program is the primary care physician or clinician. Usually this is a physician or an advanced practice provider. Sometimes it's a social worker or a case manager. And they can access the KS Kids Map through 3 ways. The first one is the consultation line. And this is where they can call in and within 24 to 48 hours, get expert advice from an interprofessional multidisciplinary team made up of the child and adolescent psychiatrist, a child psychologist, a social worker, and myself, a pediatrician. We can provide different resources for the child that the primary care physician is caring for. We can provide education. We can provide consultation on medication management and on therapy resources. And I think this takes a lot of the legwork out of the busy primary care clinician, trying to find a place that they can refer their child for therapy, maybe that is culturally competent for that specific family. Our social worker can do a lot of the legwork, and unfortunately, many primary care physicians and clinicians do not have availability of these types of resources in their office. The second way that the clinician can access our program is through our ongoing Tele-Echo Clinics. These are all teach, all learn environments, and we have been going for 2 years now with our Tele-Echo Clinic. We meet bi-monthly on the first and third Tuesday of the month over the noon hour. And this really is an opportunity for us to learn from each other through case-based learning, which is typical for clinicians to learn. We have clinical discussions. We have a very brief, focused didactic on a child mental illness topic. And then the remainder of the time is really just kind of troubleshooting a complex case together, putting more brains together and being able to have that child receive expert care where they are at in their comfortable primary care office. And then the third component, which we'll talk about a little bit later, is the physician and clinician wellness arm of the program. And this is really important because we know that when you are caring for a child with mental illness, that takes a different emotional toll on the physician or clinician than taking care of a child with, you know, an ear infection or a sinus infection or a twisted ankle. And so we really want to make sure we're providing support for those physicians and clinicians as we are asking them to increase their capacity to manage mental illness in their practices. So if you remember Andy from the testimony that we provided, this was a kiddo that was really kind of an all-star 17-year-old doing great, who really began struggling with depression and ended up having a very strong impact on his academic performance, his social behavior, and his relationship with his father. This is a hunting family, and at one point the physician asked Andy if he had any thoughts of suicide, and he said that he didn't think it would be very hard. He knew where they kept the guns. Unfortunately, you know, this is scary for a lot of reasons, and certainly that physician is definitely concerned for Andy, but this is a small town physician, and so it's not just, you know, a patient-physician relationship in small towns like this, right? This physician knows this child, he knows the family, and he's going to feel very connected to this patient and almost like that paternalistic feeling of, oh my goodness, you know, what's going to happen to this child. On top of that, the PCP that was caring for Andy had just lost another patient to suicide. And so it just hit very, very hard for this physician. And so it's really important that we support that physician because we want him to be able to provide the best care for Andy and prevent another untimely death. And so our KS Kids Map program is built to be able to provide support for those PCPs when they are struggling with things like this. We had designed this intentionally when we started KS Kids Map 2.5 years ago. We had no idea how important this arm of our program was going to be when the pandemic hit. According to data from last fall, in the height of the pandemic, 76% of healthcare workers reported being exhausted or burnt out. 69% reported feelings of depression, and 13% of our healthcare workers have had thoughts of suicide. On top of the pediatric mental health crisis that we're facing, this is another crisis in and of itself, and we need to be able to continue to support our PCPs as they are providing support to our children that are struggling. So what has KS Kids Map done? To date, we have enrolled 164 physicians and clinicians. 98 of these are physicians. We are present in 63 of 105 Kansas counties. Rachel, you want to take over?
Yeah, I can. Yeah, we're present in 64 of 105 Kansas counties. We've had nearly 450 inquiries. We've done 120 interprofessional consultations. Our Tele-Echo Clinic has been running for 2.5 years now, every other week, regularly, and it's something that has, I think, become a real touchstone and a network for many of the participants who find an opportunity to talk about the challenging issues that they're dealing with and to think about it with colleagues. We've provided a number of physician coaching sessions, a wellness retreat, and then some trainings that are focused on suicide prevention, particularly a program called Counseling on Access to Lethal Means, which enables clinicians, physicians and other clinicians to be able to counsel families on what to do with lethal means, with the guns in their families, and with the knives and other lethal weapons that their youth may, if they're feeling really suicidal, be able to access. And this is an evidence-based intervention for suicide prevention. The next slide is what we call our heat map. Kerry, can you move it? There you go.
Yes, there we go.
And
Sorry, I'm back.
Okay, you take it from here.
Okay, so this is our heat map, and this just shows where we have our PCPs and participants enrolled. So as you can see, the darker areas, the red and the yellow, are the highest population of participants that we have. And you can see we have a very wide reach across the state, both in the smallest rural communities as well as the most populous cities. And unfortunately, you know, you would think that some of those more populated urban areas have better access to our child and adolescent psychiatrists and psychologists. But like we said, even those areas really struggle. And we have a pretty high participation rate, both in the Kansas City metro and the Wichita metro areas, as well as in those very small rural counties. So we do need your help. As Dr. Brown said, this is a HRSA-funded program, and our grant is up in July of 2023. And so we are asking for funding to continue the program that we have, to really accelerate the integration of mental health care into primary care pediatrics. So like we said, we currently serve 60% of Kansas counties, and that allows the PCPs in those counties to better integrate mental health care and evidence-based, culturally competent, compassionate mental health care into their own practices, which makes it easier for the kids to access care, and it saves our highly trained experts to manage the more complex cases of pediatric mental illness. We expect to be able to expand the program into additional counties if we are able to continue the program. Dr. Brown?
I think that's about it. We do provide, alongside funding for this program, we are aware that workforce challenges and shortages are longstanding, and that there'll be years to pass before we can implement programs that will train more child and adolescent psychiatrists and other kinds of experts across the state. However, we think that KS Kids Map is using the state's capacity, our limited resources right now, to help our Kansas kids now. And our fundamental intervention is building the capacity of the existing workforce of primary care physicians and other clinicians so that children and families can access high-quality evidence-based mental health care in their own medical homes. And as part of that process, the most highly trained specialists like myself are better able to devote their time to those with more complex needs. We'd be happy to take questions, some references at the end, and thank you so much for the opportunity to talk to you this morning.
Dr. Brown and Dr. Harris, thank you very much for that presentation. It appears that your guys' slide show was different than the one that the committee has. So would you guys mind forwarding that one that you just presented to Connor so Connor can distribute that to the committee so we can have the same slide presentation that you guys have and showed? And then I do have one question for you before we go to other committee questions. Referring to Kyle, down in the paragraph to the side of the picture of the little boy, it says that unfortunately Kyle does not have access to an autism specialist in this area, and Dr. Smith is not comfortable making that diagnosis. So my question is, why would a doctor be hesitant of making a diagnosis, an accurate diagnosis, even though there's not a specialist in that area?
I'm going to let Kate, do you want to speak to that, Dr. Harris?
I can start and then you can finish. So this is a great example of, recognizing what the limits of your scope are. And pediatricians, family physicians do not want to label a child with an inaccurate diagnosis. And so this is where we would use collaboration and we would get in touch with one of our colleagues that has had extensive training in autism to try to make that diagnosis. Dr. Brown is certainly the best one to talk about because she is part of a whole nother similar program to ks.gov map that is focused on autism diagnosis. But this is not atypical at all for a primary care physician to be reaching out to a specialist to make that diagnosis.
Yeah, one of the things that has happened in my professional lifetime over the last probably 40 years or so since I saw my very first child with autism spectrum disorder as a young resident in London is that the diagnosis has become much more frequent. And that has meant in a lot of parts of the country, including Kansas, that there are wait lists for children to have the extensive evaluations that many of them need in order to get clarification about what the diagnosis, whether or not the diagnosis is present. There are children for whom the autism diagnosis is very straightforward, where any experienced clinician, including any experienced primary care physician, would be fairly comfortable in saying that child has an autism spectrum disorder. But there are many other kids where, and individuals of all ages, where the diagnosis is actually much more complex and more difficult, and where it needs interprofessional involvement or the involvement of people with more expert training in order to confirm that diagnosis.
Okay, thank you for clarifying that, because when I first read it, it kind of appeared like it was someone didn't want to give that because of maybe they didn't have the right accommodations around, but it's more of they're not a specialist in that. So I appreciate that clarification. Senator Petty.
Thank you, Mr. Chairman, and I appreciate that because I think that it's very important that our children are not labeled when there's someone who doesn't have the expertise to really look at the full scope. I just wanted to clarify, because you talked about the grant that you presently are operating under, and so when you're talking about funding, are you talking about the $500,000, the $533,843? Is that actually the budget that you've been operating under?
Yes. Okay.
So that's
Yes.
kind of that's kind of appropriate. That's the kind of annual appropriation we're talking about.
Yes. Correct.
All right. Thank you.
Senator Gossage.
Thank you, Mr. Chair, and thank you so much for being here and follow up. My question is a follow-up to Senator Petty's, and that is, you said the grant is up in July, is that correct?
2020.
July of 2023.
2023. Any possibility of renewing that grant?
We hope. We
And
have
that,
been told by our HRSA project officer that there may be a competitive renewal process, but that has not been publicized yet or determined. So it's a possibility,
see.
but we don't have an answer to that.
and then, and this is a federal grant, is that right?
It's a federal grant that goes through KDHE and then to us.
Thank you. Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chairman. And sometimes I would just add to that, it's very tricky about grants because sometimes they don't renew them, even though your program is exceptional, because they try to see that other people have opportunities. But I am looking at the part about if he is not properly diagnosed, he could be placed in an alternative kindergarten program. Can you explain what kind of services would he receive or education, I say, in an alternative kindergarten program?
Carrie, you want to speak to that?
So this was a concerning case to our team, specifically for that reason. He was a young child, and the school district was making the recommendation that he not attend mainstream kindergarten, but that he be placed into an alternative program because of behavior concerns. And it was important to us that he received the appropriate diagnosis so that he could be in that mainstream school and be given the best chance. This child also had a sibling that had similar issues as a younger child, and once he was placed into the structured environment of school, got significantly better. And so we anticipated that that could be the case with this child as well, but the district was saying that his behaviors were so significant that they actually did not even want to give him the chance of being in a regular mainstream kindergarten. I don't know, Rachel, if you've got more.
Yeah, no, I would add,
more about that.
one of the things that we see with children with autism spectrum disorders is that because of the challenges that they face in communication, in particularly the use of language, verbal language, to communicate their needs, their frustrations, their emotions, that instead what you will often see, sometimes see, from time to time see, depending on who you're working with, is behaviors that are actually directed at being that way of communication between a child who can't express what they want in language and instead will because that's what we all do, and that's especially what children do, is a behavior that is directed at communication. And so if you say that what you need to do is manage the behavior, you're actually missing the point. Because the point with a child who has autism spectrum disorders or a child who has a significant language delay is actually what you need to work on is alternative means of communication. You need to help that child know how to communicate that child's needs, that child's internal world, that child to develop the social interactions that child needs in order that they no longer need the behaviors that they've previously been utilizing.
Thank you, Mr. Chairman. Thank you very much, both of you, for your explanation on that. Because when I saw alternative, I felt a little uneasy because an alternative says that in so many cases you will receive less than what you really need. And because you'll receive less, they won't be addressing the main issues. And I think you explained that very well, and I thank you for that. And I would really hope that this particular child would not, especially if he had a sibling that showed improvement in that area. But sometimes it's so easy to just put him someplace else so you don't have to deal with it, but that's not always good for that individual. So thank you very much for the explanation.
Yeah, thank you.
Senator Erickson.
Thank you, Mr. Chair, and thank you for this information. Just a quick question on the slide referencing our medical community needs support. I see that that's a National Institute for Healthcare Management. Is that Kansas numbers? Is that, what is the trend there? You know, is that historically about, or have we seen a spike due to COVID? Or can you provide a little bit more context around those statistics?
Sure. Yeah. So those are national numbers. We definitely have seen a spike. We don't have Kansas numbers during the pandemic. Those are the numbers that that reflect the pandemic. It was about 7 months into the pandemic, so kind of at the pandemic high last fall. I would expect those numbers are the same or higher even now, just, you know, anecdotally speaking with healthcare workers.
So hopefully we're leveling out some of the stressors, I'm hoping, over time due to COVID. Would you assume that that's probably the peak, or would you, I'm just trying to get some context around that, because that's pretty alarming, those high of numbers. So I'm just trying to get some context, because this looks like a one point in time national. I'm trying to wrap my arms around trend data and specifically around Kansas. So thank you.
Sure.
Thank you, Mr. Chair.
So I don't know that I can speak. I wish I could say, yes, this was the peak and it should level off and get better. I don't know that we have that information right now. I have not seen, I take that back. There was data that came out this past May that was very similar to these numbers. And again, that was national data. I haven't seen any state specific data on our healthcare workers or how they're doing. We have anecdotal evidence from our KS Kids MAP program, where a large majority of participants that enroll request wellness resources. We have had very good participation in our physician coaching and calm training sessions, as well as very good feedback from the other little wellness resources that we provide for them. So I hear your question. I don't have a good answer for you on it right now. From a trend standpoint, pre-pandemic, these numbers are definitely higher.
I just wanted to add one thing. I thought at the beginning, and I think that we're seeing it as we go forward, is that the COVID pandemic would be followed by a mental health pandemic. And we pay a lot of attention. We've paid a lot of it. There's been a lot of attention, understandably so, and rightly so, for the impact of the coronavirus on our physical health. I think the impact of the coronavirus and all of its accompanying the trauma that's gone with it, the loss and death that has happened in children's families, the disruption of services for including schools for our children, but also services for their parents who need mental health resources. I think all of that disruption continues to have an impact and will most likely continue to have an impact going forward. One of the things that we typically see, those of us who work in inpatient facilities, is we see dips in numbers of admissions for adolescents who are experiencing depression and suicide and other mental health crises at certain times of the year. This year, we did not see those dips. Instead, what we saw was an ongoing need throughout the usual quiet times of the year, which often include the kind of more historically and traditionally summer vacation times, where our inpatient resources are less in need, and we haven't seen that this year. So I think that the mental health pandemic is continuing, actually, and I don't see that, at least anecdotally, and from my stance as a clinician, I don't see that the pressure for that becoming less as time goes forward. I think that it's a wave that's still to come.
Dr. Brown and Dr. Harris, thank you for your presentation. I see no further questions, so we will move on to our next item on the agenda. We will now hear responses from state agencies and MCOs on unresolved topics. And before we get into the presenters, Connor has a couple of things he would like to discuss with the committee.
Thank you, Mr. Chair. This is Connor Stangler, Kansas Legislative Research Department. Members of the committee, you have these two documents in your folder. I just wanted to point them out and give a bit of an explanation and background because this spreadsheet is not the easiest. This is the large spreadsheet. The one confusing thing, the only confusing thing on this spreadsheet, I'm sure, is that the first few pages, specifically pages 1 through 7, refer to what are called specific issues. That was established at the beginning when this spreadsheet was originally composed. And then you'll notice that right after page 7, the pages restart at page 1. And I know that's a little confusing, but for the first two conferees from KDADS and KDHE, they will be starting on the second page 1, where the yellow bars start. As you go through, you'll see there's sort of a yellow highlighted column there, and that goes on and on and on to page, about 43 or 44. So for the first two conferees, we will be discussing those issues. And you'll see on the left, the conferees will reference the issue number. So you'll see in the left-hand column, there's issue 1. Issue 1 might go on for a couple pages. They might jump to issue 8, issue 9, et cetera, et cetera. So I just wanted to clear that up. The third conferee will be Carrie Kimes from United, and she will refer to the first few pages, which only have, I believe, 2 issues. So I just wanted to clear that up. I also wanted to remind the committee that last time at the September meeting, the committee did approve removal of 6 issues. So we did remove 6 issues last time. The issues were then renumbered. So if you happen to have last meeting's spreadsheet and you're thinking, well, where's issue 19? And you're trying to find it, it's not going to be a perfect match. They've been renumbered just to avoid confusion on that. But KLRD does keep historical versions of the spreadsheet. So if you want to see an issue that was removed last time, just feel free to contact me and I can get you that issue. And the second thing is just a legend of abbreviations, which comes in handy sometimes. And if there's an abbreviation on there that I left off, please let me know. So that's just an explanation, Mr. Chair.
Connor, thank you. Committee, do we have any questions for Connor on that? Okay. Connor, you did a great job explaining, so thank you. Committee, first up, we have Sarah Fertig, KDHE. Sarah, welcome to the committee.
Thank you, Mr. Chairman. Good morning, committee. So KDHE does not have a huge number of issues on this log, so we are going to start with number 4 of the general issues resolution log. And this pertains to some input we received from Mike Oxford indicating that there's a need for community service coordination for KanCare beneficiaries. We don't really have any update for the committee here, but this is one of the topics that we're going to be discussing as part of KanCare 3.0. So we've already had some conversations with stakeholders about that, and those conversations will be ongoing, but no major update on there. The next item for KDHE's response is item number 20. We have to flip through several pages. And this item was some input received from K4AD requesting that if Medicaid expansion passes, that certain kind of program design criteria be considered. We don't have any further update on that, obviously, because that pertains to a theoretical Medicaid expansion bill passing. So no update there. And then the next item for KDHE's response is number 24, a few pages further. So item number 24 concerns some testimony received from Tanya Dorf-Brunner of Oral Health Kansas. She indicated that when there was a Medicaid dental rate reimbursement funding passed a couple years ago, there was a particular rate that Oral Health Kansas thought should have been included in that rate increase. I'm pleased to report that we were able to do a rate increase for that particular code. It goes into effect in January. And the fiscal impact on that was so minor that we were able to do that with existing resources. So, Mr. Chairman, I would respectfully suggest that we strike that portion of the item.
Committee, without any objections, we will strike item number 24 from the list. Okay, not seeing any objections, so moved.
Mr. Chairman, I would clarify, though, that there's kind of a second portion of item number 24 requesting that teledentistry be authorized in Kansas. I think that might be a licensing board issue, kind of beyond the powers of KDHE, so that might be an item for the legislature, actually. That might require a statutory change.
So we'll clarify that since we have an objection from Medicaid not to strike all of it. So appreciate that, Sarah. So we will back up and just strike the part that pertains to the Medicaid and reimbursement rate.
Thank you, Mr. Chairman. So the next item for KDHE's response is right below that, item number 25. And this is a longstanding request from the CMHCs for Medicaid to start covering code number 90846, which is family therapy without the patient present. It should tell you something that that's one of the few codes I have memorized. That's how often I've spoken with Kyle Kessler about this. I'm also pleased to report that KDHE and KDADS agree. We need to open that code. KDADS is in the process of putting together a policy for Medicaid to cover that code. Once that policy is put together, KDHE will work with CMS to get that approved in our Medicaid state plan. So this is in process. It's not done yet, but we're moving forward. The next item for KDHE's response is number 27 on the following page. So this was some input received back in February of 2021. There were concerns that once the CVS and Walgreens COVID-19 vaccination program ended, there were concerns that adult care homes still needed to receive priority access to COVID-19 vaccinations. As we all know, we're in a very different phase now where anyone who wants a vaccine can get it. So we don't have any further update on here. And Mr. Chairman, I would suggest that perhaps we close this item because it's the issues giving rise to this particular testimony have long since passed. But I would defer to the committee's judgment on that.
Representative Ballard.
Clarification. Can I have that number again? Did you say 26?
27, Representative Ballard, yes.
Thank you, Mr. Chairman.
Committee, if there are no objections, we will strike number 27 in its entirety off of the list.
That's phenomenal, Mr. Chairman.
Not seeing any, so moved.
Okay, so the next one for KDHE to respond to, this is one of the new ones coming out. Sorry, it's not one of the new ones. I'm looking at item number 33, a couple pages further. So this item has a couple of moving parts in it. One of the items asked for the protected income level for HCBS and PACE to be increased to 300%. You all did that in the last session, and KDHE implemented that effective July 1. So that particular part, I would suggest perhaps be stricken. The only caveat there is that if, the legislature wanted to make that permanent and put it in statute, obviously that's something you all would have to do. We would not be able to do that. There were a couple other moving parts to this item talking about what the state should do with the American Rescue Plan Act HCBS FMAP increase. And the suggestions relate to direct support workers and adult care homes. And so, not to assign more work to my colleagues at KDADS, but I think they're probably the better agency to respond to that particular item going forward. As KDHEs, we've done everything we can at this point by implementing the protected income level increase.
Okay, committee, without any objections, we will strike the first paragraph and then change the state agency to follow up to KDADS on the remaining two. Not seeing any objections, so moved.
Thank you, Mr. Chairman. So the last item for KDHE's response is item number 36. And as you may recall from the September Bethell, Sean Sullivan of Midland Care gave a presentation on PACE. And one of the issues that he pointed out that faces the PACE program is that there are federal rules in place that prohibit folks from enrolling in PACE in the middle of the month. It's something that kind of drives us crazy on the state side as well. So Mr. Sullivan proposed that perhaps the state could create a mechanism so that we could sort of enroll PACE members in the middle of the month, pending their full enrollment the following month. Basically a workaround around the federal rule that prevents us from enrolling them mid-month. So KDHE, we dug into this a little bit. Our initial estimate that we got from our IT systems is that it would cost about $2.5 million to accomplish this, which I know sounds like an unbelievable sum, but anytime you do anything with our eligibility system or our claims system, you so much as glance at it and it's $1 million, it seems. So exceedingly expensive. We did ask them to go back and double check those numbers. They've dropped the fiscal estimate to about $500,000 to $700,000 to do that systems work. It's still pretty expensive because we also dug into what our PACE enrollment looks like. And on any given month, we've got about 19 new enrollees into the PACE program. Of those, 1 or 2 are not already on Medicaid. They're coming into the PACE program completely new from outside the Medicaid system. So what we would be doing, in effect, would be spending $500,000 to $700,000 on system work to allow 1 to 2 folks per month up to 30 days of pre-PACE Medicaid coverage before they're fully enrolled in PACE. So on further review, we're not sure that that's a tremendously cost-effective approach, and we really think the better solution is a change at the federal level to allow PACE participants to enroll in mid-month. That is something we would support. So that's our response on that. Based on the actual impact to new PACE enrollees, it would affect a very small number of folks for about $500,000 to $700,000 in programming. And Mr. Chairman, that concludes all the items that I was set to respond to. I'd be happy to stand for questions if the committee likes.
Sarah, thank you very much for that. On item number 36, that's awfully expensive for the benefit. Is this something that we should keep on there and look at different avenues, or have we hit a dead end and we're just need something from the federal?
Mr. Chairman, I would defer to the committee on that. If the committee wants the state agencies to continue to look at options, we certainly can, but this is kind of the best and final offer we have based on the realities of our complex IT systems and the number of folks we have coming into PACE every month. It's probably not going to get better than that, cost-wise.
Representative Landwehr.
Yeah, I think, Mr. Chairman, at this point here, with the news that we've been given and the numbers we're looking at, is that we consider this done until it's brought back again and maybe has a better outcome brought to us before we were to put it back on. That would be my recommendation.
So we do have a recommendation by Representative Landwehr, a second by Senator Gossage to go ahead and remove item number 36 unless it is brought back up in the future. Any discussion on this motion before we take it to a vote? Seeing none, all those in favor say aye. Aye. All those opposed, no. The ayes have it. That motion is moved. Do we have any further questions for Sarah? Okay, not seeing any. Oops. Senator Gossage.
Just real quick, Sarah, I know that you addressed certain ones that were on here. Will we be hearing from Sean Sullivan regarding number 37, or will that be addressed as far as expanding PACE services into Johnson County?
Mr. Chairman, I believe item number 37 was assigned to KDAD, so Janice DeBoer will be following me, and I believe she will be addressing that one.
Thank you.
All right. Sarah, do you see any further questions? Because I do not. So without any further questions, thank you very much.
Thank you.
Committee, next we'll hear from Janice DeBoer, KDADS, and our understanding from yesterday is this will be our one and only time left with Janice to come before this committee. So,
yes.
Janice, congratulations on your retirement.
Thank you. Janice DeBoer with KDADS. It has been 30 years. It is time for me to move on. So I worked in the private sector. I've worked in the public sector. It's been a great career. I'm done. So thank you all for this opportunity. You know, before I dive into these items, I do want to say a couple of things. Just thank you for shifting the order of this so that the sessions log comes after yesterday's presentation. So hopefully some of the questions from this issues log you heard yesterday. Bear with me, it's not COVID, it's just a bad lung. So I also want to thank Lee CAC Lee is going to help us try to do a better job of just tracking all these issues and connecting with our staff, and then writing the words on this particular log in addition to completing the slide deck. So bear with us as we attempt to meet your expectations, maybe a little bit better as far as what we're putting in writing. My third comment, though, and I also want to thank Connor. Connor's been fabulous to work with on this issues log. So it really isn't COVID. It really isn't. I do also want to say to you that it has been a good 30 years. These last 3 years have been the toughest 3 years I've ever worked in state government. So I've never been busier. I've never worked harder, to be honest with you. It has been tough. And the team at KDADS, from my vantage point, are some of the best people I've had the pleasure of working with and for, and have enjoyed that. And I'd like to thank Scott Bruner for joining KDADS, to be honest with you. Scott joined us a couple of years ago, and Scott came on board, and COVID came. So thank goodness you. Thanks, Rose. It really is a COVID.
Janice, I do have to warn you that Representative Landwehr has a bad habit of giving faulty cups to our
As long as it's not poisoned, I think I'll be okay. But so anyway, I do want to say to you all as we begin this transaction, that going through this list, that I do thank Amy Penrod, and I do thank Andy for the good work that they do, and thank Scott and thank for the team. I do think it's one of the best group of people I've ever worked with. So with that said, here we go. Okay. Item number 1 actually starts on the new page 1. Thanks, Connor, for that. And this is all about the IDD waiting list. I feel from my vantage point, if you move on to then page 3, because it continues all the way onto page 3 as far as the IDD wait list, I do think that the work that was done during the 2-day interim committee was very helpful. The idea of having a modernization committee, if you will, to really study the IDD waiting list and what does it mean in Kansas, I think will prove to be very helpful, just as the group has proven to be helpful for mental health. So our response to that is we have developed an RFP, and it's in the final stages to actually study the IDD and the PD waiting list. Representative Concannon, during the Kansas Senior Care Task Force, you asked, what's the difference on this study than what maybe we already know? And the difference really will be that we will reach out to the individuals and the family members on the waiting list and say, what do you need? So just pleased that we have the opportunity, thanks to the 10% FMAP monies that are coming our way, to use some of those dollars to research the IDD and the PD waiting list more than we have in years past. So we can continue to provide an update on that as the months progress. Item number 2 was from Cindy Luxem several years ago, and it has to do with funding nursing facilities. There is a statute in place that requires KDADS within the appropriation from the legislature to use 3 years of cost report data as we calculate our cost reports. We do that as a general rule based on your appropriation that you give us. So for the current rate setting period that we're in now, we did capture 17, 18, and 19. That was a change from the year before, which was 16, 17, and 18 to calculate the current inflation adjusted rates. The current rates fall within the appropriation that you provide us. What typically happens is we meet with the nursing facility trade associations with several different options as far as what their preference is on which years we actually use and how much inflation do we include that falls within the appropriation you provide us. So whatever amount of appropriation you give the agency, we use 3 years of cost report, the most up-to-date we can, plus inflation. Item number 3 is continued to page oh goodness, I think it goes all the way over to, no, on page 4. Item number 3 stops on page 4, and this is antipsychotic drugs. And Scott has been providing you with data on antipsychotics in nursing facilities in the slide deck. In addition, just FYI, this is a topic that will be covered in the Kansas Senior Care Task Force Committee also.
Janice, can we pause just for a second? We want to go back, rewind to number 2, and Representative Concanon has a question.
Sure.
I just was wondering if that's one that we could take off the list. Number 2.
Yes, it would certainly get my vote.
Okay. Without objection, we will strike number 2 from the list. Yeah, there's just one part of 2.
It's the ones with the yellow. I think you might be on the green. And
Yeah.
I'm just bringing up as a question. If there's been a resolution, it's just dependent on the appropriations every year.
Right. I mean, every year we set nursing facility rates, and we use the 3 years of cost report data. That's what we look at. We do several pro formas, whether we use 17, 18, and 19, 18, 19, and 20. We run reports on 3 years worth of data. And then if we can include inflation, we include inflation based on the appropriation that you give us. That's the way the process works.
And that's what, when she brought that up, that if it's based on appropriations, I don't see a reason for it to stay on our list.
Representative Carpenter.
Well, it's not quite that simple. I'm not sure when the last time. I think this last year was the first time that we funded it as it needed to be. The governor's budget the last several years has only been a 1% increase. And part of the problem is it's also the way the study is done. And the results have come out, and correct me if I'm wrong here, Janice, but the results come out after the legislative session in May. So we really don't have accurate numbers for those 3 years. Is that right?
Well,
it comes out in May, and this year it came out in May. So we did a 3-year deal on what, 17, 18, and 19?
17,
well,
18.
Here we are, 21. So last year it would have been 20. So we're years behind on the actual costs of that, and that's what it's for. It's for the nursing homes to actually establish the cost that it costs them to house folks. So it needs some work. It really does. But the big thing is it has no teeth. Again, you can look back in history. I venture to say that there aren't very many times that it's fully funded at the 3%.
If I may just add to that, Mr. Chairman, the nursing facility program in Kansas is a prospective payment system. It's been that way for, I bet, represent 30 years. It's been 30 years I've been here. It's a prospective payment system. It's not a retroactive system. We don't ask for costs to be submitted and then calculate a claim and then settle up. That's not the way Kansas operates. Its nursing facility program, it never has. What happens instead is we ask nursing facilities to submit cost reports every single year. They're due to us February 28th. By the time we do all of our auditing of those reported costs on February 28th, it is the middle of May before those final rates are ready to load into our system for July 1. But in the meantime, we have a pretty good sense after February 28th. We can ask our contractor to give us a sense, give us a feel of how the cost came in this year. We can then do all sorts of pro formas to say, based on these costs and the 2 years prior, here's a pretty good idea of what cost coverage is going to be with these rates based on an appropriation that you give us. So then as soon as we have a pretty good feel of what that appropriation might be, what's in the governor's budget, and then what you all are asking us, we can get a pretty good sense of what pro forma might work best to get us as much cost coverage as we possibly can in a prospective payment system. And we've done this for 30 years. So for 30 years, we get the costs in, we do some, it's not quick, it's a lot of work by our contractor, give us some estimates, we meet with the industry, and we say to them, based on the reported costs, and we've looked 2 years back, then we trend forward for inflation, this is what we estimate we will pay in the way of rates to get you down the road with a prospective payment system. A prospective payment system includes inflation, which means the idea is we'll pay you enough to get you down the road until that next cycle starts again and again and again. So it is a prospective payment system. It is intended to assist. Now, no one could have ever predicted COVID. So COVID has been more than difficult in a system where you use inflation to project. But what you've done is you've given us extra money. You've given us money outside of the appropriation, if you will, the rate-setting appropriation, to give more money to the industry, and that's what we've done. Last year, you gave $15 a day, I believe it was. That translated into an additional $50 million. So on top of the $717 million that you appropriated for the industry and the rate setting, you gave us an additional $50 million that we could pass through to help cover costs that were unexpected. But keep in mind that the system is prospective. We do give inflation. We don't settle up. So if that helps, I hope that helps.
That helps, but still, how much inflation do you give? I mean, we're looking at 6% nationally now, so they're going to be behind the game, you know.
Yeah,
and
right.
You're probably giving them 3, and they're operating at 6.
Right.
So all I'm saying is it's not a perfect system,
Yeah.
and it needs work. Thank you.
Representative Landwehr.
Thank you, Mr. Chairman. You know, I think part of it goes back to, it's not just the inflation piece, but it's the 3-year rebasing that we have struggled with for the last several years when we found out it wasn't happening on a regular basis because apparently it became 7 years in rules and regs, but that was never the intent. And actually the person that came up with that and started it, and Representative Ballard will remember that, was the very person that this committee is named after, and that was Bob Bethell. And so I think we're still not to a fully funding. If we go back to looking at that, I think we're still backdooring a little bit coming into these rates. So I think maybe the wording needs to be changed on here a little bit, and perhaps we can explain what you're talking about. Let's explain this rebasing, because I don't even see the word rebasing on here anywhere. And if you haven't been through that process, you don't understand what that is. So I think we just need to kind of reword it and update it. We're not saying you've done anything wrong with it, just, you know, change our wording so we talk about the rebasing, we talk about the inflation, and that, yes, your language here that says the current rates fall within the appropriation funded, that's a lot different than saying this is fully funded under what the legislature's intent was, which was the 3-year rebasing plus inflation. So that's not saying you did it wrong. No.
Right.
That's
right.
not what we're
saying. I mean,
saying.
we can't spend more money than you all give us.
Right,
So,
but
yeah.
but I think we need to be clear,
Right.
you know, Representative Carpenter, and perhaps you can help Connor with that language, because your committee is going to be dealing with this. What does that need to say so that future committee members will understand why this is still on the list?
I don't disagree. I think that also the process is, though, most of the time, this year especially, we were through the appropriation process by the time we got the report. If we wouldn't have given the extra $50 million in the $15 a day, we would have not, you wouldn't have had the 3% or anything. So in a normal year without COVID and without all this other stuff, quite frankly, we would have been behind the game. So anyway. Thank you.
Representative Concanon.
Thank you, Mr. Chairman. I still go back to the fact that this has been resolved for now, and this list is for specific issues, that maybe it would be a good idea to move this onto our regular reports that we get from KDADs and just have a regular update on this issue rather than leaving it on a list of specific issues that we need to take care of. It doesn't matter to me either way. It just seems like getting a regular report on it would make more sense than it being in a list of a specific issue.
Representative Carpenter.
Yeah, I don't have a problem with that. Our committee will be on this first thing this year. There's, 3-4 members on there. So this is on our radar screen for this year for sure.
Representative Landwehr.
Thank you. I guess as the person that will be chairing this committee next year, I like the idea of it staying on this list here, just kind of updating the wording on it so that this committee stays up on top of it, not just the budget committees within the House and the Senate.
Representative Concanon.
Thank you. And if that's the way, as chair, if that's the way you went, but what I was proposing was that it would be to this committee. The list that we have in the agenda of all of the issues that they cover, to have that one specified. But however you want it, that's fine with me. If you as the chair would like to see it on this list, that's fine. It makes more sense to me for it to be in their quarterly report to us. But however you want is fine.
Well, and I agree it should be in their quarterly report, but it's not always there. And that's why I think that this is important. And it's important for us to, what I have loved about this worksheet is it doesn't let us drop any issues that have been brought before us. And this is not resolved, in my opinion, or I think Chairman Carpenter's opinion. It's better than it was, but it's not totally resolved yet.
Representative Ballard.
Thank you, Mr. Chairman. I would agree with that. When we got this list, I think it was a happy day because that way we could see the progress that was being made, and they were all in one place. And I think part of it is keeping it on the list so that it doesn't get overlooked. I know that sounds really weird, but when we get so many items like that, it's not given the attention that it really needs. So for that reason, I would prefer that it was in. I understand that it looks like it's resolved. It looks that way. And if I looked at it, I'd say, well, gee, there's no need. But when I think about the people that proposed it and the problems we have had, and as you heard the chairman say, if we had not come up with that additional money, I'll just say we would have been in hot water. I could use a stronger word, but we would have been in hot water. And I just think we need to keep it just to make sure that we know it is a priority. Thank you, Mr. Chairman.
Okay, I do not see any further discussion on this, and I think just by reading the room that we're going to go ahead and leave this on here and no need to take it to a vote. So, Janice, you can go ahead and continue.
Okay. Let's see. I think the next item is number 5 on page 6. I'll try to say this again, that as best I can on the issue, which is the conferee's perspective that SED folks should transition right over to the IDD waiver. The SED waiver is being renewed. I think I said that right. So it's a good opportunity to get comments from this conferee as far as her perspective. Again, currently, the IDD waiver does not allow individuals to bypass the waiting list when transitioning. We've said that a couple of times now. The reason, again, is because the waiting list is so long on the IDD. So what we are hopeful is that during the modernization of the IDD waiting list, that this topic can be included in that discussion with you all and with stakeholders and with KDADs and see where we land on whether indeed this is a policy direction that the SED children should automatically bypass the waiting list and get right on services for the IDD. I think now is the perfect time to have the conversation as the SED waiver is being renewed and the IDD waiting list is being further reviewed also. Certainly, if you direct us to change the waiver, we will. We did want to note that individuals qualifying for both SED and IDD waiver services can be placed on the IDD wait list. So while receiving SED, I think we mentioned that last time also. So we attempted this response to say more than we've maybe said in the past, and we probably could say even more. If you want us to write more, we will. But I think more importantly, it's the direction that the stakeholders want us to go and the direction that the legislature wants us to go. If you direct us to allow SED kids to just get at the front of the line with the IDD system, that's obviously what we'll do. So I think during the conversations about the IDD waiting list, this would be the time to mention the SED. I'll also share with you, I think it will be the time to talk about autism. So we also know we've got some autism issues, to say the least. And when you have the modernization committee, I think that would be also the time to talk about the autism challenges as far as our system design right now and what's available.
Representative Landwehr.
Yeah, Janice, I appreciate this explanation. I think this clarifies, for us to understand better what's going on. So is a child then able to stay on the SED if they're on the IDD waiting list?
I think the answer to that is yes, but let me check with Amy. Yep, that's what I thought. Yes, so you can be, a child can be receiving SED services and already have been placed on the waiting list. But when the SED services then wrap up, they're not long-term. They're not generally long-term on the SED. That child then just doesn't automatically transition onto the IDD services and avoid the waiting list for the other 4,000 families who are waiting. So that's what we've been trying to say. Maybe we said it better this time, but the tough conversation is, does that SED child, should they just automatically transition right into the IDD waiting list when other families are waiting when the SED services wrap up? That's the question. And I think it will be helpful, Representative Landwehr, to have that bigger conversation with stakeholders, a lot of stakeholders who, will say, no, don't do that. So, this will be a tough conversation to have, but I think it'll be a good one to have during the modernization committee from the IDD community. And autism, please. We need conversations about that.
So I would think with this explanation here, Mr. Chairman, we could actually remove that, and then we can put into our report that we think this should be discussed in more detail as Janice recommended for the whatever the new committee is called, or going to be called.
Yeah.
So there are actually two sections for this item 5. So you're just referencing the KDADs. No.
Yes.
I'm sorry. No, there is only one. I apologize.
Okay. I thought.
The one above that's number 4. So I misread that. This misspoke. So
There's a lot of things to look at on this chart.
boy, there is. It keeps you hopping. So if without any objection, we will strike number 5 from the list. Okay, seeing none, we will strike that, and that is passed.
Okay, item number 6. This is about the behavioral health services and the IDD and evidence-based practices with dual diagnosis from Nick. And I'll be honest with you, is this even mobile crisis also? Did we have mobile crisis? I mean, we just couldn't agree more with this conferee. What has happened is, as a result of the mobile crisis system being built for kids, which DCF, I'm sure you have heard, they've successfully launched the mobile crisis system for kids. Commissioner Andy Brown is working hard to launch a mobile crisis for adults. So I mean, our perspective is, yes, we want to do the same for the IDD community. There's a lot of work to be done in the area of mobile response for IDD, the IDD community in general. We are working closely, we believe, with Nick and Matt and others to ensure that as we build the IDD system for kids and adults with mental illness, that we not forget the IDD community, but we also know that the IDD community needs some additional resources and some additional training to those first responders, and we're going to have to build a system that supports not only the mental health community, but the CDDO and the IDD community. So what we are proposing, based on our commitment to this project and to this system enhancement, is we want to use some of the FMAP money. Oh, it is freezing in here. Is it just me? Is it freezing in here? Holy moly. I don't know where the vent is, but it's cold. Oh, golly. Oh, we would like for, whew.
I didn't change it.
Geez, and I don't get cold easily at all. It is cold in here. That's what I'm looking at you thinking, oh my gosh, you want my sweater?
Was it a cold wave that moved through here?
Holy moly.
Straight line winds? Whew. I haven't touched it. I admit, Barbara will tell you, I do confess,
Holy moly. I would share my sweater if I could, but I think I would freeze you. Whew. Whew. Easy. Holy. Oh. Anyway, I'm sorry. Representative Landwehr. What we would like to do as part of our 10% FMAP enhancement project is make this happen. Figure out a way to make this happen. We don't have the appropriation to build a mobile crisis system. We'll have to look to you all for that. But what we want to do is know what to ask. Know how much to ask for this enhancement for a mobile crisis system that will target the IDD community. We need it. We know we need it. We just don't know how much to ask for quite yet. But we're hoping with part of this FMAP money, we can better figure that out. We can replicate what some other states have done, complement what we're already building in the mental health world, and then hopefully bring in some specific training and resources to help build an IDD mobile crisis system for dual eligibles. Yes.
Yeah, Janet, one thing on that is in the 988 legislation is we're including mobile crisis units for the IDD along with the behavioral health side of it. So I think that if, everyone focuses in that area, then we can alleviate maybe some of the cost issues we're going to face.
Good. We appreciate that. And I know that Andy Brown, we talk to Andy all the time, make sure he knows, don't forget the IDD community, and he won't let us do that.
No, we don't let him forget it.
Yeah. And actually issue number 7 on page 9 is very specific to the mobile crisis system for the IDD community and autism, to be honest with you. You are going to be receiving a report. Well, before I digress, let me go to page 10. Our response is that we do hope to use part of the FMAP money so we know how better to build the IDD system. But I will also share with you, while I've got the chance, Secretary Howard asked us a few months ago to launch an autism task team. KHI is helping us facilitate that with our stakeholders and family members to help us gain a better understanding of our autism system and what we need to do to strengthen it. So I will share with you every chance I get. Please keep autism in mind as you meet as a group, because we also need to better support families out there with kids who are on the autism spectrum, as we heard today. The mobile crisis will very much focus on the IDD community and the autism community, and we hope that that stays at the forefront, in addition to the dual diagnosis IDD kids.
Connor, I'm wondering if we couldn't combine and condense items 6 and 7, and then that, put the, keeping the emphasis on the 988 and the crisis as well as the autism piece and get that drop one off. Sound good? Any objection? No, Ray Reese has a question.
Representative Reese, was that an objection or?
No question.
Go ahead.
On that number 7 on page, no, I'm looking at the wrong, I'm sorry. On number 6, I was late. And you're looking at, evidence-based practices from other states, and there's some training, and especially if you're going to look at training for like law enforcement. Law enforcement is supposed to be receiving mental health first aid already. There is a supplement to that for intellectual disability and autism.
Okay. I'm sure Andy and Amy know that, but they're both here,
Yeah,
so,
just-
yep.
Yeah,
Okay.
just to make sure, because that's readily available through the state to get mental health first aid, but then we just have to add.
Okay.
Yeah.
Okay.
Thank you, Mr. Chair.
Okay. Item number 8, which is on page 11. Again, this even gets more complicated for the IDD community, and those are for those individuals accused of a crime, discharged from a state psychiatric hospital following a civil commitment. This one, again, we believe very much that there is an issue, there is a gap, and we need to figure out how to fill it. We have asked for some help in that area when it comes to bringing in some facilitators to help us from the law enforcement and the hospital side and the IDD community and tell us how best to fill in the gap. There's a process called the Sequential Intercept model. You're hearing it more and more. It's being used in Sedgwick County right now at the CDDO to help us better identify, where are the gaps? How do we fix them? We will closely work with Nick and Matt and the IDD community, the CDDOs, to figure out, what is the gap. Again, Amy included this as part of her 12 projects with the 10% FMAP to just give us the resources that we need. Bringing in facilitators using the Sequential Intercept model is not cheap. So we just are going to use part of the project money to bring in some facilitators to help make this happen, in addition to coordinating with Dee in Wichita. Dee's moving forward without us, I think, and that's okay too, because then we can follow her lead on what's working and what isn't when it comes to this particular gap in our delivery system. It is something we also agree needs to be fixed. We just don't yet have the fix. Okay, issue number 9. Issue number 9, this was the Olmsted Plan discussion. Kansas does not have an official Olmsted Plan. Bless your heart. Kansas does not have an official Olmsted Plan. We don't know how to respond to that differently than to say Kansas doesn't have an official Olmsted Plan. So I don't know if this is one of the items you'd like to remove, or if you want to stay, keep it on there. It's up to you.
Representative Landwehr.
Thank you, Mr. Chairman. I would have to say, I do think that we can make this go away, because nobody's been able to go back through the history and figure out when the Olmsted stuff came down, Kansas did it a little bit different. And I want to say it was Gary Daniels that was secretary at the time.
Might have been Janet Shalansky. I think it was Janet Shalansky, but right on, on the heels of Gary.
Somewhere in there. And so we're supposed to be operating under like we do with Olmsted, but we don't have, quote, it's not named Olmsted, and no one can tell us what the name of that is. So maybe at some time in the future, we'll figure that all out.
Well, and Representative Landwehr, we actually brought in Mary Ellen Wright. Do you remember Mary Ellen Wright from all those years ago working in Katy? And she did go back and grab the history for us and write a nice report that captured it all. Okay. And you're absolutely right. We didn't call the report an Olmsted Plan, and we don't have an official Olmsted Plan. We do not. but we did a lot of work at the time. We did a lot of rebalancing at the time, and we did a lot of, requesting grants. So at that point in time, we'd be happy to share that report with Irene and Connor, so at least it could be on the books. I think we've done that, but we could do it again. Make sure you get a copy of what we call the Mary Ellen Wright report on Olmsted.
Yeah, I think that would be good, because I think the whole thing around Olmsted, and correct me if I'm wrong, Janice, was the money to follow the person.
Right.
And there's those within the service industry and even some of us legislators that are not convinced that the money is always following the person. And that goes back as we started shutting down state hospitals. We made that commitment.
Yeah.
But we've fallen short in a whole lot of areas, not just in the senior side. So
Yeah. Yeah,
I would say we could take that off, Mr. Chairman.
Without objection, we will strike number 9 from our list. Not seeing any objections. That is so moved.
Item number 10 on page 13. There's a need for some kind of small caseload person-centered support system that is tied to and has deep history with local communities to realize the goals of person-centered philosophy. This came from Amy Heighton at TILREC. Our response to that is we agree. Person-centered choice and supports are critical components of HCBS. We could not agree more. That's our mantra. That's what we do for HCBS. Our perspective on this one is this will be a conversation that the stakeholders need to have as we revisit KanCare and move to version 3.0. This will be the conversations that stakeholders will need to have with Sarah, with us, with you all, as far as what does KanCare version 3.0 hold for Kansas. The philosophy of person-centered planning and caregiving is becoming more and more the expectation and the norm in HCBS, but it still has to be talked about. It has to be very deliberate and very intentional for it to happen. So from our vantage point, we agree. I mean, we agree with the conferee completely. It's just at this juncture, what we need to do is then when we have conversations about KanCare, make sure that person-centered planning is part of the conversation. So I don't know how much more we can write down on this log about that issue that we agree with and believe in. So,
Representative Landwehr.
Thank you, Mr. Chairman. I would say that now, I mean, we can take and condense this down, but I think it now goes into Sarah's court to keep that on KDHE's radar from a Medicaid perspective because of the 1115 side of it.
Right.
If that's all right. Connor, does that make sense what I said? Okay.
okay.
My
Issue
goodness gracious.
number 11. Issue number 11 goes on for pages and pages. It is the workforce. It is staffing issues. You all heard it. We've all heard it. It's on this issues log. We are doing the best we can. I think it goes to page 16, actually, where we need to support the direct care workers. Scott talked to you yesterday about what we've done in the nursing facility world to try to help with staffing issues as best we can. You've heard it over and over and over from stakeholders, so have we. Our response to this is that the large majority of the money, the 10% FMAP money that we're going to get from CMS is targeted to workforce for HCBS. It's not often we get the opportunity to use some investment money to just get that money out to the direct care workforce for home and community-based services. We are looking forward to it. We are hopeful this is going to happen sooner than later. CMS took much longer to approve our plan than we expected, but we did receive the green light. I don't know if Sarah, did you actually get the letter?
No, not yet.
Not yet, okay. We actually, CMS will be sending Sarah a letter, and I want to thank Sarah. She helped us immensely. As we grew impatient, Amy and I grew impatient week after week, expecting to hear back from CMS in August, and we did it. And Sarah did a nice job of just sending them very kind emails and asking them, where are we on this? Come on, because we knew other states were receiving approval. So Amy did a nice job also. Amy Penrod did a nice job of reaching out to some other folks and saying, hey, what are you getting for approval, states, and got some good feedback. So we think we've got the green light to get this 50+ million out to the HCBS workers. We're going to do everything we can to make it happen fast. That said, we're government, so we have to go through processes to make sure that we get the right vendor we need to help us get the money distributed. It's not an issue of distributing the money per se. The work is tracking all the employees of our employers who will receive these dollars and being ready to report those to the feds because it is ARPA money. So, and yes, Representative Carpenter, we do intend to give all this money to the direct service workers. We think we're going to have some pretty clear guardrails to our employers, to the HCBS employers, and say, this is who the money needs to go to. These are the employees we want to benefit from this money. We've heard from, I'll just say a couple of, I'll say states, that there's called eligibility creep, that all of a sudden, these employers and providers might be saying, well, can we include this employee? Well, can we include this employee? Well, how about we include this employee? Just to get bonuses other than just direct service workers. And we're going to try to do our best to say, no, this money needs to go to the direct hands-on care workers who are making $10 an hour. That's who these bonuses are intended for. We're not going to say who are making $10 an hour, but we are going to say, no, please give this bonus money to your employees. You're doing the hands-on care, frontline workers who need some additional support. That's the intent of our project, which we hope, well, Amy's already working on it every single day. It's her top priority. So we will obviously keep you posted as we finally get the green light letter. We're moving anyway. We won't, what I mean by that is we're starting to draw down the federal funds. We know a letter is coming. We won't actually get the money out the door until we actually get the letter, and then we've got to get a vendor secured to help us do all that. But that is our plan.
Representative Carpenter.
Thank you. And thank you, Janice, for just to give the committee a background. As I've been, I don't want anybody to be left out. That's all. I mean, every one of our frontline direct support workers are valuable, and we need to keep them. So we've just kind of had this running deal that I've been, as people that are like on the SCD waiver, I want to make sure that everybody that is a direct support worker gets it. So that's kind of what Janice was referring to, is we've had this ongoing question and answer deal of, are they covered, are they covered, are they covered? And so anyway,
yeah,
I'm very comfortable with that, but I just want to make sure we do it right, because somebody's going to scream,
yeah,
you didn't take care of me, you know what I mean, if we don't do it right. So thank you.
And Representative Carpenter, we appreciate the questions because, I mean, we're kind of building this as we're flying it. So we appreciate your questions. It makes sure that we're all on the same page. Yes, we're going to include SED waivers. Yes, they need to be hands-on. No, it's not for the social workers per se. It's not for the nurses. It's for the direct care teams who actually do hands-on, who actually go out and touch people, who actually do the hands-on care. So we appreciate the questions, Representative Carpenter, so keep them coming. On number 12, this is the temporary nurse aides. Scott, I thought, covered it nicely yesterday. And Lacey, that, in fact, I'm not even going to read it. If you all want to read it, it's the temporary nurse aides. You've heard the issue over and over and over, what we can do. So I'll move on, unless you want to talk about it.
Representative Carpenter.
Thank you, Mr. Chair. Now, that was one of my questions.
Oh, sorry.
About that, and I don't think it was cleared up at all.
Oh.
So what guidelines do we use for temporary nurse aides? What requirement?
The temporary nights, the 8 hours for the, I might have to get Scott up
See,
here.
that wasn't clear at all.
Oh,
And is
I
it
thought
still
Scott-
going on? And
No.
Okay.
No.
And what is, I'm wanting to know, and I think the committee also, what we can do to continue that, because we obviously are still in a workforce shortage. And so what is the barrier?
Okay, I'll ask Scott. I thought he talked about it yesterday. In fact, you all are now saying TNAs, which is a new term that I think you've labeled these workers as TNAs. But Scott knows more about what we're going to do with TNAs than I do.
Getting off my ears. Scott Brenner with KDADS. So the authority we had to authorize the temporary aides, I've never said temporary nurse aides because they don't meet that qualification, but the temporary aides ended with the executive order and the emergency declaration in June 16th. As we got close to that date, we tried to transition as many of those temporary aides into certified nurse aide courses and made sure they could use time that they had been working as a temporary aide to count for their practical experience. But our authority to recognize those designations and allow temporary aides to provide care in facilities ended with the executive order and the emergency declaration. So we could restart it with another executive order that the governor could authorize. We'd need to make sure, given the action that the legislature took in the session last year to require approval of any executive order, we need to make sure that was in place as well. So we haven't done that over the intervening almost 6 months because of that not being clear on where the executive order would lie if we requested that from the governor's office.
Representative Carpenter.
Thank you. I guess what I'm looking at is in absence of the executive order, what process do we need to go through? Is it a legislative process? How could we address this without an executive order?
Legislation.
Legislation would be one path. You could create this category of worker and give KDADS or some other agency the authority to authorize it, make sure the training occurs, and then some level of registration. We didn't do a lot of that. We didn't do any of that actually with the executive order. We said these are workers who can work in facilities, but the training was recorded by the facility, and the Healthcare Association had the online training. So you could add more structure to it in statute if you wanted to, but you could do that through statute or I don't know what else you would do besides that. But we don't have independent authority as an agency to authorize a new licensure type or worker type on our own.
Very good. That's what I needed to know. Okay. Thank you.
And I apologize for not answering that yesterday. You wanted us to come back today, and I figured there'd be an opportunity, and this was when it was.
Scott, thank you very much. Senator Petty, you had a question?
Well, my question is, do we need to keep number 12? Isn't that where we're at?
Yep.
That is where we are at, and I believe that we can, if we make put it into the legislature's hands to take care of that, which I think we're going to have recommendations to do. So,
Conversation with the nursing board.
I'd recommend we drop number 12.
So, without any objections, Senator Petty, was that for all three parts? Okay. Without any objections, the entirety of number 12 will be stricken. Not seeing any objections, so we will strike number 12. Representative Landwehr.
Mr. Chairman, then would we start a new one to talk about the new term that we phrased as the TNA, and to explain that, for this to be with the legislature, and the Board of Nursing probably needs to be engaged in this as well. So replace it with a smaller, and put it with the legislature and put it with the Board of Nursing to have that discussion.
Yeah, we could do that. Just as a follow-up to keep the legislature. Senator Petty?
Could we clarify the term? I mean, it seems that temporary aid is the more appropriate term than temporary nurse's aid because of the training that's involved. I think if there is legislation that's brought forward, it certainly would involve all of the medical profession bringing in their expertise for these decisions. But we are talking, I want to just be clarified. We're talking about TA or TNA, and we've kind of thrown around a couple of different acronyms. Which was the appropriate one to be using?
I might need some backup from my reviser friend on semantics, but I think it is kind of semantics. But I do believe whenever I make a recommendation that I'm just going to say TA. So whether it's someone wants to call it a TNA, I'm going to refer to it as a TA. So. And apparently the chair is a lot more funnier than he thought. Scott, would you like to add something to that?
Maybe just so certified nurse aide is the licensure category that we regulate now, and that carries with it particular meaning in the long-term care setting. So a temporary nurse aide would be something new in Kansas. You'd have to figure out or place somewhere where that authority would lie to document, I don't know how much regulation you would want to have, but at least document it to show that that training was complete. Temporary aide would be something that we could, and the way we used it in the executive order was only in a long-term care setting could where a temporary aide could work. CNAs can work in other healthcare settings. They can work in hospitals. They can work other places. You may want to limit the scope by using temporary aid that would only apply to a long-term care or adult care home setting. That was our intention of when we implemented it during the pandemic, was to be a specific workforce for adult care home, long-term care settings.
Representative Landwehr, then Representative Reese.
So then we could keep this issue with KDADs because you have the responsibility on the CNAs, correct? So we wouldn't go to the Board of Nursing.
It would be your choice, but
I think we
would
stay
be
with
more than comfortable I was going to say creating more regulation, which I'm not comfortable doing that. But we could manage the process within KDADs. I think adding the word nurse would involve the Board of Nursing, and you want to talk to them. I think for temporary aides, we could implement a similar program that we did during the executive order in a fairly straightforward way and dedicate them to adult care homes, which I think is the committee's intent.
Right, because when I pulled up the TNAs, temporary nurses aid is a term that's being used out there. It is the 8-hour course.
Yes.
Probably what the executive order was based off of, and I noticed one of our neighbors, Nebraska, happens to be one of them that has it. So it's not as unique as maybe we thought it was, or a made-up term.
It's not, but in the executive order, we did use the word temporary aid only. We didn't use the word nurse.
Representative Reese.
Would this be a stepping stone to going and getting the certification, the CNA? Are we looking at it that way? Or is it going to be truly temporary?
Representative Landwehr.
Thank you. I think it could be something ongoing. And one of the things I like about adding temporary nurses aid is because then, you think about it, because you can be 16 and above to do this work, is you could see this going into our high school. So I can say, instead of, back when I was younger and we had candy stripers, that was kind of a big deal. Well, now you can say, I'm a temporary nurse's aide. And then it, hopefully that sparks some pride in what you're doing and different things. Maybe you want to go into another area of nursing or advance that, or the facility that you're working for may even want to help you take an advance into that, into a course that gets you more into certification or even licensure. So not temporary.
May I respond?
Representative Reese.
I mean, could we just drop the T, the temporary, and just call them nurses' aides? Or is that going to mean we then have to bring in the nursing
I believe then you
association?
have the certified nurse's aide. I would believe it'd be the same thing if you drop the temporary. I don't know.
Back to this here.
Representative Landwehr.
Okay, when I pulled, whatever this site is, and I can get it to staff here, but see, it actually lists, it says, under additional training or other actions may be required in these states, contact your state healthcare association. But Kansas is also listed as having temporary nurses' aides.
All right, we have a question.
Representative Ballard.
Thank you, Mr. Chairman. I believe I asked this question yesterday of the person in terms of, was that class that they took, was it elective or not? And she said anyone could take it, but normally they take the class, but they didn't necessarily go into nursing or anything else. And her comment was, perhaps if they took this class, maybe there should be a requirement in a way that they would go into additional nursing training and everything else, and that's what she was discussing yesterday. But what I took that to mean as, because it's an elective and anyone can take it, and they're not really looking at nursing, and you're not sure you can require that that's what would be a prerequisite in order to do nursing, it would seem to me to put nursing in right now is early, because how do we know when they take it that they're actually going to go into the nursing area? And for that reason, I would be probably favor just the temporary assistant until we know that they're in it, because that's implying they're either going into nursing, that they're a nursing something along those lines. And what we really want was a temporary person because there's a shortage of nurses. Am I correct? So for that reason, I would say temporary, because that's what it is right now, because they have not declared where they're doing it, that this is a training that's going to, but if they wanted to, they could use it. But I think it's more accurate if we just say temporary assistant.
And I believe we've gone down several rabbit holes we probably did not start off going down, so we'll come back to where we were. And I was handed a note by a revisor that had a recommendation that we drop temporary and say limited nurses' aid. And I think that's a wise and good advice. So that's give our kudos to our resident revisor, Eileen Ma, on that one. So, and Scott, thank you. And I don't know if you have any other thing to add, but we do need to kind of get back on track.
I agree, and I apologize, but I did want to clarify for Representative Ruiz. So the way we implemented the temporary aid program, that 8-hour, some of the practical experience could count towards a CNA course if that aide decided to go on and start a temporary, the certified nurse aid program, but there wasn't a direct connection between in the 90 hours of training that's required for certified nurse aid, the 8-hour course that they had to take to become temporary didn't count for any of that 90 hours of training. That may be something that you want to do if you wanted to act on it through statute to say then it is a path. We did not create it as a path because it was temporary for the pandemic. But that I think that was part of your question. I wanted to make sure that was clear.
And Scott, I think just in general conversation around my immediate circle here that we agree with you, so it should be a path. So want to make sure you understand. Yeah, count that 8 hours.
And that's what she was saying yesterday.
Janice, and
Okay.
we've gone off track a little bit, but we're counting on you to get us back on track and get this train a moving.
Page 19, number 13, and I can talk faster. This issue is about the final settings rule, and Leslie Anderson had asked to focus on this when it comes to what the final settings rule means and the personal choice and the quality of life. I think I've said this before. We're proud of what we've done with the final settings rule. It is a compliance issue with the federal government. Kansas has initially had a little bit of difficulty getting this requirement project off the ground, but I do want to thank Commissioner Amy Penrod and her team. They've done a fabulous job. At this point in time, we do think Kansas will be in compliance with this federal regulation. We have included an update to the committee and the agency presentation yesterday. I think Amy did that. I hope she's very proud. She should be. We asked that this item be closed. That said, I would like to say at some point in time, if you want to hear a presentation about the final settings rule, I would suggest you add it to the agenda. It is a compliance issue that basically says to states and to providers, if you want to continue to receive HCBS dollars in your setting, as a home and community-based setting, there are some expectations attached to that, and that includes some personal freedoms, and that includes person-centered care planning, and it truly is a federal requirement that hasn't received, in my opinion, quite the attention that it should have received, because it is compliance. But the fact of the matter is, I do think that the final settings rule will make a difference in the lives of Kansans who receive services in their homes. So if you ever want to hear more about it, ask Amy to make a presentation specific to the final settings rule. Again, we can't thank Amy enough and her team for moving us down the road. It took a couple of years to get it going, and under her leadership, we finally got started and we're in good shape. So if we could remove item number 13, Amy will have a final settings rule report. Well, maybe she's already sent that. Have you already sent it to the feds? Are you going to send it to the feds to get approval, Amy? Yeah. I think she talked about that yesterday in her presentation. So at some point in time, Amy and her team can send Irada and Connor a copy of what we submit to the feds. From my vantage point, this could be removed, but that's up to you all.
Okay. Janice, thank you. And we're going to pause just a second because I got ahead of ourselves. Senator Petty had mentioned removing item 12, I believe.
Oh.
And no, we did not do it. So, sorry, we went down many paths, but not that path. So, yeah. Now we can condense it if you would like, or we could remove it and make the new LNA as a piece. So, if without objection, we will do that with item number 12. Okay, seeing no objections.
And then you remove it, but then replace with the LNA discussion.
Yep. Okay. All right. Sounds good.
Then can we remove item number 13 as suggested?
And then on item number 13, without objection, we will remove that one from the list. Okay. Not seeing any objections, that's removed. Janice.
Item number 14, Mitzi McFatridge brought this up several years ago. It was when we had the facilities were in receivership. It was the Skyline experience. It was traumatic. I'll just share that with you. It was traumatic. We seem to be past this conferee's concern as far as what needs to happen next. You all did act very quickly and gave us more statutory strength, if you will, when it comes to reviewing change of ownership applications, and we feel at this point in time we've got the language we need to better vet owners who want to buy buildings in Kansas. Now, that's not to say we won't have a bad experience again in years to come, but for right now, we've done what we think we can do with your help to give us more authority to ask more financial questions of nursing facilities when they want to buy buildings in our state. So from our vantage point, we appreciate what you've done. We are hopeful. We don't have additional buildings come into the receivership mode. We have, FYI, one building left out of 22 that has not yet sold. It's here in Topeka. We still work with the actual owner of that building and with our broker every Monday at noon. So we still hope to get that building sold at some point in time. But for this particular issue, there's nothing else we need your help on or anything else we can do with regard to receiverships.
Representative Landwehr.
Thank you, Mr. Chairman, and I have to agree, Janice, I think that the process has come a long ways, and with everybody working together, this item can be removed.
Without any objections, item number 14 will be removed. Not seeing any. Item 14 is now removed.
And we hope never to have 22 buildings in our receivership again. But then I'll be gone. So I hope the agency never has it in their receivership again. And number 15, this is the PEAK program. Haley has brought this in 2019. And actually, we did agree with her even then that the PEAK process needed to be reviewed thoroughly within KDADS. We believe we've done that. New members were added to the PEAK Advisory Board. The advisory board for the PEAK initiative is actually made up of nursing facility administrators. So we have shifted that PEAK initiative from, it was in program, it's shifted to Scott's shop for years, and now it's back in program as it should be. And we are much more engaged with the members who serve on that PEAK advisory board. We've got committees that come together every single quarter. They've got ideas. They've got 3 new goals that they set for themselves. So from our vantage point, we've done a lot of work in this area, and we would respectfully request that this be removed. But if you want to keep it, we can also keep you posted on what the work group is doing.
I believe we want to keep this one and just
Okay.
get an update on how the work group's working on this one.
Item number 16 from our vantage point is from a conferee who is very concerned about an individual in the IDD community who'd had a very difficult transition with law enforcement. We agree with that. Again, we couldn't agree more that we need better solutions for folks who have dual diagnosis, and we're working on that. I don't know if you want to combine this with the sequential intercept model effort that we'd like to advance at some point in time to make sure that this IDD individual, his experience isn't shared by others.
Yeah, I think without any objection, we'll combine those two. So, no, not seeing any.
Okay. Item number 17 was from Linda. She was concerned about our change of ownership process, that it had become too slow. We have worked, well, actually, this is Scott's team and my team. Scott's team actually does all of the paperwork processing for the change of ownership, and then my team actually helps work with those new owners to get them Medicaid certified if they choose. So we feel our process is a well-oiled machine, as good as it's going to get, with a very paper process, if you will. So from our vantage point, we've addressed Linda's concerns. It's my understanding that Linda just left, but that Lee reached out to Linda to ask her perspective if this issue still needed to be on the list, and Linda said she agrees that our process has improved over the last year or so. And maybe this was during COVID that we were just really not on our game. I don't know. But from our vantage point, our child process works pretty well. We would ask that it be removed, but that's obviously your prerogative.
Committee, without any objections, we'll strike number 17. Not seeing any.
Number 18, I may need Scott's help on this one also. Lacey provided a few more details on the issue of insulin administration by our CMAs. Now, Scott, don't get mad at me. So there are CNAs in long-term care and in Kansas and hospitals, but then there are also what we call certified med aides, which are very specific to long-term care buildings. This question was about assisted living and nursing homes. So Lacey's response to this is that her recommendation, Scott, would be that the CMA curriculum be modified to help with the training of CMAs, if that is the direction the legislature wants us to go. There are concerns that if the curriculum changes so that insulin can be administered by CMAs, then there would need to be some opportunity for that skill to be updated as needed in the nursing facilities. So, Scott, I don't know, I don't want to catch up flat-footed here, but is that fair enough? That, I mean, Lacey Hunter, our Commissioner of Survey and Cert, her recommendation on this, again, is that the curriculum would need to be revised, but she's also concerned that there would need to be ability for the CMA to be able to have the time to review the blood glucose levels and make a decision based on their training. So, I mean, KDADS would be in favor of this, it's my understanding, if that's the will of the committee.
It does require a regulation.
It does require a regulation change, sorry. And again, this would be in assisted living. This would be in nursing homes, which is where we have CMAs. We don't have CMAs in assisted living and other residential and home care, home plus facilities. So we would only be able to partially address this conferee's concerns with look into the CMA curriculum. So. If that's something you want us to do, we'll continue to explore this curriculum change. It will take some time.
I think that's something that we would like to see
Okay.
pursued.
Item number 19. Oh, this was from Mitzi. She also was recommending that the Senior Care Act should be amended to serve those under 60 with diagnosed younger onset, and Representative KanCare. This is one of the issues that's being discussed in your task force, so if you want to leave it here, obviously that's fine too, but I do think that's going to be part of the discussion there. The statutory language for the Senior Care Act currently does state 60 and older, so if you want that changed, you'll have to change it in statute. But that may be a recommendation that comes from your committee, Representative KanCare. So, Item 21 on page 26 was also from Mitzi, that this was right in the thick of COVID, although COVID is still here, that there was noncompliance with infection control practices. Oh gosh, where's our response is actually on page 27. And this was from Lacey on Scott's team also, so I may need Scott's help here. But they spent some time, I think, yesterday talking with you about the guidance when it comes to visitation and the update on survey and cert and where we're at with infection controls. And I think Representative KanCare and Lacey also presented at your Kansas Senior Care Task Force, and she did a nice job of explaining to the committee members how many surveys have been done with a real focus on infection control early on. I think there's less focus on just infection control surveys right now. We've gone back to full-blown surveys. So I don't know if you want to keep this agenda item or not. We are back in the mode of full-blown surveys.
Just me personally, I think, I know you guys have addressed this, but I'd like to keep it on there just in case this arises quickly again, so.
Okay. Issue number 22, which is on pages 28 and 29. This is the Money Follows the Person program, and we were being strongly urged to resurrect the initiative that Kansas had in place several years ago. Again, we do believe in money follows the person. Kansas was one of the first states to move forward with an MFP. In fact, I think we actually developed our own MFP before the federal government even had the idea, to be honest with you, in my opinion. So we will continue to work with stakeholders and develop our Money Follows the Person project. Amy has included this in part of her 10% FMAP enhancement as far as how can we actually get the MFP process up and running again. So what that means is that you have a process in your state that the money does follow the person. When someone transitions out of a nursing facility into the community, the money follows them. So I would suggest we keep this on this issue list, and we'll keep you posted as the MFP process materializes in Kansas again.
You want to keep this on instead of removing it?
Well, I mean, I would, yes, just to keep you posted, or you can remove it and know that we are working on it. So, I mean, it's up to you.
I was going to.
You're going to remove? Okay.
I'm going to remove it. So
That'll get Amy's
if
vote.
it pop back up, you guys just can readdress it. So
Okay.
Without objection, we will strike number 22. Seeing none.
Great. Item number 23, this came from the Center for Independent Living Community. This is from the SILs, and their vantage point is that there's not a designated source of support or line item in the state budget when it comes to providing Center for Independent Living services to Kansans. So their suggestion is that they receive additional appropriations so that they can do their work better. We agree additional appropriation would be needed in order to make that happen. And here's what we've heard. I mean, we've heard from the Centers for Independent Living community that they would like to have something similar to the Senior Care Act that would allow them to receive some SGF to help them better fulfill their mission in Kansas and serve individuals with disabilities. That will be up to you as far as if you want to support legislative action that would include some additional funding to the Centers for Independent Living.
I think that one is okay to change and put under legislative action instead of move it from KDADS.
Okay, we'll go to number 26, which this 26 was a combination with KDH&E. I think Sarah addressed it slightly when she was talking about the pandemic. Let me look, see, what are we, this is staffing, wage pass-through. This all has to do, from my vantage point, which is COVID, the COVID experience in general, which has been a hardship on nursing facilities, and we would agree. It talks about, our response to it talks about temporary aids were authorized, which we probably don't need to go there again. Unless you want to, we can. But then I think in general, Haley is also talking about, well, what is she talking about? We remove the, Scott, I might need your help here. It's temporary aids again? Okay. Okay, I don't know if we could combine this with the other TA or limited TA or limited A, whatever we were going to call the other. What was it? LNA? Limited nurse aid. Okay, LNA. That's got a nice ring to it. I think that works good enough. So if we could... No, I'm sorry, Mr. Chairman, I should not have said that. We don't need to have another discussion.
Okay.
So
I think without objection, we can combine those. And
I think we're almost finished, Mr. Chairman. On page 33, number 28, again, this was emergency waiver for the use of we'll say LNAs. Same thing, whether we want to combine this with item 26.
yes. Without
And then
objection, we will.
29 on page 34, Nick Wood again brought up the issue of a statewide mobile crisis service program. We could not agree more. We are hoping to move in that direction. So we would ask that this also be combined with the earlier conversations about mobile crisis for the IDD community.
I think that makes a lot of sense. So without any objections, and I don't see any, so.
Page 35, issue number 30, Janet Williams brought up the policy changes for the BI waiver. And our response to that is at your request, we are providing you with recommendations from the BI policy work group. They have been incorporated into the work plan. Amy, I think, probably shared that with you yesterday, and we'll be happy to share more details of the work plan as needed. This has been a top priority for KDADS, the HCBS crew that oversees the BI waiver, to make sure that we are reviewing those policies. We are responding to your requests that were listed in the proviso for us to do so, and we are responding. Amy has asked that this be removed from the issues log because she will continue to report on the expectations list or whatever we do with our slide decks. So that's up to you.
Representative Landwehr.
Thank you, Mr. Chair. So what we've basically gotten to the point, we are not doing a waiting list with the brain injury waiver. Correct?
Not
All
at
right.
this point. No, the appropriations that you provided us, along with the changes in the policies, at least for right now, correct. Now, we'll let you know if that changes, but Amy will let you know that, and so will Secretary Howard, if anything changes.
Representative Carpenter.
Thank you, Mr. Chair. I thought the proviso required looking at the brain injury and making sure that people were on there for that they're actually able to be rehabilitated.
Yep, it does.
Okay.
It requires us to ensure that our policies are such that folks are making progress on that waiver, that you can't,
right.
You know, we don't want people to stay for 10 years.
We would move them to a nursing home or
move them to the PD waiver or to another waiver.
Right.
Right.
Okay.
And some of that, Representative Carpenter, has to do with, you know, some of our rates aren't standardized across the waiver, so we've got incentives here and they're wacky. You know, we need to get them in better alignment, and one of those wacky areas is the BI waiver pays higher for attendant care than the PD. So you're going to hear more about that in our budget submission that help us standardize some of that, and maybe we would see less of someone staying on a BI waiver for 4 to 5, 6 years, and then it's about the attendant care rate. So we are attempting in our review of this BI waiver, in our policy review, to help us better ask you, what do we need from you to stop some of the incentives that are not what we want to see happen. We don't want someone to stay on the BI waiver because the attendant care rate's higher than the PD. That makes no sense. So let's get that corrected.
Representative Landwehr. Representative Carpenter.
Well, I just think that mainly, you know, it's about how large the waiver's gotten, how quickly, and are we doing a good job? Are we incentivizing getting on the waiver? Are we, you know, I mean, I think that's what it's about as far as that goes. We grew, you know, exponentially since its foundation, and this last year, there was $8 million added to the funding of it just to keep it from having a wait list, and I think that's where that came from. Was are there people on there that were too long, or what are we doing?
Well, if I may, Representative Carpenter, what I share part of your vantage point on that. What actually we saw was the TBI waiver it grew pretty fast right out of the gate all those years ago, and then it really did plateau and steady for quite a while when it was just traumatic brain injury. It did plateau and stayed pretty steady, and actually we saw a slight dip, which surprised us. And then once you all made the decision to change that waiver to just brain injury, which then includes stroke victims and kids, then yes, exactly, that's exactly what happened. But the TBI waiver stayed steady for years, and then we brought in the kids and the stroke victims, and then we saw the increase. So at the same time, what that forced us to do was look at that brain and the TBI policies really closely, because we had people on that waiver who had probably stayed too long. So it forced us to look at the policies more closely, and we're doing that, and we've done that. So we'll continue to report.
Representative Landwehr.
Well, and I think, you know, that was the intent when we did this, because it's no different than what Medicare does.
Right.
If you're in rehab and you're not improving,
right,
then you're going to get shifted. And that's the way it should work here, because the brain injury waiver is about getting that immediate rehab to hopefully get you as functioning as much as you're going to be able to with your new injury. So
right. And Janet was here yesterday. Janet Williams was here yesterday. She brought up the fact that we're going to initiate a review committee, because to actually remove someone from the waiver because they're not making progress, we want a review committee to help us with that. We don't want one of Amy's team deciding on his own or her own that this person's no longer making progress. Let's remove the person from the waiver. We want a review committee to help us make those decisions. So, and Janet talked about that yesterday. Amy's request is for this to be removed. Obviously, that's your prerogative on number 30.
Without any objections, we will remove item number 30 from the list. Not seeing any, that is removed.
30, I think I'm almost finished, Mr. Chairman. This is 31 is from, well, maybe this is it. No? Number 31. I don't think we responded to number 31. I bet that was assigned to me. Well, let me just take on 31, and we'll go back and fill in December. I apologize for that, Mr. Chairman. I think that was assigned to me, and somehow I missed it. There are significant amounts of uncompensated care and assisted living. Well, maybe Sarah talked about this. I don't know if she talked about, the reality is that CMS does not allow for retroactive payments in assisted living and HCBS. I mean, that's just the reality. That's not something we can change at our level. We simply do not have the authority to backdate with eligibility an HCBS client. So if an HCBS customer goes into assisted living, we agree with Linda. If that assisted living provider starts delivering care and the person is then applying for HCBS, we can't go retroactive. And CMS isn't kidding about this. They're serious. We've had multiple conversations over the years with CMS about this isn't fair. I mean, we've said that, the advocates have said that, because in nursing facilities, you can go retro. You can go back. In HCBS, you cannot, and CMS has been very clear with us. That's the way the process works now. I think at some point it'll change, but it hasn't happened yet. So, I mean, when I say it may change, it may take 5 years for it to change, and maybe it never will. But for right now, we don't control the eligibility requirements for HCBS as far as CMS rules.
Representative Landwehr.
Well, so the delay that I think that she's talking about here would be no different than an individual that's not going into a nurse or an assisted living facility. If they're applying for HCBS waiver, they're under the same delay and everything else. So it doesn't make any difference whether it's in assisted living or it's in your home. So this isn't new. So
Right.
I would say we take this off.
Not new at all. It's unfortunate, but it's not new.
Without objections, we will remove item number 31. Not seeing any, item 31 is removed.
I think I'm close. Number 32 on page 36. This was a new item that Haley brought up. And you know what? It's a good one. And she brought up the fact that, and honestly, we double checked the statute to make sure this was accurate, and it is accurate, that when it comes to decertifying licensed beds and the quality assurance, the quality assessment language in the statute, that you can actually be charged immediately for new beds, but when it comes to decertifying beds, there is no relief. You actually have to continue to pay for those beds until we reach that next cycle. That is in the statute. So I provided the statute for you so that you could read the statutory language. And the last sentence, any change that reduces the number of licensed beds in a facility shall not result in a refund being issued to the skilled nursing facility. So if you want to change this particular issue and allow us to issue refunds to nursing facilities, now we're talking at this juncture, we're talking the quality assessment, the bed tax. So if you want us to give us a refund on the bed tax, let us know. At the current time, we do not, based on your direction.
Okay, Jana, thank you. And Connor, I think maybe that might be something just to put on a recommendation for later. I know it's past 10 o'clock, but so I'm sorry. Janice, go ahead.
The very last one actually is on page 40, number 37. Sarah mentioned that we would get to this, and we will. Johnson County is an area we're interested in for PACE expansion. We have met with Sean Sullivan on the 10th of December, and then we're going to meet with him again on the 17th. So KDADS is interested in expanding PACE. I will note, I think Secretary Howard mentioned it yesterday, I think, but I didn't hear all of it, that PACE is now part of caseload. So that will be incredibly helpful as we continue to, yeah, it will be in 2023. You're correct, Representative Concanon. So at this point in time, we are interested in visiting with Sean about expanding PACE into Johnson County. So that is it for me, Mr. Chairman, members of the committee.
Janice, thank you very much. And again, do we have any questions for Senator Gossage?
This is more of a statement rather than a question, in that being in the healthcare world and health insurance world, LNA sounded familiar to me. And it's actually licensed nursing assistant. Is a medical professional. LNAs generally work under the RN to help care for patients and perform routine care of the medical facility. The LNA title is interchangeable with CNA, which is a certified nursing assistant.
Oh, wow.
So even though our LNA is not the same as this LNA, just a thought, we may want to reconsider how we use that.
I think we'll save that conversation for when we make our recommendation so we can keep the progress moving, if that's okay. But thank you for bringing that up. Right. So, Representative Ballard.
And thank you, Mr. Chairman. I believe in the beginning, Janice, you made thank yous to so many people. And I think we will take this opportunity, having worked with you for many years, to thank you for all the work you've done. And I'm sure the last 2 years has not been fun, but they have been effective.
Yes.
And for that, we thank you very, very much and wish you only the best in your retirement.
I think my hair will continue to get grayer, and
Well,
I seem to continue to get fatter, a little chubby. So I hope that, I think it will be fun. Thank you, Representative Ballard. It has been my pleasure.
Thank you very much.
Thanks.
Representative Landwehr.
Janice, I just want to say it has been a pleasure working with you, and we've been able to agree and disagree over the years, and it's never personal. And I can tell you that there's a lot of fun, a lot of enjoyment to retirement. And I'm looking forward to getting back to it, and just travel every minute that you can, but just relax with it. Don't worry about the gray hairs. We earned them.
Okay, last on our list before we break for lunch is Carrie Kimes, United Healthcare, and she's going to give a joint MCO response. Carrie, welcome to the committee.
Hi, good afternoon, or not quite afternoon. I'll get us out of here before afternoon, I promise. My name is Carrie Kimes. I'm the Director of Provider Relations and Network Strategy for United Healthcare, and I'm speaking on behalf of the MCOs. We have 3 items to cover quickly. On the spreadsheet, we'll start on original page 1, item 1. Related to some concerns for home modifications and the process that providers have to go through to get home modifications reviewed and approved. This has been on here for a while. The MCOs have collaborated as a group and made some recommendations to streamline this process. We've created a 1-page document that all 3 MCOs can use to make those recommendations and to streamline that process, and have submitted that for KDAD's approval, so we can initiate and start using that. And so as soon as we have an approved document from KDAD's, we can start implementing that into our process. So that is our first item. Our second item is item number 2 on original page number 2. In regards to network adequacy, there were 2 items directed to the MCOs on that one. One was specific to sedation dentistry, and some questions around how many sedation dentists and availability in sedation dentistry. And so we have 3 bits of information from United Healthcare. In our network, we have 32 dentists that provide sedation, that are let me clarify, that are actively providing sedation dentistry to our members. They're members of 22 group practices, so just you might have 3 dentists in one group, but there are 32 individual dentists that are actively providing sedation dentistry that are members of 22 groups, and they are located in 15 counties throughout the state of Kansas. From an Aetna perspective, they have 365 dentists that have the capability to do sedation dentistry in 205 groups. And I always make that distinction of individual dentists in the group practices. That represents 65 counties. And then Sunflower has 11 dental offices, including 9 oral surgery offices that offer sedation dentistry, and then 15 anesthesia practices or anesthesiologists that will offer and work with those dental practices. The second piece of this was specific to durable medical equipment or DME providers and that network. So from a United perspective, we have 220 participating providers who can serve our members. Aetna has 348 durable medical equipment providers in the state that can assist their members, and then Sunflower has 492. And so that was just something we've been reporting each session since that issue has been left open. So we wanted to continue to report on that as we have historically. And then the last one for the MCOs is on Part 2, issue number 35, and that is on page 37, I believe. I'm sorry, 38. And this is related to the IDD crisis process. And there's been some concern that that process is clunky and doesn't work as well as it should. All 3 MCOs have staff that's dedicated to working both within our internal processes and with KDADs to go through the IDD crisis process. Part of that would be looking for other services that we can put in place, whether it be covered services or non-covered services in the community that we can put in place to help the member get out of crisis. But ultimately, we are working with KDADs to evaluate the overall process and policy around IDD crisis and hopes to improve that. And obviously, as MCOs, we will follow whatever policy or process the state puts in place in regards to IDD crisis. So those are our 3 items, and I'll stand for any questions.
Carrie, thank you very much. Committee, do we have questions? Senator Gossage.
Thank you very much. A couple of things that came up earlier from a conferee was regarding the home modifications, and you had addressed that there is going to be a standardized request. But it also mentioned that families are required to get their own bids. Is this still the process?
No, I know for all 3 of us, we have program managers that are specifically dedicated to home modifications, and we work with our contracted providers who do the home modifications within our network to get bids.
Okay, great. And the same thing about medical equipment. I didn't notice anything in here about that. There was the same concern about bids and about it being uniform across the MCOs.
Yeah, for durable medical equipment, there are no bids involved. These are items like shower chairs or risers and things like that, and there's a standard retail or manufacturer's price for those, so there's no bids involved in that. The members are asked to go to a participating provider, and the participating provider will provide that to the member, submit a claim to the managed care organization, and we'll pay them the Medicaid rate for that. So there's no need for the member to get a bid. In some cases, if it's a high dollar item, they will be asked to get a prior authorization, but there's no bid, and really shouldn't be any inconsistency in that process.
Thank you for the clarification. Thank you, Mr. Chair.
You bet.
Okay, Carrie, I do not see any further questions from members of the committee, so thank you very much.
Great, thank you so much.
Committee, that does conclude our morning session. Representative Carpenter.
Thank you, Mr. Chair. I just had one item left over for KDADs. Before they left here, I had asked yesterday about the presumption of background checks, presumptive eligibility. I wonder if they had how that process works.
Amy?
Hi, Amy Penrod with KDADS. In our existing waivers, the language requires that an individual pass a background check prior to providing services. During COVID, as an Appendix K flexibility is something that would help us get workers, out and working with individuals as quickly as possible. We did ask for a kind of a waiver of that requirement to be in place during the public health emergency. So right now, an individual still has to have a background check, but they can go ahead and begin providing services and begin working pending that background check. Now, if a background check comes back with a prohibited offense, they would have to cease providing home and community-based services to an individual. But that's kind of the process we're at now. And right now, Appendix K is still in place, and it will be in place up to 6 months post public health emergency conclusion.
So we think March, so it'll be 6 months after.
Mm-hmm.
Okay. And that is permission from what, the federal government?
Yes, permission from CMS to waive a requirement that's in our waivers currently. So some of those requirements or some of those waivers, the waiver language, we could make an amendment to allow that provisional employment during the background check. That, along with paid family caregivers and telehealth, are three of the items that we have on the fast list, or the fastest we can go list to get addressed through waiver amendments.
So you're going to address that then? That's all I wanted to make sure.
Yeah.
We're just struggling with trying to get people to work. And,
correct.
Don't get me wrong, I don't want anybody to get hurt by not having a background check, but I don't know what the wait time is on a background check, but if you've got an able-bodied employee that just is waiting on the background check, it's significant. So anyway, thank you. Good job. And let us know if we can help on that issue. Thank you.
Thank you.
Representative Lynn.
Thank you, Mr. Chair. I was just curious, who is your vendor for background checks and how long does that normally take?
We have a division within KDADS that coordinates and operates our background checks. The KBI portion goes through the Kansas Bureau of Investigation for the primary background check. For home and community-based services, there are a few other checks, such as motor vehicle records for individuals that are driving. There is a Inspector General federal exclusion list that must be checked. And then we have a requirement that the Adult Protective Services and Child Protective Services and the Nurse Aid Registry lists are also checked. So as a general rule, there's kind of a lot of not a lot of hands, but a few different places that we have to coordinate responses for.
If I may, so it's not just looking for felonies, even the MVRs. I mean, I do background checks as well. I can usually get them done in 24 hours. So I guess that's what I'm asking, what it is that's creating that delay.
I don't think I'm misspeaking that the primary background check through the KBI generally returns very quickly. There are some other processes, for example, the APS and CPS checks that are handled by DCF. They are more manual, and my understanding is that they are more of a manual check, and those do take time depending on the volume. So that it's not necessarily that KBI check that's taking the time. It's some of the more manual processes.
Thank you, Mr. Chair.
Representative Carpenter.
I apologize, but you didn't say how much time. That was part of your question, Representative Lynn.
I will have to, I want to say that the KBI checks come back within 48 hours, don't they? Okay, well, we will double check on that. And I will check on the current time that it takes, that we're averaging to get a response on the APS and CPS checks.
Amy, thank you for answering questions for us. And committee, we have nothing else before lunch, so we are going to break for lunch. And they're singing to us so as we walk out the door. So everybody enjoy your lunch. We will be back at 1 o'clock sharp. Thank you. to reconvene the Bob Bethell Oversight Committee. First up on the agenda, we are going to have discussions on nursing facility staffing agencies. And with us virtually will be Bob Lavonis with Lavonis Consulting. Bob, welcome to the committee.
Thank you very much. Can you hear me okay?
We can, thank you.
Great. Well, thank you so much for letting me do this virtually. I appreciate it, and I'm excited about the opportunity to talk to you all. I'm Bob Lavonis, and I want to thank you for letting me participate and to provide you some insight on the healthcare staffing industry, which has been in existence for about 65 years in the United States. I've been in the industry for about 30 years. I was the head of 3 different healthcare staffing companies during my full-time working days. In semi-retirement, I'm working as a board member or board advisor to 7 different companies in the industry. I'm still very active. In fact, I recently gave the keynote speech at one of our industry annual conventions in Boston just last month. I'm formerly the chairman of the American Staffing Association and a board member for 7 years. Now I'm engaged with ASA to help educate and communicate on behalf of the nearly 5,000 agencies in the United States that provide healthcare professionals to long-term care, hospitals, and other healthcare facilities on a contract basis to fill short-term needs, provide proper, safe care to the residents and patients. Prior to the hearing, the American Staffing Association submitted a one-page document that you should have in the materials for this meeting. It explains the higher pay rates that are driving the increased cost of nurse staffing. It discusses the supply and demand imbalances. And it predicts the inflationary pressures will moderate as the pandemic subsides, but unfortunately, the nursing shortage will remain. I'd like to give deeper insight into how an agency works for all of you, and that may help clarify some misconceptions you may have and may help impact the alternatives that you're looking at to curb this current crisis. I understand that there's some discussion and activity to evaluate putting rate caps in place for staffing agencies. Well, this has only been done in 2 states, and it was done quite a few years ago. No one has done it recently. I urge you to understand the negative impact that these actions have taken on the staffing shortages in those states. I also encourage you to talk to states who examined this option and elected not to do it. The staffing agency model requires that pay rates for agency nurses be higher than the rates that are paid to full-time nurses to cover the costs of recruitment and staffing process, and I'll get into that more. When states have tried to drive down the rates, the agencies shift their focus and start placing these people in other assignments or stop servicing the state altogether. The nursing homes in the 2 states with caps have been more desperate for staff than before the caps. Many facilities have had to pay even higher rates to import nurses into their market by paying for travel costs to get them there. As a background for you, only 1 to 2% of all nurses in the staffing agency work in staffing agencies. You might have thought it was a much higher percentage. I did too. A much smaller percentage than you might imagine. In this period of COVID, however, I estimate that we've lost more nurses for fear of COVID, for fear of the vaccine, or the client has restricted the use of agency nurses. And this has exacerbated the supply problem. While there have been several drivers to the excessive shortage we are experiencing during this pandemic period, many caregivers were afraid to get infected and at work and then take the virus home to their family and friends. And more recently, nurses who don't choose to get vaccinated are being forced to find employment at other places without vaccine mandates like Amazon or Walmart. And finally, many caregivers are burned out and are choosing to retire. In my experience, about 60 to 70% of nurses who work at an agency already have a full-time job and are simply working extra hours for extra money. Only a fraction of nurses that work in the workforce that work for agencies on a full-time basis. Nurses use this option to bridge the gap in their income requirements. Alternatively, they might work at Walmart or Amazon for the extra money. Staffing agencies help keep nurses working in nursing. Staffing agencies are employers of record for all their nurses and healthcare professionals while they're on assignment. We are like nursing homes and assisted living facilities or even hospitals. We're also responsible to carry and pay for all professional liability insurance to cover any clinical errors. We pay for workers' compensation insurance for any injuries on the job. We pay unemployment claims. Agencies pay all payroll taxes, including state and federal taxes. We're obligated to pay overtime wages. We provide drug tests, skill testing, background checks, all at our cost. We're responsible for contracting with the state to ensure that the compliance of all the nurses to be properly licensed and verified with all the documentation that they have all the proper immunizations. Agencies test all nurses for their skills to be assigned to the job. We aid them in getting compliant with the state and federal laws and remaining compliant with all requirements. And we're responsible if they go on assignment unqualified. Most agencies provide some form of continuing education. And if a caregiver is traveling, the agency actually pays the nurse for their travel, lodging, and meals. So that's all included in the bill rate. On top of these costs, the costs for the recruitment and onboarding staff of agencies cost to get qualified to get the right qualified healthcare professionals. So I'm talking about the onboarding staff and the in-office staff. And there are all these costs for the office staff to coordinate scheduling, rescheduling, cancellations, call-offs, sickness, and finally, placement of a caregiver at the right place at the right time. Interesting to note, about 15 to 20% of shifts that are filled with ready-to-go caregivers actually get canceled by the client. So there's quite a bit of rework. Staffing agencies also help fund the payroll of their clients. Agencies pay their nurses every week, but they don't get paid by the client for 30 to 45 days. In some sad cases, when a long-term care facility goes out of business, agency owners are left with significant unpaid invoices that can amount to tens of thousands or hundreds of thousands of dollars in losses. All of these costs are in addition to the hourly wage paid to the healthcare caregiver. Profitability of the industry, after all recruitment, placement, and statutory costs, is much lower than you might imagine. It's a very low percentage. Changing the equation of the pay and bill rate will cause agencies to go to other states or just not operate in the state of Kansas. Even if the wages of nurses who are willing to work for staffing agencies goes up, as it did during this pandemic, and that results in a higher bill rate, the profit margins remain the same due to the increased cost of more staff and more advertising and even more competitive recruitment effort for very few nurses. It's a rare exception that a nurse working full-time at a facility quits his or her job to go to work full-time on an agency. Now, we've seen more of that during this pandemic period. Of course, personal circumstances can cause one not to be able to work full-time or anymore, or to work less, especially in these stressful times. Staffing agencies serve a very important role in keeping many caregivers in healthcare as possible, to keep as many in healthcare as possible by enabling them to work just the number of hours and days that they wish to work. By keeping them active in the workforce, we're helping fill the void and the shortage of supply in Kansas and in the United States. I'm sure you already know the long-term care sector is currently understaffed by tens of thousands of caregivers, and it's only projected to get worse if we don't increase wages for nurses broadly. The cap on Medicare and Medicaid must allow for higher wage rate for all nurses and other caregivers. We must be able to attract more people to become nurses. Wage rates are an increasingly bigger issue, and the pandemic has exposed this issue that's been there every day for every facility administrator across the country. I've been in this business of staffing in long-term care facilities and hospitals with doctors, nurses, therapists, and other healthcare professionals, as I said, for 30 years. The ebb and flow of wage rates and bill rates has always been a function of supply and demand. During recessionary periods, many caregivers choose to find full-time jobs because their spouse is out of work and they need health benefits. This reduces both supply and demand. Agency pay rates go down and bill rates go down as there is not a strong enough demand for contract nurses. But for example, when the flu season hits every year, there's always an increase in demand. Clients tell us they're willing to pay more because they need the coverage for the care and safety of their patients. It's supply and demand. Nurses are influenced heavily by the difference in pay rates between one agency and another. Agencies do not collude. The fundamental economics of the industry are that bill rates go up increasingly proportionate when wages go up. Because of any nursing home administrator can pick up a phone and call multiple agencies, the bill rates are driven by competition between agencies. Bill rates are being driven off of pay rates. The belief that an agency is marking up the bill rates and pocketing the increase is simply not true. The competition for both pay and bill rates is dynamic and very much driven by supply and demand. The bigger issue is that Medicare and Medicaid rates must contemplate the rising cost of labor and what it will take to compete to get people to enter and stay the healthcare marketplace. This is particularly true of CNAs and medical assistants. These roles are projected to be the fastest growing need in the United States. There are over 5,000 companies in healthcare staffing and home care market who are competing for local talent. Staffing companies bid against one another to offer the most competitive pricing and comprehensive pricing to hospitals and long-term care facilities, while offering the best pay to nurses to be able to attract them to the job. So it's clearly understood the staffing business that it is illegal to collude on pay and bill rates between agencies. You don't do that. While the pandemic is in a unique period of time, we have examples of other crises that have created unique demand in labor costs. For example, firefighters, will leave their full-time jobs in a local firehouse to go put themselves in danger to fight fires in California at rates far above their salary at home. And when hospital workers go on strike, the hospital is forced to pay for strike nurses who are willing to cross the picket line at rates far above the salaries of those that are on strike. Those nurses come out of full-time positions to take these assignments only because the pay is high enough as an incentive. And that's what's happening during this pandemic. The needs are strong enough and the pay rates are high enough that nurses are making different decisions that they would normally make. But it's not because there's price gouging. There's not price gouging in the staffing agencies. Rates are a function of supply and demand. Agencies are proportionally raising the rates and not taking profits unfairly. Putting caps on agencies for long-term care or in hospitals will cause an already low margin business to either stop servicing or closing their doors. And while staffing agencies, there's no easy outlet for healthcare workers to earn money during doing healthcare. Without staffing agencies, nurses who are semi-retired would not be able to fill shifts when they were able. And we desperately need healthcare professionals to stay in healthcare. Finally, we're in a labor crisis. And when the federal and state governments have stepped in to help us with supplemental payments to help address these extreme labor shortages, it was very, very helpful. And we need more permanent fixes. Higher pay for nurses through Medicaid and Medicare rates need to contemplate those higher rates and attract more people to nursing to contemplate these rising costs of caregivers for your residents and for your patients. Finally, I want to thank you for your time and thank you for all you're doing. I look forward to questions. Hopefully you'll have some for me, and for everything that you do to take care of the elderly and disabled in Kansas. Thank you very much.
Bob, thank you for your testimony. I'm almost certain you will have some questions, but we're going to hold questions till after all the conferees on this subject. So if you could stay with us, that would be greatly appreciated. Committee, our next conferee is Haley O'Donnell, chairperson for the Kansas Adult Care Executives Association. Haley, welcome to the committee.
Good afternoon. It's nice to see several of you again in the past week. For those of you, my name is Haley Ordoin. I am the chairwoman of the Kansas Adult Care Executives. For those of you who do not know our association, we are a nonpartisan, nonprofit professional association that represents the actual administrators, operators. We're the boots on the ground. We're the ones that live this day in and day out. Hot topic here, staffing agencies. We have a lot of insight for this from our members. I will agree, it's no secret that staffing has been a crisis prior to the COVID pandemic, but what we're facing is becoming unprecedented, and if we don't start putting some boundaries in place, we'll have an even larger issue for the seniors in our state on our hands. One thing I did want to mention too, and I believe it actually got cut out, and I know this is on a federal side, the Build Back Better Act, just a heads up on that in case sometimes the state imposes requirements and regulations that we still have to follow regardless of whether it's state or federal. We had heard that the Build Back Better Act had a portion in it that was going to require 24-hour RN coverage in our facilities. Hopefully I'm correct in hearing that that is not the case and that that got cut out. I am telling you on a state side that if that were to come in discussion, that would cripple our industry and many would close. I have heard from many conferees, close to 70% of our buildings, that would be a huge issue for, because we already have a problem with staffing just the 8 hours of RN coverage that we're required to do. In regards to reimbursement rates, just to help you understand too, our reimbursement rates are low, and I know we've talked a lot about methodology of calculating that. This pandemic has put an even higher need for that because 5 years ago, we used to be able to operate with probably about a 50-50 mix of private pay and Medicaid in our buildings. That has increased now, I would say, closer to a 70% Medicaid, 30% private pay. So there used to be a little bit more reimbursement through that private pay to help. What I'm saying is our bottom dollar has decreased through that, to help you understand the reimbursements. We have increased our pay rates to our nursing staff, not just the nursing staff, but all staff. And we still the staff is still not there. Our members are saying that if their reason isn't going to be financial for buildings to close, it will be staffing. Of all of our membership, I just wanted to give you a couple different insights to what we are seeing with staffing agency use. Yes, I know it was stated that the agencies pay the mileage, the meals, the labor rate, the hotel fees. That's passed through to us. Yes, it's paid by them, but we are charged that. It's a pass through. Agencies have a buy-back or buy-out clause. I don't know if several of you are familiar with this. So basically, if I have a CNA or a nurse come and work in my building and we really love them, we develop a great relationship with them, and we're like, hey, we would love to offer you a full-time job. Many staffing agencies have a clause in their contract where we have to buy them out. Some of those are anywhere from $3,000 upwards of $10,000. I don't know any other industry that has that. That's not something sustainable for us. And we have multiple, and you'll see this in some of my slides. I apologize, this is 8 pages long, but I try to give pictures for depictions. We do have full-time staff that are leaving us to go work agencies full-time. And if you want to reference, again, I apologize, page 4, I believe. Yes, page 4. During the COVID pandemic, have you lost employees to staffing agencies? 92% have said yes. So that is a huge problem that we are facing too. We are being asked to pay overtime rates when the person didn't even work overtime for us. We've had a couple different buildings that have ran into this. So, for example, if a nurse works 20 hours at building A, 20 hours at building B, and then 5 hours at my building, we will be charged that overtime rate because it's an accumulation of what they worked within the whole week. The agencies have told us that was part of an audit from the Department of Labor on them. So, if we're the poor sucker at the end of the week on a Friday or Saturday that needs 8 hours of coverage, and they've already hit their 40 hours working at some other buildings, we're now paying time and a half for double time for that. Yes, again, they pay overtime. It's a pass-through from us. Agencies hold individualized contracts for reimbursement. So they each have different contracts with each building, hospitals, what have you. Our members have discussed with these, CNA staff of the agencies and have been told that because they have this power, they're often using it and will send staff to whomever they have a higher reimbursement rate with. So if we're in the same county and our hospital pays, 20% higher than what we do based upon our contracts, we have had places where they'll feed all the staff to where their higher rate is rather than us. Multiple buildings will have multiple contracts to try and staff. I know one building in my region, North Central Kansas, they've got 8 contracts, 8 different staffing agencies, and are still not able to fully meet the demands for the supply that they need for adequate staffing ratios for safety. That's where you oftentimes get your staff that is working multiple hours overtime and burnt out. There's no penalties for a staffing agency when someone calls off, even when there's short notice or no notice given. We have to pay oftentimes in contracts if we cancel within a certain time frame prior to the shift, that shift, worker, but if they're a no-show or they call off, there is no penalty to them, and we're just sitting ducks having to scramble at the last minute to try and get additional staffing. And to our knowledge, there are no known competency expectations for staffing agencies within our state. We have always been told that it is upon us to guarantee that competency and to educate according to our building. When we get surveyed, if an error is made, that comes back on us. That comes back on our survey. That does not get penalized, a CMP imposed on the staffing agency. That gets enforced on us. So at the end of the day, the accountability is on the facility and that the contract workers will work in. Also, too, their rate for recruiting. I know that they stated in the testimony that the rate's higher so that they can recruit staff. Yeah, that's true. So essentially, I'm being charged a higher rate so that they can recruit my own staff away from me. That seems a little counterintuitive to me that I would pay somebody to take my staff. I did update this table. Some of you probably have seen this before about the staffing agencies and the rates. This was prior to COVID, the average hourly rate, and some of this I've adjusted this to show what the average rate was for many of our members if you applied at a position in our building. The average agency hourly rate and what the differences are. Those rates have increased. In the last year, I got copies of two contracts from the same staffing agencies, and their rates are increasing have increased about 10% from this time last year. So I don't see that problem going away. I just wanted to depict a couple graphs that we surveyed amongst our membership. And yeah, over 80% of them now are using agency. Prior to the pandemic, the majority of us were not. If you take a look too on page 3, how much over your current rate are you paying for agency staff? I really want you to notice that, because where state and federal dollars are being concerned, that's Medicaid money going to pay this through our buildings. If you take an RN at $25 an hour average rate, you've got about 20% are paying $50 an hour. The majority, about 55%, are paying 3 times the rate, so $75 an hour. We do have, excuse me, about 18% paying $100 an hour, and we do even have a small gap of people, about 5%, that are paying more than 4 times the hourly rate. It's not sustainable at all. Over half of our membership, if you turn to the next page, how much longer can you sustain these staffing agency rates? The 2 bottom lines, orange and purple. If you're colorblind, I apologize. That's over half. Over half of our membership cannot sustain these rates past 90 days. That's a huge problem. We'll see here, kind of painted out the process of what it's going to look like if we're not able to sustain that. How often did you utilize agency prior to the pandemic? 55% didn't even use them at all. I know in my building prior to the pandemic, of the 14 years that I was in operation until the pandemic, we never utilized a staffing agency, ever. When the pandemic came, we had no choice. We don't willingly pay those rates. We're not happy to oblige with those rates. We have no other option. How often are we using them now? 44% now use multiple shifts a week that they have to cover with staffing agency. So the Medicaid rate, with staffing being so competitive, really our wages, we're going to have to figure out something collaboratively to try and increase those rates in our state and increase that rate even as a pass-through for the wage increases. Excuse me. My rate is going to be my lifesaver over here, I think. Thank you. Bless you. So if you haven't been into a nursing facility,
Right now, it's literally all hands on deck. Many are universal workers through the temporary aid system. We are not only having a staffing crisis and shortage with nurses, it's everyone. Agencies are even staffing for cooks, for housekeeping, for maintenance and environmental. It's across the board. So the consequences of the inaction, if you can just take a quick look there. Here's where our problem becomes your problem. More nursing homes will close if we are unable to find staff, to have staff. When these homes close, state receivership will take place. I know right now, I believe there's $5.5 million in that fund. It's not going to go very far if you have a lot of these facilities closed. Like I said, half of our membership can't sustain past 90 days. That's approximately 150 homes. The state CMP fund will dwindle swiftly. National Guard will be forced to be deployed. I think every day when I watch the news, another state is deploying their National Guard. It's a very realistic reality that we may be facing. Rural communities will start to deteriorate. We're one of the top 5 employers in a lot of our counties and a lot of our cities. Families will have to drive so much farther to see their loved ones, and ultimately, everyone will be paying more money for care, including the state. Under solutions, does no good to complain if I'm not going to bring any solutions or recommendations of what we would like to see. We are all proponents of running a business the way that you like, but when Medicaid and federal dollars are being used to pay these rates, we can't change our price to the consumers. We can't just say, I'm going to double my rate now and pass that through to offset. We cannot do that. This is predetermined by the state and CMS, thus the need for a cap on the rate that can be charged. I don't know if many of you follow what happens in other states. But Representative Timothy Bonner out of Pennsylvania is leading a really great effort in his state that we would like to ask the committee to recommend here, and that is to put a cap on the rates that agencies can charge at 150% of the median wage rate average over the last 3 years. Yes, it is true. 2 states have imposed this. Minnesota and Massachusetts have these in place, and other states are in the works to do so. I know Illinois and Missouri are taking steps actively to do the same. And some states are also working to eliminate that non-compete clause that agencies enforce, that's the buyout or buyback. So request. One that saved us, and I know it has come up in conversation here and probably in other committees, is to work to make the temporary nurse aid program permanent. It was a lifesaver. It was a lifeline. I honestly don't know of any building that did not find a way to utilize that. Cap the rate that the staffing agencies can charge at 150%. It's killing us. If you look back on the graph, we are averaging 200 to 250% of the rate that we're being charged right now. It's not sustainable. Also eliminate the non-compete buyout clause that the agencies enforce, and finally invoke stricter regulations and oversights of those agencies and hold them accountable to the same standards and the environment that we, the employers that they are coming and working in, are required to do. It's a huge fight that we collectively as a state have in keeping our senior population safe, and CASE is happy to collaborate and work with you to find any solutions that we can. So there's some additional experiences, if you have time, to go through and read of some of our members that kind of validate some of these key points I've tried to hit on. Again, appreciate your time, your energy, and happy to stand for questions at the appropriate time.
Haley, thank you very much for your testimony. Committee, next we have virtually Anthony Johnson, Chief Operating Officer of Recover Care. Anthony, welcome to the committee.
Hi, I'm here.
Man, virtual has really got realistic.
That's quite the 3D, Mr. Chairman.
I am telling you what, technology.
It's
Anthony,
something else.
welcome to the committee.
It's great to be here. Thank you, Chairman Hildebrand Committee, for listening to my testimony today. I'd like to talk about my role in the company. I won't get into all the details. You have my outline in front of you, but I represent 21 business units in the state of Kansas. I've been operating here for the last 7 years. I'm also the Vice President of Government Affairs with KHCA, and we represent 265 members from the profit and non-for-profit sectors in long-term care. What I'm going to talk about today are some of the anecdotes that I've experienced firsthand, and some stories relate to me from KHCA members. The previous conferee did a wonderful job with sharing data. I'm not going to get real deep in that. So in essence, I'm the canary in the coal mine today. It's not just about dollars and cents. It's looking long-term, what this situation will do to us with quality. And the unfortunate thing about long-term care sometimes is we're often not thought about in the public until it's time to put their loved one into a facility, and then people pay attention, and then they get back to life afterwards and forget about it again. I'm very concerned about our future and our quality for our seniors if we don't do something about the out-of-control staffing. One of the previous testimonies talked about supply and demand and everything that goes with that. I like capitalism. I like free market. They've created a monopoly, and Kansans are suffering at it. Like the previous presenter discussed, their employees will go into our facilities and actively recruit ours. They probably are incentivized to recruit our employees. We've tried a few times to negotiate and say, if you poach one of our employees, we'd like to charge you for recruiting our employee. They all but laugh in our face because they know if we won't agree to the terms of their contracts, they will go to somebody who will. The recruiting costs and everything that was mentioned previously, I had to try hard not to LOL. How is it that a CNA that base wages these days is $15 an hour? Why is it that they're charging us $88 an hour for that CNA? I think it's more than recruiting costs. So everybody in healthcare is underpaid. I'm a former CNA. I guess I still am one, but I've done the work. It's very difficult. Everybody in healthcare is underpaid, in my humble opinion. I'm for paying more, but I've seen the pattern. We'll raise our wages, and within a year's time, I don't know if agencies do market research, whatever it is, they get wind of it. They leapfrog what we're paying them, knowing full well they can bill it back to us because we're at their mercy. Prior to the stay of the vaccine mandate, we've had conversations with agencies preparing to show proof of vaccination for the employees. There were agencies that weren't willing to commit to giving us that information that we were scheduled to be held accountable for providing. Training and orientation, we don't see much of that. We often have to do it on the fly, on their behalf. We have no idea if they're competencied. And if we ask these informations, if there's a situation where we have to investigate an allegation of abuse, neglect, or care issues, it is very difficult to get them to comply with us. My organization spent $1.3 million in the month of October on agency. This is unprecedented. We're on pace to spend about 11 million if we keep running at this rate. To put it in perspective, for every dollar spent on agency, we could save 60 cents if they were on our payroll. Some more of the consequences that I'd like to discuss is the burnout. We have directors of nursing who are expecting agencies to show up. It's always on a weekend. It's always a Friday night. And for whatever reason, sometimes they go to a different bidder. They don't show up. I've had a director of nursing say, it doesn't matter what you do to my salary. It's not about the money. It's feeling helpless when the people you depend on do not show up to work. And so what does a good nurse do? She stays. I'm not proud to say this. We've had nurses work 24 straight hours. Not because they want to or they're greedy, but they feel a sense of duty. And imagine for a moment that one of your loved ones is in our care. We all know what fatigue can do to one's mind and one's performance. We need to do something so we don't have our caregivers in that kind of situation. So a lot of brain power and leadership we have lost in the last year because COVID is a popular thing to blame. It's like pouring gas on a fire. We get that. But we are losing good people because they feel powerless. And the DONs can go make just as much money in an agency and go home at the end of the day and not have that burden. So long term, it's going to be hard to have the oversight, the system analysis, and move forward our sector to be the best that we can be in long-term care. Previous testimony talked about cash flowing our payroll. Many times, the agencies will demand that we pay them weekly for the employees to come up to our facilities. From a solution standpoint, obviously, we're asking for strong consideration and limiting what agencies can legally charge to providers to keep the supply and demand and the inflation of rates under control. I would also like to see development of grants and incentives for future nurses and caregivers. I spoke to a doctor the other day in Belleville, Kansas, and he was telling me how there's an incentive program for grads of med school to go work in rural communities and get their loans forgiven. It's not a quick fix, but I think in the long term, if we could put our heads together in some incentives for caregivers to live and work in rural communities, I think that would help with some of our risk in those parts of this state. And finally, the temporary aid, if we could reinvigorate that, that would be very helpful. We are kind of doing it by proxy, at least in my organization. We're trading, we call them hospitality aides or patient care techs. They help lighten the load. They cannot lift people or provide all the cares, but they can help answer call lights and do some of the things that take time away from skilled nursing care. And finally, more access to schools and programs to educate nurses and CNAs. I speak for my peers, my association, and my company. We're willing to do whatever it takes to help solve this. And I appreciate the time you took today to listen to my testimony, and we're willing to work together to find not only short-term solutions, but long-term solutions for long-term care. Thank you all.
Anthony, thank you very much for your testimony. Committee, next we have Dawn Bay, CEO of Mennonite Friendship Communities. And Dawn is with us in person, yes. I had to make sure. Dawn, welcome to the committee.
Thank you. Good afternoon, Chair Hildebrand and committee members. I'm Dawn Bay from Mennonite Friendship Communities in South Hutchinson, and I'm here representing the members of Leading Age Kansas. And I've prepared written testimony, but I have a few other comments. When you think about the type of services that our residents come to us for, assistance with eating, toileting, bathing, dressing, walking, transferring, these are very intimate activities in their daily life. And most people are pretty private about those activities. And it brings an emotional toll on the residents who often have different people taking care of them each day. The ultimate goal is to have all of our own staff who can provide these services in a dignified fashion. But for now, we do what we can to provide emotional support to our residents. The individuals we serve have lived in 3 different living areas on our campus, giving them choices on where they might want to live. But because of staffing and financial concerns, we have had to close down our home-like rehab house and are looking to close down another area of our campus in order to conserve staff and not use agency staffing. Financially, this is the only way we can continue to operate. Many times when we are scheduling agency staffing, we do it weeks in advance. Sometimes then the agency is not able to fulfill that position coverage, and there is nothing in the contract that shows a penalty to the agency for doing this. And we would like to hold the agencies accountable for these situations, but we fear losing a contract for the provision of any staffing if we complain too much, because they know they will be able to go to another place who won't hold them accountable for this. The increasing costs that we are having to pay for staffing is going to affect the state budgeting process, as our costs are included in our rate setting process. And currently the rate setting process is over a 3-year cost average. And at this time, only 86% of our costs are covered by Medicaid or KanCare funding. And so as those costs increases come, we know it's going to be harder and harder to get reimbursement for those services. There are other states who are putting in place some regulatory parameters on agency operations, as they had said before, with 2 states already passing that, and several others are in that process. They are also allowing facilities to temporarily shut down while maintaining their license. If by some chance the staffing situation does turn around in the coming year, this would allow these communities to be able to reopen. And this would give the rural facilities a chance to keep residents closer to their family members and friends. I know at our community, we basically stopped taking any admissions in the month of August and have not taken outside admissions since that time because of the staffing issues. In my written testimony, I said that we had started with 96 residents in February of 2020, and today we have 62 residents in our building. So that's a loss of 34 residents. Because of the increase in agency costs and what we have had to do to raise our own staffing rates, the difference in the payroll cost for 2 weeks is only $10,000 difference in cost, but we have lost the income for 34 residents in our building. But our pay rate is only $10,000. Difference is our costs for payroll. And it is not sustainable. So, and I know in some of the agency testimony, that they talked to, basically that all agencies do the same things. And if there are not regulations or guidelines in place, agencies are not going to follow specific procedures. We had one agency specifically tell us that they will not educate their staff because that would make them an employee and it would cause them to have a lot more costs in having them work for them. So that we are responsible for providing all of the training for them. And they aren't our employee. And so it's just very difficult. So this is and will continue to be especially critical for rural areas of the state because of the limited availability of staff, coupled with the number of staff members leaving the caregiving profession because of the increased workload, requirements, and stress of the work. We are nearing a breaking point for many facilities. I appreciate the opportunity to share some insights with you from within a functioning campus, and I would be open to questions as time allows. Thank you.
Dawn, thank you for your testimony. And if you wouldn't mind, go ahead and stand at the podium. We'll kind of do questions a little different this time, hopefully to be more less time consuming. But if you'll just stand there, I just want to make one announcement to the committee, just to remind them there is written only testimony in your packets by Toby Mallara, Vice President of Government Relations, American Staffing Association. So committee, what I think I'll do is we'll start with, since Dawn's already at the podium, if anybody has a question for Dawn, we'll take those now, and then we'll go back through the order that they testified in. And if you have a question, they can come up. If not, we'll move to the next one. So Dawn, I do have, me personally, a couple questions for you, if you don't mind. In your testimony, you have, I guess it's anecdotal, but a agency nurse aide or person where they had 5 agency staff come to work for them, but not one of them showed up. So I've got a question. So were you guys told, or this person, were they told you have 5 people, they're coming, you have a contract on it, they're coming, but then later?
Yes.
Okay.
I talked to the administrator the day that it happened. He said, yeah, today we had 5 people who were scheduled and they didn't show up. And later they found out that they got paid more to go to another building.
Okay. I'm curious on the other part of your testimony. You had that something about they wouldn't do training because then they would be considered an employee.
We had, it was a newer agency that had started. And so we asked about training because that was an interest of ours. And he said that we don't provide any training because then they would be defined as an employee and their costs would be higher because they would have to do more training and other things if they were an employee.
Does the nursing home or the facility that is contracted for that employee, who pays the unemployment tax?
I don't know if that's in our rate. That we pay them.
So
I don't know.
But does the nursing facility physically make a check out to the unemployment tax? Or does the?
Yes, we would.
You guys would pay the unemployment tax?
Yeah, I'm going to check on that for sure.
Because then that would make it your employee.
Uh-huh. Oh, no, so I think that, I'm sure the agency does. I'll check on that.
Okay, thank you.
For sure.
Representative Ballard.
Thank you. Actually, this is a question for you, but I can also move to Anthony Johnson and Haley as well. What is it that, all right, so if I get the problem, it's very competitive. Supply and demand.
Correct.
The top bidder gets the person. working 24 hours a day is not unusual for some people. Knowing all of this, was this going on before the pandemic?
I'll just say that before the pandemic, it really wasn't looked upon favorably if you worked for an agency. Generally, the staff who worked for agency at that time were people who could no longer find a job in your area because they had worked everywhere and could not keep a job there. And so then they were hired by the agency and may come into the same buildings where we all maybe terminated that employee. But with the pandemic, it has become okay to work for agencies. And I mean, to me, that's just the biggest difference with what's happened with the pandemic. And so it's...
So prior to that, one of the things that I understood is that a nurse could work 12 straight hours. You know, maybe they would do 3 shifts and that would be their full time, or they could get paid on different shifts. So that was acceptable, right? For them to just not work their traditional hours.
Yeah, I mean, you have different shifts and buildings, but really, I mean, 24 hours straight is not a normal. No, that would be in an emergency situation that my DON here has done that, but, you know, not very many people do that. So,
Okay, so I think for all three of you, my question would be, what is it that you want us to do legislatively?
There has to be some kind of cap put on the payment that are paid to these agencies. When Haley said, you know, the possibility of the percentage of facilities that will close, I know even with the vaccine mandate in place, it was estimated that at least 30% of facilities would close. You know, we are looking at going down to a census of maybe 50 to 60 in our building, you know, from 100. We have, 1 week we turned down 15 people coming to our building because we didn't have the staffing. And so then people have to go to other places. We had one gentleman that kept calling back, and we just said, we still don't have the staffing to be able to do it. So they had to go out of county because none of the facilities in the area could take them because of staffing issues.
All right, so put a cap on what agencies can charge.
I mean, in the states that have really put legislative or regulatory parameters on that, they have put a cap at 150% of the area wage, average wage. And so like in different areas of the state, they would have different wage rates for people in different areas of the state. I will just tell you, you know, our RNs in our building, you know, an average, I mean, pay would be from $25 to $30 an hour. We just got the latest update from one staffing agency that an RN wage is $67 an hour. So if they are working overtime, which, as they said, even if they worked 40 hours somewhere else, they come to us, we're the ones paying the overtime, so we're paying $100 an hour for that person to come. You know, holidays coming up. So on Christmas Eve and Christmas Day, those are both considered holidays for them. So it's going to be time and a half that we're going to pay for any agency people. But that nurse rate for an RN was 67, LPN 51, CMA 34, and a CNA 31 from that agency. We have... most of them now it's over $60 an hour for an RN.
Wow. Thank you, Mr. Chairman. This is, oh, my goodness.
Representative Lynn.
Thank you, Mr. Chair. I'm not sure if you're able to answer this, but I'm curious if you know if the RNs or the other workers are able to work at multiple staffing agencies at one time?
As far as I know. I don't know.
I'm wondering if they are required to stay full-time with them, expected hours, or if they can kind of go in between and kind of pick the job.
You know, I mean, for us, we request the same staff person. And if we know ahead, we can contact with them for a month at a time so that we know it's the same person coming all the time.
Okay, because it was mentioned that when people didn't show up, it was because they were paid better at another location. I didn't know if that was that person's choice or if that was the staffing agency's choice.
It would be the staffing agency's choice.
Okay, thank you.
That if, as they said, each place you have a different contract with them, you know, for the wage rate.
Senator Petty.
Thank you, Mr. Chairman. I'm trying to. This is not from your testimony, so I think I want to ask a question of Haley.
Haley. Okay. You want to come up? I'll just sit up here. I'll sit up here.
Sorry, I didn't know if you wanted me to come up for my turn or wanted to wait for Dawn. So
I think Senator Petty was the last one for Dawn, so I didn't see any others, so we're okay to go to you.
Okay.
So.
That was just that's the whole topic. On your testimony, you put down invoke stricter regulations and oversight of agencies that hold them accountable and to the same standard as the environments that they serve. Could you expand a little bit on that?
Absolutely, I'd be happy to. There are so many things that we, as the facilities, are required to keep record of to make sure that we enforce, such as the training standards. We have 12 different disciplines that we are required as part of the individual's licensure upkeep, so to speak, that shows that they've received this training. It counts towards the CEUs that then keep their license up. That's something that we have to provide when we have a survey. We are required to show proof of TB skin test, of vaccination records, as that will come up, proof of training, as I believe Dawn had mentioned. If we have a allegation of abuse, neglect, exploitation, medication error, so to speak, we're required as part of our investigation that we turn into the state when we self-report that person has had competency, has had the training in it, if an error occurred, how we re-educated them, multiple things of those. We really like to see that the requirements that we, the building, have to follow regulatory, that they're also held accountable to the same. Because the best example I can give is if we had an agency nurse make a medication error. At the end of the shift, that nurse walks out. The best that we can do is call that agency and say, I do not want that person back in my building. Don't ever send them to me again. That's the best I can do. And it's after the fact. Now, if that were in our building, when we get surveyed, or if we're a facility that calls it in like we're supposed to and self-reports the medication error, it comes back on us. The surveyors will come, they will investigate, they will say the building was negligent in this. We accept the accountability. At the end of the day, it's us. So even though that was one of their staff that we contracted in, the responsibility falls to us.
As a follow-up, so I understand that, but like you said, it is your facility.
Mm-hmm.
And so you're not being, or the different facilities are not being forced to contract with any agencies. They're making decisions about what agencies they're contracting with. Is this correct?
Yes and no. I would say yes. I mean, at the end of the day, yes, we have the authorization of who we contract with, who we sign and contract with. And I say no because we don't have any other choice. We have to provide the staffing. So it's kind of a best case scenario of either work the people that we have to the bone and they leave, or provide what supplemental assistance we can with a staffing agency, and quite honestly, do the best that we can. I know COVID seems to be the amplified excuse for a lot of things, but a lot of the times this isn't even COVID. Does COVID make it worse? Absolutely, because when our staff test COVID positive, we have a very short time to fill that need in.
You did say during your testimony, though, when you were referring back to COVID, you did say that prior to the pandemic, that the different locations were hardly using any outside staffing.
Yes.
So, and I think I heard that overwhelmingly from both. So definitely it is pandemic related. This issue and the severity of it seems to be pandemic driven.
Yes, I would agree with that.
And, but I did want to ask, because this has been brought up in a couple times, talking about abuse and neglect. And so I was wondering how many issues of abuse and neglect have involved agency hires.
I like to give facts and figures. I don't have the exact number. I would be happy to go back through our association and provide that and coordinate with KDADs through the A&E hotline for that information. The best answer I can give you is that yes, it has occurred.
But has that also occurred from employees within the organization themselves?
Absolutely. I think it would be counterintuitive to try and imply otherwise.
Yeah,
no one's
yeah.
perfect. You're going to have instances.
And then it's been brought up about the agency hire not showing up. But what happens when your own employee doesn't show up?
So I appreciate you bringing that up, because I kind of wanted to counter that back to answer both of you. Prior to the pandemic, you had asked the question about nurses working 24 hours. I will say, in my experience, that was once in a blue moon that we would have staff do that, because a lot of the times we knew that it was on us to, pre-plan, figure something out. Our staff were respectable enough that they would communicate prior to, not maybe an hour before the shift when you're expecting someone to leave, that, hey, I'm not feeling well, I'm not going to be able to come, I'm calling off. Let's make plans otherwise. In rare instances, a lot of the times, as she knows all too well, it falls back on the director of nursing, and they would come work as a CNA, work as a med aide, whatever the need be. But what we run into now is a short notice, no notice, where when our directors of nursing or scheduling coordinators do the schedule and they say, okay, this agency A has agreed to work this space, mark it off, it's filled. Agency B has done this, mark it off, it's filled. As in Dawn's example, 5 different agencies or 5 different positions were allotted for. Our regular staff, great, I get a break. I can go home, I can breathe, I can relax. When they don't show up, that if the agency nurse does not show up, the off-going nurse cannot leave. Legally, that's abandonment. So that's where you run into instances where you have nurses working 24 hours. It's no call, no show, and no accountability on the agency staffing.
But the no-show issue could go both ways. I mean, you could have your own employee not show up, and they maybe, I mean, I'm sure that the expectation is that they give advance notice, but we know that doesn't occur. So this instance, it could have happened either way. It's just been exacerbated in this period of time that we've been in with pandemics.
Yes, and each facility is going to have a totally different policy. I know our policy would have been a no-call, no-show is grounds for termination.
Thank you.
We do have a question from Senator Stephan online, and then we have Representative Lynn and Senator Gossage. Senator Stephan?
Thank you, Chairman Hildebrand. Can you hear me today?
We can.
Well, my question would be for any as a physician, as an anesthesiologist, I've had the opportunity for the last 35 years, day after day, to sit elbow to elbow with nurses, and nobody has got to understand the mind of a nurse like I have through the years. And they are unquestionably some of the finest people in the world and the most dedicated, like y'all were saying earlier. I'm also have been aware of agencies and agency staffing for decades, and it's very, very interesting for me to hear the discussion today and the way the agencies are being vilified, and that's fair enough. But I guess, and I could talk about this for hours upon hours, and I'll spare you all that misery. But I guess the question I would have is, it appears to me, and I may be mistaken, that you all have kind of chosen the lowly wage earner to throttle their one time in history within your business plan to make a better living, and to seek legislation to limit their pay, while it really seems to me like maybe it's the fact that you all are subject to the whims and regulations of the federal government, the CMS. Would your efforts not be better served to go after the CMS side of this rather than pursue lowering the pay of the CNA or the nurse? Thank you.
Haley?
I'm going to attempt my best to try and answer that. If you would like to fly me there, I will gladly take the battle there. However, our best efforts are within our state. We're trying to do the best that we can. Is there national regulatory issues that make this more difficult for us? Absolutely. Absolutely. At the end of the day, though, I think it's a both and situation, in all honesty. Yes, I think there's regulatory requirements that are issues. I think there's state requirements that are issues. And I do believe that there should be caps and expectations that help us devote time, energy, effort, and money back to the direct patient care that we are there to provide.
Representative Lynn.
Thank you, Mr. Chair. In your table that you have talking about the hourly rates, the average agency hourly rate, is that the rate that the facilities are being charged, or is that the rate that is actually paid to the employee?
No, that is the rate that we are being charged. We do not get to see without asking the individual what they're making. That is the rate without COVID in our building. If COVID's in our building, it's an even higher rate. It's normally 1.5 times that rate as a clause of that. I know in conversations with CNAs, this is the best example I could give you, they are really only getting, I would say, of that rate of 13, they're probably getting 1.5 times that rate, is what my experience has been when a staffing agency, CNA, would disclose that.
And if I may, do you tend to find that your employees that you hire directly have a better working relationship with you than maybe the employees from the staffing agencies?
Absolutely. I think there's a higher level of trust, of camaraderie, of a family built. As Dawn said, she was very eloquent in that we try to build our staff, our communities, our families, where it's the same consistent people providing that care, because then they know the people rather than coming in. It takes, this is again my personal opinion, it takes the human element out of it. Because when an agency comes in, they're there to do the job, clock in, clock out. I completed the task, I checked all the boxes, I'm gone. When you have a member that you can actually hire in, there's a better accountability. They can go back and actually build relationship and create that trust over and over again. Yes.
Thank you. Thank you, Mr. Chair.
Senator Gossage.
Thank you, Mr. Chair. Thank you for being here. I think the crux of this problem that we're hearing comes at the bottom of your first page of testimony, which is private pay percentage was closer to 50-50, and that helped offset the reimbursement rates. But now you have 70%. of people that are in your facilities that are on Medicaid. We all know that when these government programs were originally designed, it was there'll be a very small part of that so you can accept lower reimbursement and make up the difference from the private payers. We're finding as more and more people get on these government programs, there's just no real way to make up the difference. And my other question, if I may, Mr. Chair, is on the second page, which is when you're talking about average hourly rate, and you're talking about the agency's hourly rate, that's kind of apples and oranges. And the reason is that in addition to your hourly rate, if you have someone that's a full-time staff member, they would also be receiving benefits. You'd have to pay liability insurance for them, unemployment insurance, FICA FUTA SUTA on their taxes, on their payroll. So an individual is worth far more to the company or costs the company far more than just their hourly rate. Do you have any idea what the average then rate would be for these categories if you were to take all of this? In other words, the full compensation dollar per employee.
The best I could give you is a guesstimate, and I don't like to go off of guesses. I would much rather follow up with the committee to provide that information, because I'd be glad to. I've done payroll in my building. I know exactly the preciseness of what you're asking.
Thank you very much. Thank you, Mr. Chair.
I will make one follow-up comment to this too, that, and again, this is in my experience and several colleagues' experiences, we are finding in healthcare less and less people that are wanting to work for benefits. The days of, medical issues, needing to get on group insurance so that there's no pre-existing conditions, we're finding that less and less. Just comment.
Representative Ballard.
Thank you. I have a question for Anthony Johnson.
I do apologize. I think I fell asleep behind the mic. Senator Erickson was next. I apologize, Haley.
Thank you, Mr. Chair.
My vice chair wasn't doing her job and reminding me.
Well, it looked as if she was trying to deny me an opportunity to ask a question, so I appreciate that, Mr. Chair. Thank you very much. So, thank you, Haley, and I apologize. We've had a lot of information. If this has been shared, but do you have any idea how much Kansas facilities received in provider relief funds?
I don't know the total allotment, and I think it was individualized each building. I do know that there was some financial, there was some other, I don't know if there's knowledge over here of that, but I do know that there was some other state programs that, provided like personal protective equipment and things like that. Again, I'd have to go back to find the exact numbers. I don't believe I have that in here.
Okay, thank you.
Okay.
Thank you, Mr. Chair.
Representative Ballard.
Thank you. No, I'm fine. I just want him.
Yes.
Okay.
I just want to follow up on the last statement that you. Thank you, sir. Thank you, Mr. Chair. The last statement that you said toward me and the chair, and then it went on to another person. I wanted to follow up with that. So are you saying that you do or do not offer medical insurance in your facilities for the employees?
Most of us do.
Most do. Okay.
However, the majority seem to not. That doesn't seem to be an incentive as it used to even 10 years ago.
Thank you. Thank you, Mr. Chair.
She's waiting to see.
Do we have any more follow-ups for Haley? Okay. As we regain control again, let's go back to Representative Ballard.
Thank you, Mr. Chairman. All right. So when we look at this, there's lots of reasons, but the main reason is there's a shortage of nurses. All right, so when we look at that, for whatever reason, whether they don't want to work anymore, they're scared of getting the pandemic, they don't want to take it home, there's lots and lots of reasons, okay? But you did mention something about development of grants. So if we know we have fewer individuals working, and we hear everybody talk about work shortage, everybody wants the same people for what they can do. You talked about development of grants, but what else do you think we can do besides being annoyed with contract and who doesn't show up or whatever. What is it that we really can do? I mean, I don't see myself as a legislator, even though I would probably I would vote to try to do something along those lines. But what else can we do to have enough people to take care of people that are in the facilities? Those people are other people's loved ones. If I was in Kansas and my mother was living today, and I heard you talk like this, I would be in fear that I would have to put my mother in a place like this. Not because it's a terrible place, but wouldn't be people to take care properly of her. What else do you think we can do besides putting a regulation on somebody that they must do something?
Certainly in the healthcare profession, some of the scariness that I discussed isn't limited to post-acute facilities. Hospitals are struggling as well. In addition to grants, this isn't a quick hit by any means, but it's a very noble profession to be a caregiver. I think some of the stories that me and my colleagues discussed today, those who remain in our buildings, and there are some good people in agencies, they're not all bad. A lot of people are in it for the right reasons. And it's a career path. Like I said earlier, I'm a CNA. That's how I cut my teeth in long-term care. If somebody chooses and has the passion to grow and advance their skill set, there's opportunity for that. So maybe a public relations campaign to promote people entering the sector of long-term care. Other ideas that come to mind, this is a fantastic question, by the way. Other than monetary incentives and PR campaigns, with the grants, loan forgiveness, which we do. We do tuition reimbursement as providers. We don't always pay the entire bill, but we help offset that. We help people advance themselves through that program as well. I don't know. Maybe we could talk to the Red Cross and see if they have any ideas to help us as well. I think it's going to have to be a collective effort to identify. It's very complex. If I had the magic bullet, I probably wouldn't be talking to you today.
I thank you very much for that. And when I said, my mom's not living, but when I have a family or friends want to know what to do or how can they find or is there a place for their grandmother who has Alzheimer's, I do feel a personal responsibility, as I think everyone on this committee does, that it is our job to try and help them or represent them, or we shouldn't have been knocking on doors. And when I look at this and think, what is it that we really can do? We know the problem is everywhere. Representative Landwehr and I talked about it. It's nationwide. But I'm not responsible for the whole nation. I'm responsible for Kansas right now. Mm-hmm. And it is a terrible place to be when you can't help your constituents because everyone is after the same few people.
Mm-hmm. I share those sentiments. My gray hair and losing hair is due to the powerlessness I feel every week. I wish I could do more. I'm with you.
I wish we could help you, and we'll do what we can. Thank you so very much.
Thank you.
Senator Erickson.
Thank you, Mr. Chair. I'm sitting here and listening to the conversation, and what is happening, I agree with Representative Ballard. It's about the care of the people who need your services. My question is, as I look at statistics From 2010 to 2020, CEOs in healthcare's salary rose by an average of 17%. That's higher than the 5% in all other industries. And taking the emotion out of what you guys are experiencing, what if we capped CEO salaries? What if we capped, I know Representative Ballard, we put my father in a nursing home back in 2007, and we paid out of our pocket $5,000 a month for his care, in part for what Senator Gossage said about, you know, someone has to make up that 30% that you don't get for your reimbursement rates. Lived it, been there. People still do today. What if we capped what you could charge the private payer? When we start capping, where does it stop? And I understand the problem you're dealing with, but I'm struggling a bit with that. So if you have some thoughts around that, I would appreciate that. Thank you, Mr. Chair.
I do have some thoughts on that. In my opinion, I'm going to start with the private pay cap. And one of the solutions is right now, charge more to private pay. To me, that's just getting the money sooner to most private pay people. Let me explain in more detail. Say I'm worth $100,000 and I'm paying privately, and the rate is $5,000 a month. So that would go for about 20 months, just under 2 years. We raise the cost theoretically to $10,000. The money lasts 10 months instead of 20, and then they go on public assistance. I don't see putting the burden on our private pay customers as a viable solution. It just accelerates the process to getting on other sources of payment. In the second part of your question of capping CEOs or any other executives, if there was extortion going on between companies and not having leadership in those companies to deliver the care, I guess I'll speak for myself and not my association, but it'd be something we'd be willing to entertain if that was the root cause of the problem.
I would just say I would be cautious to want any government body interfering in that process. Thank you, Mr. Chairman.
Can I say one more thing?
We're getting ready to move for, apologize. No. Committee, do we have any further questions? Senator Gossage.
Thank you. Is he still on? Okay. First of all, it says down here at the bottom of page 1 of your testimony that only about 1% to 2% of all nurses work for the staffing agencies. So I find that to be interesting, and just thought I would point that out to some of the things that we're discussing. Also, you have only a fraction of the nurse workforce work only for the agencies. So you may have some that work for the agencies, but some of these nurses have full-time jobs, but they choose to bridge the gap in their income to work at someplace else where their nursing skills would be put into place to help supplement their income. Am I reading that appropriately, sir?
Yes, and I thank you for bringing that out. You know, 70% of the staff that we have in our agencies is working full-time somewhere else. So they're actually your nurses somewhere else. Then they can't work overtime for you because you typically don't want to pay overtime. So they'll go to work at another place, not being paid overtime, but being paid a higher rate to go work as an agency nurse to make up that gap. But I know it feels like there's a ton of state staffing nurses out there that are in agencies, but they're simply not true. The number and the percentage is much, much lower than I think people give credit for it. Now, in this particular period of COVID. And in this pandemic, what's happened is there's been such a number of reduced nurses who won't work because they're afraid of the pandemic, or they've just got burned out and they've decided not to work. That percentage of nurses that are working who will work, but only work for higher rates, and only will work if they get paid higher rates, is a higher percentage. So it feels like we have a lot more agency nurses during this period of time. I'd just like to comment on the rates also. When you talked about, a nurse rate of $75 or $80, that nurse is getting paid probably $55 or $60. That nurse is not getting $25. If you're going to see being paid, you're paying $40. That CNA is getting paid at least $30. So when we think they're getting paid $15 because that's what you pay, they won't come to work for us unless they're going to get paid $30. And they're being offered that opportunity by multiple agencies. And that's the phenomenon here of people thinking that staffing agencies are just pocketing all this and we're not paying nurses because there's a huge shortage. I think you also mentioned earlier, some of the things that we could do. This is a nationwide problem in hospitals as much as it is in healthcare, in long-term care facilities. As you know, it's a major problem. The shortage is tens of thousands of CNAs that were short right before the pandemic, probably close to 100,000 CNAs short across the United States right now that would be. So what does need to be done is incentive to pay higher wages to CNAs. Everybody pays higher wages to the CNAs to encourage more people to come in. The only way to work is if you're able to bill more. And the only way you're able to bill more is if you're able to raise your rate. However you do that. And thank you for your question. I'll stop there and take that.
So do you also, because obviously you work with some of the long-term care facilities, as we've heard, do you also contract with hospitals?
Yes.
And other,
Absolutely.
okay.
Yes, but they're typically different kinds of nurses. Of course, hospitals don't use CNAs very much. They will use some LPNs. And even nurses prefer to work in either long-term care or hospitals. They typically are different mentality and prefer continuous care with patients in long-term where they like the continuity. And other nurses like the hospital because it's just a kind of do the work and then move on to the next patient. And they typically get paid a little more to work in a hospital setting. I do want to clarify a question that was asked earlier. Yes, typically a staffing person that works for an agency will usually work for multiple agencies. They could be working for 5 different agencies and getting 4 or 5 different calls. And I also want to clarify one of the points that was made about one of the persons that said that they wouldn't do the training because they wouldn't be an employee. If your agency tells you that they're not the employer, stop using that agency. That means they're not paying workers' comp, they're not paying professional liability. All that exposure is on you as an administrator. There are no staffing agencies in this industry who do not operate as an employer. If they do, they're doing it improperly. The other thing is you talked about standardization. You should only use staffing agencies that are JCAHO certified. That means that all of the standards that you were looking for, and you mentioned earlier that you'd like to have all the tests are done, all the information you have. Well, JCAHO requires staffing agencies to do all that. And so all you have is your staffing agency is certified, and they know that all of that is taken care of. Thank you for more time.
And if I may, 2 more follow-ups. This is, I'd like for you to address a couple of things that were mentioned that are kind of troubling. One was they said, or it was said earlier, that if somebody worked for you for 10 hours and worked over here for 10 hours, and then you end up getting them for the 5 hours, you're paying the overtime. Could you address that? Because that absolutely doesn't seem fair.
No, it isn't right. And these are examples of either an agency that is taking advantage of you or is simply saying to you, look, I only have 1 nurse left, and that nurse has already worked 40 hours for me. I can't give her to you unless I have to pay her overtime. So if you're willing to take her and pay overtime, that's the only way I can provide her, and then you have the choice. But to tell you that I'm going to always charge you overtime or have to charge you overtime would only be because you chose to take the nurse. That's not the way it's supposed to work at all. And no, that's not common. That's some agency that simply takes advantage or gives the option of working somebody more than 40 hours.
Thank you. And the last one is, we've heard about contracted nurses just not showing up. Maybe they got a better offer with another agency in which they're employed. But you say that about 15 to 20% of the shifts that are filled with the ready-to-go, your quotes, caregivers, get canceled by the client before they start.
Yeah.
Can you address
And
that?
Yeah, that is the norm of our industry. We're expected to help fill jobs that come open at the last minute, or even if you plan ahead a week or so, or even a month or so, we want to make sure that we have the nurses there for you. However, things change. You might have thought you needed 4 nurses for the weekend or 3 nurses for the weekend, and you only need 2. Well, we've got 4 ready. You only needed 2, so we get canceled 2 of the nurses. That's part of our industry, and we understand and we accept that. It's part of what we'd like to, we work with our clients to have them do as little of that as possible. But it happens. And likewise, we have nurses that are supposed to be going to a shift and, their car breaks down or they simply don't show up and, they just don't do the work we do, which we typically means they're fired from the agency. No shows. In the case of many agencies, the agency charges the nurse for a no-show. Now, we haven't yet seen very much where the nurse gets, where the client gets paid for that no-show. That hasn't become the norm, but I wouldn't be surprised if any higher demand and less supply issue, that wouldn't be the case. In other words, right now, the real crux of this issue is that we are simply, it's like construction work right now. There aren't enough construction workers. That's why buildings are taking long. That's why homes are taking longer to be built. There aren't enough chips. That's why automobiles aren't being manufactured. There aren't enough CNAs, period, and there aren't enough nurses, period. And that's really what the issue is. We need to find ways to attract more nurses into the profession, and it starts with higher wages.
Thank you very much. Thank you, Mr. Chair.
Thank you very much.
Committee, I do not see any further questions, so we will now move to our next topic. We will have a presentation on the Kansas Perinatal Behavioral Health Access Program. And with us, I believe virtually, is Lindsay Galindo. Lindsay, are you with us?
I am. Good afternoon. Thank you, Mr. Chairman and members of the committee for having us today. So my name is Lindsay Galindo. I'm a research project manager at KU's Center for Public Partnerships and Research, and I'm joined today by Dr. Melissa Hoffman, psychiatric mental health nurse practitioner, president of Postpartum Support International Kansas, and expert consultant for the Kansas Statewide Perinatal Behavioral Health Access Program, Kansas Connecting Communities, or KCC for short. KCC is a 5-year project funded by the Health Resources Services Administration and directed by KDHE's Bureau of Family Health. And KCC aims to improve the mental health and well-being of pregnant and postpartum women through provider training, technical assistance, and consultation focused on increasing screening, timely assessment, effective referrals, and reducing barriers to accessing treatment. We want to thank you for the opportunity to speak about our work today, and I'll begin by handing it over to Dr. Hoffman to provide an introduction and share some information about the need for this program.
Thank you, Lindsay. Thank you, Mr. Chairman and committee members, for your time today and for this opportunity to speak to you about a topic that is dear to my heart, both professionally and personally. As Lindsay said, I'm a board-certified psychiatric nurse practitioner. I'm currently integrated in an OBGYN clinic where I provide reproductive psychiatric care across the lifespan with a particular emphasis in perinatal mental health. In addition to that, Lindsay mentioned I'm the current president of the Kansas chapter of Postpartum Support International, or PSI for short. I also have volunteered as a state support coordinator through this organization for the last 15 years. And I also founded a local peer support network called Build Your Village, where I facilitate a weekly perinatal mood support group. It is my hope that through all of these viewpoints I share with you today, some information about not only the prevalence, but the impact of perinatal mood and anxiety disorders on women and families in Kansas. Before I start, I just want to clarify that for the purposes of the presentation today, perinatal will refer to pregnancy and the first year after birth. And the term perinatal mood and anxiety disorders is sort of an umbrella term that encompasses several mood or anxiety disorders that can occur in pregnancy or the first postpartum year. It is not solely limited to the one that we hear most often, postpartum depression. Important, the reason we're here today is that perinatal behavioral health disorders are the most common complication of pregnancy and childbirth. An estimated 1 in 5 women will experience a mood complication in the first year, in pregnancy or the first year postpartum. For women who are diagnosed with a mood complication, approximately 30% will enter into pregnancy with a pre-existing mental health condition. About 30% will develop that in pregnancy, and about 40% will develop that or have the onset in the postpartum period. Important to note that 38% of women who are also people of color will experience a perinatal mood complication. So we do the math there, and we know that's about twice the rate of white women. As you can see from the statistics here on the slide, the Kansas PRAMS data is in keeping with the national data, and that's why we're here today. Of note also is that we want to consider perinatal substance use disorders as well as mental health disorders. These two things often occur comorbidly, and therefore we really need to consider both when assessing and treating the mother. And in addition, we really want to consider treatment that is sensitive to this critical time for the mother-child dyad. Can go on to the next slide. So as you can see here, again, this is a common problem, not only for the state of Kansas, but nationally. We know that sadly, mental health conditions can lead to increased maternal mortality, both by adversely affecting a woman's physical health, but then also more directly by maternal suicide. A recent study out of the University of Michigan and the University of California followed about 1 million moms postpartum through the whole first postpartum year, and overdoses and suicide were the second leading cause of death following obstetric-related causes. Interestingly, out of those suicides, they were most likely to occur in the later postpartum period, so between day 43 and day 365. And for the overdoses, those were more likely to occur in the 6 to 12 month postpartum period. So as we think about that, that really exemplifies the need for continued support of a woman and her family throughout the full postpartum year. Additionally, as we work to address maternal mortality in our state, it's important to note that mental health conditions contributed to approximately 1 in 5 of Kansas's pregnancy-associated deaths between 2016 and 2018. In thinking about the impact that maternal mental health has on a woman, those things can be a little bit more obvious, but the impact really extends to that of the whole family system. Maternal depression affects the mother and child and really poses significant risk to development of the child, both in utero as well as after birth. The effects of a woman's ability to care for herself, let alone her child, are greatly impacted when there's a mental health condition involved. Perinatal mood and anxiety disorders are associated with adverse complications in pregnancy as well as postpartum. So in pregnancy, we have increased risk of poor health consequences for the mother and child, including delayed fetal development, prematurity and low birth weight, increased rates of perinatal complications such as preeclampsia, placental abnormalities, and spontaneous abortion. The negative impact then extends beyond pregnancy into that first year with an increased incidence of difficulty breastfeeding, leading to early cessation of breastfeeding, impaired maternal and neonatal bonding, increased risk of unsafe parenting practices, such as unsafe sleep practices, and then psychosocial, developmental, and behavioral impairment in the offspring. There's also an increased risk of paternal depression. When one partner is suffering, it's about 50% more likely that the partner will also develop a mood complication. Additionally, we can think about the impact on society as a whole. Societal cost of untreated perinatal mood and anxiety disorders is approximately $32,000 per mother-child pair from pregnancy through 5 years, with more than half of those costs occurring in the first postpartum year. So when we think about treatment, unfortunately, what data tells us is that, unfortunately, when a woman is diagnosed with a perinatal mental health complication, rarely does she receive the treatment that she needs or that is adequate. The national data will tell us that about 15% of women diagnosed with postpartum depression will receive treatment, with even less of those, approximately 6%, receiving what is considered adequate treatment, and only 3% receiving remission of symptoms. The Kansas PRAMS data, again, as you can see here, revealed data that was pretty consistent with that. 13.8% of Kansas mothers felt that they needed treatment for a mental health condition, but did not receive it. Common reasons that were cited are listed here, and this is probably to be expected. The largest being it seemed too difficult or overwhelming, that they did not have time because of childcare barriers or time that they couldn't take off of work or other commitments. And then lastly, that they were worried about the cost or that they could not afford it. Of note there is that 14.7% of the mothers reported that they were uninsured after the birth of their child. So the barriers to treatment are many. Barriers not only are barriers, patient barriers, but also provider barriers and system level barriers that exist. Provider education is one of the greatest ones. Oftentimes frontline provider trainings, those people who are not training, excuse me, frontline providers lack the training to treat and screen for perinatal mental health complications. These are the providers that are interacting most with women in the perinatal period, whether those be OBGYN providers, certified nurse midwives included, APRNs, family practice providers. Workflow and screening, obviously this takes a coordinated effort, if you will, to identify and then subsequently treat or refer to treatment. And clinics need an effective workflow in order for that to happen. In addition, this really requires that all clinic staff that are interacting with the women and families receive education and training in order to provide that compassionate and sensitive and effective care for women who are experiencing a mood disorder. Access to psychiatric treatment, and I don't think this is a new idea for any of us. Obviously, psychiatric providers are limited. Kansas does not have sufficient psychiatric providers, let alone reproductive psychiatric providers, to serve this population in need. In addition, many women lack access to care for various reasons, whether it be transportation or distance. Many women also lose coverage at that 60-day postpartum, And so it's really not uncommon for a woman to be assessed and identified either at risk or in need of psychiatric care at her 6-week postpartum visit, only then to lose her coverage that very same month. Additionally, just in our state, we know that the rural and frontier areas are also lacking psychiatric resources as well as other parent support resources. Distance is often a big barrier to receiving care. And then thankfully, telehealth has paved some new avenues for that. However, many women still do lack that reliable internet connection in order to make that happen. I think that is the end of that. I think I covered it all. So before I end, I just want to end with a quote from Dr. Cheryl Totano Beck, who was one of the pioneers really of perinatal mental health. She once said that a striking characteristic of postpartum depression is how covertly it is suffered. So I urge you to consider that and consider perinatal mental health complications in that they know no boundaries. This is a complication that impacts women in all of our lives. It's a complication that can occur regardless of a woman's support system, her socioeconomic status, her education level. However, we also do know that risk factors such as low socioeconomic status, adverse life events, poor social support, Medicaid status do increase a woman's risk for developing a perinatal mood or anxiety disorder. So I will now hand it over to Lindsay to talk to you all about the impactful work that KCC is doing.
Thanks so much, Melissa. So integrating behavioral health care into ongoing care that women receive during pregnancy and postpartum is really critical to ensuring that needs are identified and responded to. And KCC was really designed to fill this gap by building the capacity of the frontline providers that Mel spoke about to identify both perinatal mental health and substance use disorders and intervene effectively. So KCC provides support and education that's targeted specifically at frontline providers working with perinatal patients. This includes healthcare providers, as well as public health professionals and family support professionals like home visitors. Our work includes provider training, technical assistance, and resources to ensure that frontline providers are well equipped to screen and effectively respond, as well as same-day access to provider psychiatric consultation and care coordination support. Over the last 3 years, KCC has worked to develop and provide training and technical assistance aimed at building foundational knowledge of perinatal behavioral health disorders, implementing universal screening practices to increase identification, and responding to identified needs through brief interventions, referrals to treatment services, and pharmacologic management. More than 500 frontline providers across the state and more than 50% of Kansas counties have participated in a variety of KCC training activities, and trained providers report to us increased confidence screening, conducting those brief interventions, referring and treating for perinatal depression, anxiety, and substance use, as well as increased knowledge of best practices and available resources and increased screening rates during the perinatal period. The map here shows the location of providers who've received training to date through KCC. And since beginning this work, we really continue to hear providers express a need for this type of training to support their practice. Certainly, this map also demonstrates that there's still more work to be done to engage and educate both healthcare and public health professionals in all areas of our state to increase their self-efficacy, responding, the screening rates, and knowledge of available resources. The other main support that we've mentioned a little bit that we offer providers is provider-to-provider psychiatric consultation and care coordination support. These services are provided through a perinatal access line known as the Provider Consultation Line for Perinatal Behavioral Health, which was established to provide any Kansas provider with direct real-time access to expert support in identifying and treating perinatal behavioral health disorders. When providers call the line, they speak with a dually licensed social worker and addictions counselor with expertise in the perinatal period to really help them to support any resource and referral needs they may have for their patients. And then their calls can also be triaged to a psychiatric provider. In October of this year, we onboarded a peripartum psychiatrist located at the University of Kansas Health System to really expand access to this expert treatment-related consultations. And you'll see some examples here on the slide of requests that have been received by the line. For example, a family physician treating a pregnant patient with severe panic attacks, a social worker struggling to locate counseling services for a Spanish-speaking patient without insurance, and a certified nurse midwife seeking consultation for a pregnant patient with suicidal ideation. The consultation line really allows these providers to receive the support and resources they need to respond immediately and effectively to their patients' behavioral health needs. Similar to the Kansas Kids Map grant that you heard about this morning, KCC is a HRSA-funded grant led by KDHE, and funding is set to end in September of 2023. Significant efforts have been made to integrate the training, TA, and resources within existing provider networks to really increase impact and support sustainability. However, we know that the identification and treatment of perinatal behavioral health disorders is complex, and that dedicated funding will be required to continue training activities, TA, and consultation services after the life of the grant. We'd like to close by acknowledging that the behavioral health needs during pregnancy and postpartum period are common, and that Kansas moms need our support. Continued care throughout the perinatal period is critical to ensuring that moms' needs are both identified and met, and providers really need support so that they can respond effectively. Supporting our frontline providers is really key to the outcomes that we all want: healthy moms, babies, and families. And we really appreciate the opportunity to share this work with you today. And with that, we're happy to answer questions. Thank you.
Okay. Lindsay and Melissa, thank you for your presentation. Senator Petty.
Thank you, and thank you for the presentation. You mentioned, I have a couple of questions, but you did mention towards the end about the funding, and prior to that, you'd mentioned the I guess I'll call it a hotline, that for consultation requests. So that hotline for the statewide consultation requests, would if your funding is not renewed, that would also go away. Is that correct?
That's correct. The consultation line is included within that full annual funding that's referenced there. Yep.
And then I'm just curious, as you know, one of the areas that's been looked at when it comes to perinatal behavioral health is an after-birth home visit. Has that been incorporated in your work at all?
That's a wonderful question. We certainly have worked to support training for home visitors that are providing those visits post-birth, and there certainly are some pilots happening across the state around that work. So yes, from a training and technical assistance perspective.
Do you have any numbers on areas of our state that are doing that on a regular, well, with every birth or with every Medicaid birth?
I don't, but that's definitely something we can look into and see if we can get those numbers, unless you might have that information, Dr. Hoffman.
I do not. We'd love to follow up with that, though.
Thank you, because I know that is an area that a number of hospitals are looking into, a great way to identify a need immediately. Thank you so much.
Senator Erickson.
Thank you, Mr. Chair, and thank you for this presentation. I see that, and I agree that moms and babies need care and support. do you also provide that support to the family unit as a whole, to the spouse, to the other children as they try to help mom and baby in this situation? Thank you, Mr. Chair.
I'd be happy to answer that. As part of our training, we are always discussing the impact on the whole family unit and how the whole family can be supported. So as I mentioned, screening for, or at least discussing the option or the possibility of a mental health complication in the partner, whether male or female, and also the impact that it has on the whole family unit. So again, getting back to what Lindsay just said, it's really those home health visitors, our parents as teachers, our parent support services, having education in how to talk about perinatal mood and anxiety disorders, how to talk about mental health in general. Therefore, when they are there providing that wonderful support that all families should receive, they also can be sure that they're addressing any mental health complications and assisting that family in getting additional services for that specific need.
Representative Reese.
This question, I think, is primarily for Lindsay. Is there work, any collaborative kind of work with the community mental health centers?
That's a great question. Yes, we have targeted some of the training that we provide specifically at community mental health centers and have been coordinating with executive leadership there around what that training looks like. That has been kind of a secondary component to working on the training of frontline providers that has been part of the training plan as well.
Mr. Chair, I have a second question, if you don't mind. And Lindsay, it's also to you. What about services that for families that would require interpreters or any kind of information that is needs to be translated into Spanish or any other languages?
That's a great question. Some of any of the patient-facing materials that we might provide through training or help providers provide can be translated. However, I think the primary way in which that need is met is through the consultation line and through our resource and referral specialists helping to find specific resources and services that meet the needs of patients. So for example, in the example I gave around a consultation line call for a patient whose primary language was Spanish and without insurance, our resource and referral specialist works to locate available services in that patient's language that could be provided. So that might look like in-person services, telehealth services, or it might even be peer support services that are in that patient's language. So really helping to do that legwork for providers behind the scenes to help meet that need.
Great, thank you.
Lindsay and Melissa, I do not see any further questions from anybody in the committee. So committee, we will now turn our attention to a presentation on adult dental benefits. And with us virtually is Dr. Marco Vucicicek. Marco, welcome to the committee.
Thank you, and pleasure to be here with you today. I'm joined by my colleague Chelsea Foss, and we're coming to you virtually from Chicago. We are part of the American Dental Association. We are researchers at the Health Policy Institute, and happy to spend a little time with you today presenting some new research. I'm going to go ahead and use a presentation, which hopefully you are seeing. Okay, that's great. What we're going to do today is present some new research to you that's pretty fresh. It's Kansas specific, and it is about estimating the cost of introducing comprehensive Medicaid adult dental benefits. Before getting into that, we do want to cover very briefly a little bit of the macro landscape. We want to tell you what the global national research says on how important adult dental benefits in Medicaid are to ensuring access to oral health care for low-income adults. And we'll give you a little bit of a landscape of how states are addressing this before moving into the meat of the presentation, which is, again, this new research that's estimating the fiscal impact in your state of introducing comprehensive adult dental benefits in Medicaid. As I mentioned, Chelsea and myself, we are researchers. I'm a PhD economist who's worked in healthcare. Chelsea, among other things, is a dentist and a health services researcher. We do different types of research for scholarly journals, stuff that's been picked up in the press, and increasingly we're doing more custom research for audiences like yourselves, state policymaker groups, legislative bodies that are looking to make evidence-informed decisions and to incorporate data into their policy. That's what we're about. So again, just a little bit of a landscape. I do want to share some stylized facts. On the screen, you're seeing a summary of data showing the percent of people that report barriers to dental care in the US, both of a financial nature, which is the red bars. You see the prevalence of financial barriers to dental care, which is things like I can't afford dental care, it's too expensive, I don't have health insurance and dental insurance, as well as non-financial barriers, which are in teal. Things like I don't have time, I can't find a provider, it's not a priority. The point of this chart is to just show and hammer home the fact that when we look at the reasons why people avoid dental care, overwhelmingly they relate to affordability. This is true for all ages. The second big conclusion I want you to take away from this chart is when we look at working age adults, that 19 to 64-year-old group, again, this is like that Medicaid eligible population if they're low income. But in terms of an age group, it's working age adults that tend to report financial barriers to dental care most. So again, very important thing here, affordability is the main reason people are saying they're avoiding needed dental care. Important to put dentistry into context. When we look at primary care, medical care, prescription drug services, mental health care, and we compare all these services and ask people, look, which of these are you most likely to avoid because of affordability? Again, for all age groups, dentistry is different. It tends to rank the highest. So again, in the context of other types of healthcare services, clearly dentistry seems to have the most severe affordability challenges. And once again, if we focus here on the middle group, it tends to be that working age population, not children and not seniors, but that working age population that is most likely to report avoiding needed dental care because of cost. So that's a second kind of stylized fact here, that cost barriers to dentistry are higher than for any other type of healthcare service. And lastly, now, when we finally put all this together, let's now look at different age groups, but now let's also look at the data by income level. So what this chart here is showing us, it's showing us 3 age groups, and within each age group, we're cutting the data by income level. So low income populations are in the red, middle income are in the teal, and higher income populations are in orange. Again, when we focus on that low income working age adult group, so that middle category of 19 to 64-year-olds, and the red bar, which is focused on those that are low income, i.e. that's like our Medicaid population. By far, that is the group that is most likely of anybody to report cost barriers to dental care. So that's a really, really important stylized fact, just to say it again. Of any age and income group, low-income adults, 19 to 64, face the most significant cost barriers to dental care. All right, all that's global evidence across the US. Let's look at now the landscape of adult dental benefits in Medicaid. This, of course, is a different policy approach than for children. Medicaid programs are required to cover comprehensive dental care for children as part of the EPSDT stipulations. For adults, it remains an optional benefit, and the current landscape is what you're seeing on the screen. I'll just focus on the blue states, which Kansas is a part of. It's one of 16 states that we and others have classified as providing a limited, so not a comprehensive, but some dental care coverage. There are, as you see there, 9 states that don't provide anything other than emergency care. There's also 21 states that provide what we call extensive or comprehensive coverage. So that's kind of where Kansas lies in the national landscape. And what we've done in my team is we've developed a model to estimate to the state budget folks what would happen if a state introduced comprehensive dental benefits in Medicaid. How many more adults would go to the dentist? What would the average spending level be? We also know, this is really important, especially in the context of the last presentation related to benefits for pregnant women. We do know, for example, that there are links between the mouth and the rest of the body. To an economist, I can tell you there's also compelling evidence showing that when you improve oral health, you do see reduced medical care spending in certain areas. So for example, among diabetics and people with heart disease and pregnant women, we know that there are what we call fiscal offsets. There are reductions in medical spending. We've reviewed all the evidence and the research, and we've incorporated those into the modeling. We also know that there are people going to emergency rooms in your state, all over the country as well, for dental care conditions. And we know that when states expand their Medicaid benefits to include comprehensive dental coverage for adults, we do know that emergency room visits for oral conditions fall. Anyway, not to bore you, we can go through this more if you're interested, but we have a lengthy methodology that's been part of the report that was provided to you. We review all the evidence, we put all the most reliable numbers together, and we come up with a model to help legislators say, okay, how much do we think this would actually cost for our budget? And we've done this in several states. I'm just showing you a screenshot here of some of the states we've done some in-depth work and presentations to with legislative groups like you. And today we're going to just summarize the results for KanCare. And what we're really pleased about, Chelsea and myself, is this was a great collaboration. We worked with key stakeholders in Kansas, the Oral Health Kansas, the Oral Health Coalition there. We were able to partner with the Division of Healthcare Finance to get some really narrow data that was required for modeling. And again, as I mentioned, we include the modeling of anticipated dental care spending that KanCare would incur by providing a dental benefit. We also model the potential anticipated reductions in healthcare spending in other areas outside of dentistry. We put all that together, and we also include the most recent data on basically the federal match for Medicaid funds versus the state. And this will be my last slide. To just summarize here, a couple things before diving into the numbers. We do a dynamic model, meaning that we have year 1 post-reform, year 2 post-reform, and year 3 post-reform numbers. There's obviously going to be a ramp up of people going to the dentist. It doesn't magically happen overnight that you're in a post-reform world. Once you introduce adult dental benefits, it does take some time for the population to learn about them, to start going, and then it takes some time for some of those medical care cost savings to start accruing. Again, we've looked at the research and the literature to determine what the best way is to model this. But in a nutshell, if we go, let's say, to the far right of this chart here, year 3, which is post-reform, steady state, let's call it, we anticipate that there'll be about $7.2 million in spending on dental care services. And we estimate that'll be offset by about 4.8 million in savings in medical care spending, including emergency room visits, spending among pregnant women, those with diabetes and cardiovascular disease as well that are in the Medicaid adult population. So that nets out to about a 2.4 million net fiscal hit in total. And then when we tease out which part of that is paid for by the federal government versus KanCare, we get an estimate of roughly $960,000 that KanCare, the Kansas Medicaid program, is anticipated to incur on an ongoing basis. And you see at the bottom, that's about 50 cents per adult enrollee per month in the Medicaid program. So I'm going to stop there. That's a quick overview of what we wanted to share. Again, this report's been shared, as well as, again, a very lengthy methodology for those that are interested. But again, we thought it's been very useful in other states. We're happy that we were able to work with the stakeholders in Kansas as well to kind of put some numbers behind this very important reform. So thank you.
Marco, thank you for your presentation. Committee, do we have any questions for Marco? Marco, I don't see any. Thank you.
Okay, thank
You
you.
did a job on your presentation. Committee, now we will turn our attention to presentation on the KanCare Meaningful Measures Collaborative. Sarah Ursick-Good, President and CEO for the Kansas Foundation for Medical Care. Sarah, welcome to the committee.
Perfect. And I think there are slides in PDF. I think I'll just tell you when to advance them if that's okay. The content is the same as what's in your PDF. So good afternoon. I know that I'm all that's standing between you and the end of this committee, so I promise I'm actually going to only take about less than 10 minutes, unless it's really compelling and you have lots of questions. But thank you for this opportunity to speak to you today, really about the work that the Meaningful Measures Collaborative, or KMMC, has been doing. So in addition to my role as CEO at KFMC, I also serve on the Data Resources Working Group and the Executive Committee for KMMC. So the work that we've been doing would not be possible without the efforts of our participating organizations, the state agencies that assist us, and individual stakeholders who contribute their expertise, their experiences, perspectives, and most importantly, their time. The group is also facilitated by the Kansas Health Institute, and they provide a tremendous amount of work supporting not only this effort, but keeping all of us on track. So the purpose of the coalition is, as a refresher, is really a collaborative effort of stakeholders that was initially created in 2018 out of a desire to better understand the KanCare program and its impact across the state. Today, we are a coalition of KanCare consumers, stakeholders, researchers, and state staff whose goal is not to evaluate the KanCare program, but instead establish consensus around metrics that already exist and new metrics that can be created to better understand the performance of the KanCare program as it relates to the whole person. So I'm on slide 4 if you're following. So over the last 3 years, our working groups have been busy evaluating and exploring the data that already exists as part of the program and evaluating existing metrics. We've surveyed stakeholders and members and engaged taxpayers, providers, and policymakers to really understand what is important to each different group in terms of KanCare's performance. Over that time, we've produced 3 sets of recommendations over several key topics that were identified by stakeholders and members alike. We've identified measures that stakeholder and data resources agreed were meaningful to the program and to those that are served by the program. We've identified gaps in availability and limitations in available data. Leveraging those previous activities, we've provided a recent report to KDHE, which includes a few priority recommendations that were relevant to the upcoming KanCare procurement and waiver process, along with components and approaches that could be incorporated into future KanCare MCO contracts or program evaluation design, thereby addressing those identified gaps and limitations that the recommendations have identified. The priority topics included in the most recent meaningful measures recommendation were first identified by the stakeholder working group, and then members of the data resources group conducted an initial scan of available measures for those 3 priority topics, which include telehealth, behavioral health, and quality assurance. Once identified, stakeholder and data resources group members collaborated via task teams to review the available measures, discuss gaps that existed in the data, and ultimately develop the recommendations for meaningful measures. So the report recently provided to KDHE summarizes the work of the task groups and is arranged by each priority topic. Recommendations for each topic cover existing meaningful measures, new meaningful measures which should be developed, and other recommendations which include items for further study or investment in certain areas that were strongly encouraged to address data limitations or other issues related to methodology. So, yep. Slide 5, perfect. The full set of recommendations that have been developed by the group are available in 3 separate publications. They can be accessed individually through the URLs on this slide, and they're all accessible in a list going to kmmcdata.org. Next slide. So those individual reports included recommendations around specific areas: pregnancy outcomes, care coordination, provider network adequacy, recently telehealth, behavioral health, quality assurance, and social determinants of health. Next slide. Some examples of the types of recommendations that were provided to KDHE in these reports. So for pregnancy outcomes, the recommendation includes the development of a summary report or dashboard to monitor over time various measures on pregnancy, including both healthcare processes and clinical outcomes. For care coordination, the recommendations included requiring MCOs to complete the HCBS CAP survey or consumer assessment of healthcare providers and systems, and to complete that survey by waiver, including questions that assess both targeted case management and MCO care coordination. Next slide. For network adequacy, the recommendations included continuing to strengthen the consistency of provider network reporting across MCOs, and then asking future bidders how they would boost network adequacy across the state of Kansas. For quality assurance, the recommendations included increasing the sample size of CAP surveys to allow stratification and comparisons across geographic regions and waiver populations. Next slide. For behavioral health, the recommendations included asking potential bidders what practices have they implemented to improve key measures, including adherence to antipsychotic medications for individuals with schizophrenia and initiation and engagement of alcohol and other drug abuse or dependent treatment. And finally, for telehealth, the recommendations including building data collection mechanisms related to telehealth into MCO contracts and/or overall program evaluation. So while these are just a few recommendations that came out of the coalition, they provide some frame of reference for how the recommendations are intended to improve both the visibility and the transparency as it relates to the KanCare program. So what's next? Those key or priority recommendations are currently with KDHE, and they're reviewing them as they prepare for the next procurement process. And you can see that final report or any of the reports again at kmmcdata.org. So as a founding member of KMMC, I feel a sense of accomplishment in delivering those reports and recommendations to the state to help enhance that performance management process. But as such, we're kind of reevaluating our purpose as a coalition now and deciding where we go from here. So some of the questions that we're asking, and I would pose to all of you today, is in what ways can the work that KMMC has done or is doing be leveraged to complement other activities. We've also asked the state to consider if KMMC's consumer and engagement or stakeholder engagement process can parallel the process for KanCare 3.0. And then finally, from this committee, what would be helpful for you all from KMMC? And I think we ask this question as a coalition every year of the Oversight Committee, but there are lots of resources that kind of are at your disposal as a part of that group. I think the member list is 2 pages. So if there are specific things that you're looking for or ideas about how that coalition can support your work here, just let us know. And so finally, I'll take any questions or comments that you have, but if you ever come up with questions, not when somebody's up here, you can reach out by that email address, and KHI will dispatch that question or concern or whatever you're needing to the appropriate person that can answer that. And so I'll thank you for your time, and if you have questions, let me know.
Sarah, thank you. We will open for questions. I don't see any, so thank you very much. Well, committee, now for the time that you guys have all been waiting for is the discussion and recommendations for joint committees. So for our report to the 2022 Legislature, you should have the handout from Connor that has a list of all the ones that we thought of beforehand. Please keep in mind that these are not exclusive. We don't have to always just do these. And thank you to my vice chair for showing you what I was talking about while I'm talking about it. So everybody should have that. I think what I would like to do on going through this list is go by the committee member's name first, and we'll go through that. Let you have an opportunity to discuss your recommendation, and then we'll vote, have discussion, and then we'll vote on it. Now, there are some that look like are just fiscal notes, and we'll handle those just a little bit differently. But so starting out, if you're following along, Senator Petty.
Thank you, Mr. Chair. And when you mention, we're just going item by item, by the name, by the item. There's
actually, Senator, what we're going to do is anything that you have on there, since you're first, we're going to go ahead and take all of yours, and then we'll go to the next senator and then go that, or representative, and go that way.
Okay, there actually is one of mine that's on there that add 90846. It can be taken off. It's on the second page. It's on the second page because Sarah already told us that they're working on that. So would allow billing for therapy without the patient participating. They're already.
I think it could still be a recommendation in our report.
Okay, even though she said they're working on it. Okay. Maybe we just stick with that then, since I brought it up to take away and but the vice chair didn't. So, Representative Landwehr brought up the point that. Go ahead, Representative Landwehr. I don't want to talk for you.
No, it's not a bad idea. It's not a bad idea to have that as a recommendation in our report, and I think it also helps our budget chairs when they're going through this. And I believe, and staff can verify, but I think that was about $1 million fiscal note from Sarah's numbers. So,
thank you. Mm-hmm. Are we voting?
No. I would just say if there's disagreement.
So we skipped to the second page of add 90846 as a billable Medicaid code that would allow billing for therapy without the patient participating. So any discussion on that language? Do we need to refine that language, or are we happy with that language? If we are, and we do not need to make any changes, what we'll do for the sake of time is just without objection that will be recommendation will be approved. And then we'll have Connor add the fiscal notes. So Senator Petty, are you ready?
Sure.
to move?
Expand the postpartum coverage to 12 months for new mothers enrolled in KanCare. That was, we had information from that, the very first thing, I think, yesterday. I just think this is we've now had somewhat of a pilot because of the federal money that's come in, and this is a very effective use of funds. I know that the next one requests a fiscal note. I think we actually had a fiscal note in our material that we received yesterday. So I think it was four were state funds.
Yeah, I think 10 something was all funds, and then 4 something was SGF, if I remember correctly.
I think you're correct.
You have that, Connor?
Connor Stengler, KLRD. Sarah presented yesterday on extending Medicaid coverage for pregnant women to 12 months from the current 2 at the bottom of slide 8, fiscal impact estimate, $10.5 million annually, including 4.19 SGF.
I think the return on the money, I mean, you know, does has a fiscal note. It would have to go through a process, but definitely I think it's important to have in the recommendations because they return on the money long-term for our, just as we've today had the presentation on the perinatal behavioral health access program on our mothers and our Kansas children. Earlier is better.
All right, committee. Senator Gossage.
If we have one that's similar, are we going to address those at the same time, or?
Yes, that would be the
Okay.
intention. So if you guys see one on there that I do not,
Mine is right below Senator Petty's, and I would be happy to strike the fiscal note since we already have it, and obviously I missed it in yesterday's discussion. But I would still be interested in knowing further data, because they said they would get that back to us on the number of women who have used the first 2 months and could benefit, because it's hard to know if 4 million is not to say I don't think this is a good idea, just how many women are actually or would participate for the 4 million that we would be spending. I just think that would be a good thing to know.
okay. Representative Ballard.
Thank you, Mr. Chairman. I'm in favor of this one. And, you know, the research that we've been doing on it has indicated that there are a lot more women out there postpartum that have not recognized what it really is. And they may be going to therapy and they're doing a variety of things without realizing that it really is combined with their pregnancy. And I'll just use the example. Some people think, you know, you can be in top shape and still you will suffer from postpartum because there's no formula for why you should or why you shouldn't. And I will just use Serena Williams as an example. Hers was so bad that she ended up almost dying as a result of the complications that really happened. And I don't know anyone that's in better shape than she is. So I think for a lot of women not knowing what it is and not recognizing it, I think they would, if it's recognized and not seen as a weakness, that I think they would benefit from it.
Any further discussion on this? And I was just handed a note from our resident revisor that I need to make a motion, make sure we have a motion in a second, and that I clearly define that or say that. So we will make sure that we do that.
Item? He's just doing by consensus. Unless there's objection, they're adopted.
Okay. So you missed that.
Okay.
Research missed that, so.
Okay. Yeah.
Okay, I will be more clearly and more vocal. So just schematics.
Schematics, yeah. There we go.
So with that, so do we have any other discussion on this recommendation? Not seeing any. Are there any objections? If there are no objections, we will consider this as a recommendation from the committee. Senator Gossage.
May we combine then the recommendation with my request for the further data on the number of women?
I don't see why we can't. So, yeah, we can do that. So, without any objection, the first two items, expand postpartum coverage to 12 months for new mothers enrolled in KanCare, and request further data on the number of women who have used the first 2 months of postpartum services that could benefit from 12 to 12 months. So without objections, not seeing any, not hearing any online. Okay, those are moved to be, Connor. Okay, so we do have an objection from Senator Stephan, or does he have a comment? Senator Stephan?
Thank you, Chairman. I just had a comment and a question. Unfortunately, I've had things kind of pull me away a bit, so there's gaps in my following of everything that's gone on today. But clearly, the need grows and grows and grows and grows, and we continue to extricate God and the traditional family out of our social safety net. That adds to its growth. At any point in this, as we're making recommendations to grow programs, are we having the opportunity to remove programs that aren't functioning well and aren't accomplishing those goals, or not? Thank you.
Thank you, Senator. And those are always open for recommendations by this committee. So those are all, that's an open recommendation if you want, or if you have any. So, okay, do we have any other comments, or do we have any objections to this moving forward? Okay, seeing no objections, that will be added as a recommendation. The second one, Senator Petty.
I'm sure everybody remembers the presentation we had yesterday concerning pediatric care, and this is a reflection of that. It's dealing with primary care services, and those services haven't seen an increase in 20 years. That's my increase the KanCare rate for pediatric primary care services. It could be, and it goes along with the next one with Senator Gossage. It's asking for fiscal note. We did not have a fiscal note for that, but that would come about with the legislation.
Representative Reese, you are listed on this as one of yours as well. So would you like to add to the discussion?
No, I think the senator described it well, so nothing more to add.
Representative Landwehr.
So we do have a fiscal, or we don't yet? We don't. So would the recommendation be that we look at increasing KanCare rates, not just increasing them?
The increased KanCare rates for the primary care services? That's what's...
Right, because without a fiscal note, we wouldn't make it as a recommended increase. We would recommend that it be looked at what that fiscal note would be.
Really?
Well,
we're going to have fiscal notes for everything we're going to recommend? I don't know that. I mean, the fiscal note always comes into consideration through the process.
Senator, I find it difficult to make recommendations if we don't have a fiscal note. You know, one thing is to make the recommendation and have a fiscal note. It's another to ask for it to be looked at to see if this is financially feasible.
I guess that the recommendation could include, with consideration for the impact on the state's general fund.
Yeah, I guess I just, when we go in and, because we've had a couple committees discuss the postpartum one, and that recommendation was coming from other committees as well. So that one probably has a pretty good chance. I think when you go looking at, into these rates, there's a lot, and I guess Representative Carpenter probably needs to be the one that interjects more than perhaps I do on this, is that we don't want to give people the impression in our report that, well, we've said that they should do this, well, then the legislature didn't do it. But they need to understand it's possible that the legislature will look at this and consider these rates, but not that the legislature will do this. This says increase KanCare rates for pediatric primary care services. If I read that, it says, oh, the state's going to increase those KanCare rates for pediatric primary care services. They don't understand our budget process.
I can restate that or make a recommendation that we look at increasing the KanCare rate for pediatric primary services that have not been raised in the last 20 years.
Yeah, yes. That's fine. Erickson.
I was trying to be succinct when I was sending these messages to yesterday afternoon.
Senator Gossage.
Thank you, Mr. Chair. When I wrote my email to Connor, to whether I inadvertently deleted something, but what it should have said was request a fiscal note on increasing the reimbursement to pediatric primary care physicians from 61% of Medicare to 71% like all other medical services. When I read all of the written testimony that came in yesterday, there were, I believe, 7 from primary care pediatric physicians who are all requesting that. And it seems odd that that would be the one that would be picked out that did not match the rest of the medical services. So that's why I phrased it that way. It's like, that makes sense. I can see why they're requesting that. Let's just see what the fiscal note should be on it. So again, I'll restate that. And Connor, forgive me if I inadvertently deleted that when I sent it to you. I'm sorry. That might have been me. So. Okay. Request a fiscal note on increasing the reimbursement to pediatric primary care physicians from 61% of Medicare to 71% like all other medical services, which was their request.
Senator Erickson.
Thank you, Mr. Chair. And I think Senator Gossage covered it because yesterday it was stated that the pediatric does not mirror the Medicare. So I was just wondering if we had indeed confirmed that. So I think Senator Gossage covered it. Thank you.
Just to add a little comment, I wonder if we would be better off because the way I understand the Medicaid reimbursement rates, they're not really statutorily. They're done by the administration or the Medicaid director in that office. And I know in talking with her that there's a lot of things that she wants to do to look at these. I wonder if we shouldn't, on these Medicaid reimbursement rates, maybe back up a little bit instead of requesting statute via statute, because then it's in there and you can't change it. And if we comes into a lot of issues of budgetary issues, and then Representative Carpenter's favorite of, what is that, budget neutrality? Is that neutrality? So I know that's his favorite word and buzzword that he uses a lot. So I wonder, would we not be better off backing up a little bit and lumping all of these Medicaid reimbursement rate increases into one of, let's work or do something with the Medicaid director on solving those issues? Senator Petty.
I see how that fits here, but if you're going back to the postpartum, we already have from the medical director support for that. So,
yeah, that is correct. And we already had a fiscal note and things, and I know that was something that she was kind of working on ahead of time, but we still have a lot more that are looking at Medicaid reimbursement rates on the list. So that's why I brought that up. Senator Petty.
I'm not opposed to that.
So is there everybody then in agreement in lumping all of these into a motion or recommendation that we request from the state Medicaid director a review to turn into each committee, the Bob Bethell, the Public Health and Welfare, this for Senate side and the House version, and then both the budgetary committees on each chamber? Okay, so we'll do that. So we'll just lump all the Medicaid ones into that. Connor, did you get that language that I mumbled there? All right. I'm glad that you understand mumble.
That's a language by itself.
Senator Petty.
So, Mr. Chairman, could we just real quickly go through and then click them off? Like, so with that would cover the pediatric primary care services, that covered the EMS, are you saying that?
Correct, yes.
Would,
Yeah, she said EMS.
I don't, that would not cover the care providers, would it? Because that's just that's a legislative issue.
Yeah, nurse midwives would be the next one. I believe the increase to specialized medical care one would.
I don't think so. That's legislative.
Is that one on the legislative part?
That's just
increase to specialized medical care T1000 service codes.
It's got a fiscal note. I mean, it's
Okay.
legislative. Yeah.
Representative Carpenter, you got
Well, I think, all these go without saying that there will be, they will be subject to the budget process, and, some of them we may be able to do and some of them we may not. It just, we don't have a blank checkbook. We've heard lots of testimony about raising that to $47. We raised it to $43 this last year to be competitive. And then the second one right underneath that, was kind of my screw up, quite frankly. I didn't realize that the ID and DD T1000 was as large as it was. And so what we've got is a 30, the rate for ID and DD are the old $31, and this was not included in the budget process. So this merely brings, the second one merely brings it up to match the one that we approved for the TA waivers in the ID. And it's about a third of what the TA waiver money was, but I can't remember what that was, but anyway.
Okay, thank you, Representative Carpenter. Representative Landwehr.
So we just did the 43 last year, right? Right. And so then so we would be asking here, if we adopted this on that first item up there, is asking to raise it to 47. So 2 years in a row, which may not be appropriate with other items that we also have. So adopting, saying no to the first item, which is Senator Petty's, and then saying yes with the explanation that Representative Carpenter gave, that they were not included when the $43 increase happened on the last budget, like it did for the TA.
Yeah, but I want to get back to our original discussion of figuring out what, we can save that for a later discussion, but on what falls under the Medicaid reimbursement rates. And I guess that one does not fall under Medicaid. Okay, so we will take that one not lump that one, so we have just two then. Increase KanCare rates for pediatric primary care services and increase reimbursement for certified nurse midwives and advanced practice registered nurses, and then increase emergency medical services, EMS. So those three.
Is caregivers under the Medicaid?
That's a good question. What kind of caregivers?
Family caregivers with pending background checks to be paid for, that was yours.
When I get my turn.
Okay.
Well, but you're not the only
Okay,
one.
so let's stay back on course here, so before we get too far off.
Just trying to figure if that's Medicaid. No, it's not. You're sure? Okay.
That's what I thought he said.
We can go back and look at it, that's all right.
Okay, so back on those subject matter, Representative Lynn, you have a question?
Thank you, Mr. Chair. Yes, I'm wondering if we're giving the Medicaid director guidance as far as what we think it should be moved to, what they are what the conferees have requested it be moved to, or is she going to give us a range of what it's going for as far as the fiscal note goes? Are we asking them specifically what it is we want?
So going back to my original statement, I believe I said to have the Medicaid director, Sarah Furtick, go back and pull those. And she had mentioned something about pulling data, and I didn't mention this, but this should be part of it. Comparing these codes that have not had any increases in over 20 years, haven't even been looked at, and compare them with the Medicare rates, and compare that, and then report back to us with that information, fiscal notes of what each code would be, to bring it up to the Medicare, what was it, 65% or 80% of Medicare rate.
So looking at I think she called it like a benchmark rate. 65% was the benchmark that they were looking for. Is that what?
Correct.
For each?
Yes.
Okay. Thank you.
Senator Gossage.
I want to thank Representative Lynn because that was kind of my question. So I guess what you're saying is review and report reimbursement rates for Medicaid medical services. Is that what we're saying? Because some of these don't fall under that, like the caregivers, that's family caregivers, et cetera.
Correct. The Medicaid reimbursement rates, and those ones would be
For medical services.
For medical
I think that
services.
needs to be identified.
okay. Connor has that, so thank you.
Mm-hmm. So
Any-
then I would, along with what she was saying then, I guess I feel like, we had 8 conferees that were all saying, please review the pediatric, specifically 61 to 71%. And I feel like maybe that's a separate issue. Perhaps it's not. To just, when somebody asks me that, the first thing I want to say is, how much is that going to cost? To say, hey, I identify with you. It hasn't, we haven't raised this in a very long time. But we don't know what the fiscal note would be on that. So not to belabor that, but I don't know if I necessarily see those as the same amount because we know how much they're being paid right now. So to have a review on that might be redundant. I just think along with the review, maybe a fiscal note to raise it. Is that what you were saying as well?
Yeah, that will be part of it. So each code will have a fiscal note with it
Okay, a fiscal note to do what?
to increase it to whatever the level it's supposed to be, or common, what it's supposed to be. Well, and I don't remember the percentages. Connor might have it
Well,
when
I
he looks
know
back.
from the testimony, it just said, here in Kansas, the Medicaid pays 71% of what Medicare pays for all medical services, but only 61% for primary care. This is what we consistently heard in testimony. So I would say to 71% for all of those services. So do you understand what I'm asking? How can you get a fiscal note unless they're saying, well, what do you want? Fiscal note to do what?
So what I am requesting or what
Right.
I'm suggesting is that the Medicaid director looks at each code.
Right.
And I believe it's 80%, and someone can correct me if I'm wrong, but 80% of what Medicare payment reimbursement rates are. Then there would be a fiscal note per each reimbursement code And then you will get that. And then in a report, we will get that. And then we can look through, because some of them might only cost like $20,000 to increase. And those might be something that might be a no-brainer. I don't know. And some of them are going to be probably hundreds of millions of dollars. So that will give us a roadmap to look at. And so we can say, yeah, this is a priority, or this isn't a priority, or yeah, we don't want to do anything.
And
But
may I
you'll have
ask,
all that information in
where are
front of
you
you.
getting the 80%? Because they're only asking up to 71%.
The 80% was something, I think EMS, was that what it was? And I think it was something Sarah had also talked about as well.
EMS, yes,
EMS.
yes, the emergency.
And I think Sarah had, in her discussion and her testimony, had also mentioned 80%.
Thank you for that
Welcome.
clarification.
Any further discussion? Senator Petty.
Hate to prolong it, but on the pediatric, along with Senator Gossich's point, maybe the language could, or as we send it off to Sarah, that we want the fiscal on a level of, on a level payment plan, a payment parity between Medicaid and Medicare for pediatric primary care services. We want that kind of a fiscal note, because that's what's lacking.
That would be very expensive.
Well, I mean, if we're asking for some sort of a ceiling to know what that is, that's just for that one category. You're talking about that. It's the same thing. It's exactly what it's exactly what she had written down. No, it's a parity, a payment parity between the Medicare and Medicaid. That would be the same level. Which they're not at now. Right, and nobody's at. But, okay, drop it. Oh, it's just for the pediatric, it would be for the pediatric to be at the same level.
Okay, so do we have any other discussions on this? Okay.
Nope.
Do we have any objections to sending a request to Medicaid Director Sarah Fertig to do a comparison code of the codes for Medicaid reimbursement compared to Medicare reimbursement rates? And I will have Connor look up the percentage that she had talked about doing. It was either 85% of what Medicare was reimbursed. Get that rate, then to submit a report. So we'll have a fiscal note for each reimbursement rate to the Bob Bethell Oversight Committee, the 2 health committees in each chamber, and to both of the chambers that handle the budgets for that. So without objections, we will add that as a recommendation.
All right. You need a motion on that?
No, we're going to do it without objection.
Okay.
So, not seeing any and not hearing any, we will consider that as a recommendation then. So, before we get back to you, Senator Petty, Senator Gossich, does that take care of your 71%, or do you still want one to see what the fiscal note would be on 71%?
If the committee was in agreement, yes. I think partially because, let's say the fiscal note comes back really large on the 80%, and they're like, we only asked for 71%. Could we get an idea of how much that would be? So they're the only ones that have requested the 71%. So for me personally, I would like to be able to say to them, we looked into that. It's the fiscal note is this. That's my opinion.
Senator Petty.
I guess I've become lost. The 71%, are we on pediatric or are we on EMS? Because, but did the 80 come in? I didn't. 85 was EMS.
85,
Yeah, I have that. I have that right in front of me. Okay, but there was no 80, so I was trying to figure out where the 80 came, because the 80 that came from EMS. So, yeah.
Okay.
Okay.
Connor
Stengler, KLRD. As several committee members have noted, there were various reimbursement rate percentages. EMS was 85%. Sarah had said at the beginning of her presentation that the informal rate was to set at 65% of Medicare rates, and then there were others there. So I don't know if there's a consensus right now on a number for the recommendation, or if you would prefer to say reimbursement rate increases for Medicaid medical service codes and leave it as sort of a general review, or if you want to set that benchmark to produce the fiscal note.
Committee, what's your pleasure on this? Representative Ballard.
Thank you, Mr. Chairman. I like the way you were explaining it before because it puts it back in Ms. Furtick's decision as to what it is that she was really proposing to us. And if it comes back that way and if it's too high, then we have to make an adjustment.
Representative Lynn.
Thank you, Mr. Chair. I think I would like to make sure that we at least cover these, because I think she said there were like hundreds of these codes that probably haven't been done, and I don't know that she can do all of those. So I think I definitely want to focus on the ones we've heard about, and then maybe the ones that are either the lowest or the ones that haven't been looked at in the longest amount of time. And maybe have that be the focus, because I don't think she can do all of them.
It's whatever the will of the committee is. Representative Landwehr.
I think we're complicating this unless Connor's writing a lot better than I am sitting here digesting this. I don't recall, and maybe it's a different process that you guys are doing in the budget process, is where we came in and did percentages of what Medicare was doing. We've always directed the Medicaid director is that these concerns have been raised. She has access to all the testimony if she wants to look at it, and I believe that most of these people have already been in contact with Sarah. Would that be right? Yeah. So she's got a pretty good idea what these are. So I think we're confusing everything because some may come in at this percent, some at that percent, da-da-da-da-da. Like she said, it's probably thousands, not hundreds. It's thousands of codes that are out there. Depends upon what area that you're in. And that's why you see that we're very cautious anytime that we talk about opening a code, because it's not that simple. So I think if we were to give Sarah the leeway, because I think she's a very capable individual, and say, Sarah, these are areas that we are considering and would like to look at increases in. What would those increases cost us? And I think she's smart enough to give us, a ballpark of, well, it would be this if you raised it this much, this if you raised it that much, and be able to do it. Can she do that by January or February? No. We don't know. But she might be able to do just these right here, but she couldn't go looking at all the other codes. Because I can guarantee you just get in the mental health side, and I don't know, Amy, how many would you guys like to open up? 20, 30 codes? Never mind.
It's too many.
So it becomes a problem. So these here, we just say, Sarah, take a look at these, give us an idea of where they're at today, when they haven't been, how long has it been since they've been raised, and an idea of where we could raise it to. Because not everything can revolve around Medicare.
That's what I was suggesting, so I'm in favor of staying that way. I mean, it's her bailiwick. I mean, she is the one that's doing it. We're sitting here kind of speculating, and I would just.
She already knows what these percentages are, so we don't have to go in there and second guess them. We just say, Sarah, and actually some of us have had a conversation with Sarah about this Medicaid stuff, so she's aware that it needs to be looked at. And I think when she sees this list, she'll know what to come in and start targeting, because she may take and call the chairs and say, hey, this one here is about $400 million. Do you really want me to look at that? And again, like the representative said, because if we went back and we looked at, what was the one that was something that was a fiscal note of, like the 90846 code. That's $1 million. That's pocket change in what it is that we do, but it can have a big impact on things. And, I guess it's a process I'm a little more familiar with, thank you to KHI and the work we've done on the mental health modernization, is we look at, okay, what is the recommendation and how feasible is that recommendation? Is it low-hanging fruit to where It's easy to get, has no fiscal note, okay, well then, we can raise that one up there and make it a high recommendation. But if it's got a big fiscal note on it, yeah, it's going to be a very, very heavy lift. And that's when the legislature steps in and makes their priorities. So I would make it kind of a general Connor. And one of the things this committee is that when Connor gets all this language put together we talk about today, we'll all have a chance to look at that report and then make adjustments as we see. It's like, well, no, that's not what we really meant. So we have that opportunity. This isn't a final report today.
Yeah.
We'll get to approve that.
Mr. Chairman, if I could just comment, I'd have to agree with that because part of the problem is we can't solve that problem today. We're asking her to just give us information. That's all. We're making recommendations. I mean, even when we go to appropriations, we're going to talk about if that's too much and how we're going to do it. And it's going to happen what social services is going to do it. All we're doing is giving recommendations. And I hope we just give them, and leave.
Representative KanCare.
Leave. Are you done, Representative KanCare? I think you were done. Thank you very much for your time.
I agree with the idea to have a general study. I just want to throw this out there, a little bit of warning that, and I'd like to see the Medicaid reimbursement rates improve. But if we start down that path, then there's going to be other groups come and that's great if they do. But we're not going to know, we're only going to know the fiscal note on the ones that we've asked for, but it could really explode once we've opened that Pandora's box.
Senator Gossage.
Thank you. Could we then, because I agree with what Senator Landwehr is saying, could we then identify, we keep saying these, could we identify what these are and make that into one? Is what we're asking them to do.
I don't know you.
Oh, did I say Senator again? I apologize.
I thought that it was the agreement part, so it's okay, Senator.
That if we identify specifically which of these we're talking about and what they want to review and how much it would cost to increase them, to lump it all together is fine. I don't know if we have that many. I think we basically have EMS that we're talking about, and we have the pediatric primary care. Is there another one that I'm missing?
Yeah, there's 3, EMS, pediatric, and certified nurse midwives.
But the midwives, who pays them? Are they paid directly from Medicaid in reimbursement, or is that paid to an organization who decides how much to pay them? Because this is a different situation. These people are paid directly by Medicaid. They are paid directly.
Representative KanCare.
Yeah, they're a provider.
So then we have
nurse
those
midwives
3.
are APRNs that have specialized in OB.
So then I guess my alternate motion would be for us to identify those 3 and ask the question that you identified, Representative Landwehr.
Yeah, Connor.
Connor, KLRD. I can read the language as it stands now and give you a sense of where we're going. So what I have is request the state Medicaid director to review and report, including producing fiscal notes and historical comparisons, on raising Medicaid reimbursement rates as percentages of Medicare for various codes, in particular EMS, pediatric primary care, and certified nurse midwives, and submit the report to the Bethell Committee, et cetera, et cetera. So we could talk about the various codes, but I have named EMS, pediatric primary care, and certified nurse midwives.
I second that. No.
Mr. Chair, I have Bethel Committee, Senate Public Health and Welfare, House Health and Human Services Committee, and the Social Service Budget Committees in the House and Senate, subcommittees in the House and Senate.
I told you guys, Connor can interpret, mumble. Lean very well, so.
We was just going to tell him he
Kinda
was going to write it, we were going to leave.
So, with that, Connor, great job, by the way. And with that, so without objection, we will use that as our recommendation. Not seeing none and not hearing none, that will be a recommendation. Yeah. Representative Kincannon.
Thank you, Mr. Chairman. This is for the temporary I was going to say nurse midwives because we were talking about nurses' aides. So we've all heard numerous proponents the last couple of days as to the value of the TNAs in light of the continued workforce shortage. I really don't think I need to lay out a lot of discussion on this. I think we all know the necessity.
So on this, Eileen.
Thank you, Mr. Chair. I just wanted to mention one thing when we were discussing the usage of LNA, and Senator Gassage mentioned that the usage was also for a licensed nursing assistant. I did do a search statutorily, and that title is not used in the state of Kansas. So it would be appropriate if the committee so desired to use a limited nurse aide title if the committee so desired.
Thank you for that. Representative Kincannon.
And just follow up with that, I don't know that we need to decide on the title for it. I mean, we can make a recommendation, but we had discussed over here really in the medical field, the L initial usually indicates licensed or licensure. I mean, but you know that's not the part I'm worried about as much as the fact that we codify the.
Senator Gossage.
Yes, I just want to clarify that we are not codifying the continuation of an emergency in this. Great, thank you.
Okay, so the recommendation is to codify into statute the flexibility of a, whatever we decide to call it, temporary nurse's aide at the time.
Position.
That position, and to have a bill drafted. Is that part of it, of the codification?
Yes, I think
We can request to have a bill draft.
that would be appropriate. Thank you.
Okay. So, all right, so that would be the recommendation. Okay, do we have any objections to that recommendation? Representative Carpenter.
Thank you, Mr. Chair. Just, I suppose what happens when the need is, if there ever is a situation where the need is over and then we've got a law that, do we need to pass another law to rescind that law, which we all know how hard that is? I mean, is there another way of doing it where we can, measure, sunset it? Maybe that would be it. Sunset it in a year's time, or I don't know how long this is going to go on. Maybe it's going to go on forever, but we certainly should look at it in a period of time, in a couple of years and say, do we need this law now? Has things settled down? Okay, thank you.
And I think that would be something I would rather prefer go through the hearing process and on that, but just keep our recommendation to drafting a bill.
Okay.
I mean, me personally, so. Okay. Any other discussion or, okay. Any objections? Okay, not seeing none and not hearing any, that would be a recommendation. Senator Petty.
The recommendation is, we heard from several sources about paying family care providers if they meet the requirement of any other care provider within their home. And I think this should be a piece of legislation. And then it would be aired out through the legislative process.
Okay, do we have any discussion on this? Representative Landwehr, then Senator Gossage, and then Representative Carpenter.
Well, just keep in mind, we used to do that, and there was a reason that it was undone, and it had to do with some abuse, because you have to have guardrails on this. So whatever, whoever's going to work on the legislation for this needs to understand that piece, which means research has to tell us, what did we used to do before, why did we abolish it, and how do we stop that from happening?
Senator Gossage.
I agree with Representative Landwehr, and that's why the wording on mine was taken directly from one of the caregivers in their recommendations, saying that the guardrails are in place for the folks that are current caregivers and during this emergency situation where it has been allowed. So I would just say that's why I find out the fiscal note if we continue to allow this to happen, because I know it's been paid with other dollars, and I'm fine with researching what those guardrails are and if that needs to be changed.
You also have the verification system.
Mm-hmm.
What you mentioned now.
Yes, it was just brought to my attention from Representative Ballard that it does also include the verification systems and the same remuneration and scrutiny for any other paid caregivers. So they would have the same scrutiny, background checks of anybody else. And again, that's taken directly from the recommendation.
Representative Carpenter.
Ditto. I'm good. That's what I want. I know we did this before, and we discontinued it because it was an abused system. So I just want to make sure if we're going to start it up again, that we make sure that we don't go down that road again.
Representative Reese.
I agree with everyone so far. But I'm just wondering if all this could be worked out during a hearing. That we actually go through the legislation with this and work it out through a hearing.
Senator Petty.
I agree, and I think that Senator Gossage just put it in more detail, exactly what I said on the first page, but in some detail. I don't know that the fiscal note, I'm just curious, I don't know that the fiscal note would change because it'd be the same pool of money that's providers are paid for out of, it would just be who the providers are. So that's my only, but that's really nothing. So yeah, work on a piece of legislation that would include that.
So we could combine all four and just make a recommendation that we look into paying family care providers if they meet the requirements of any other care provider, along with a fiscal note, and to be sure to look at the guardrails that are in place.
Fine with that.
Representative Carpenter, then Representative Landwehr.
This may just be able to be done by regulation, versus a law, because they discontinued it by regulation. So it may be not in statutes, but in fact just policy.
Isn't that part of
Representative Landwehr.
I guess you're all making me a little bit nervous, and we're telling staff to go out there and draft bills And then we're saying, well, here, just take this idea and draft it into a bill, and then we'll let the committee process figure out all the nuances. And that's not how we draft legislation in Kansas. So if there's going to be bills drafted with this committee's name on it, then someone needs to be assigned to work with staff, our revisers, to get those bills drafted, and then brought back to the committee for approval before they're introduced.
Senator Gossage.
Perhaps someone can correct me on this, but was this not done as part of the emergency and was paid with emergency funds, right? So if the emergency is over, it's kind of like, can we continue that? Sort of like what we have seen earlier with continuing the flexibility for the temporary nurses' aides. Kind of asking the same thing, are we not? Am I missing that? Okay. So we're just saying, if we were to continue this, how much would it be? And, would the guardrails, assuming the guardrails would be in place, because they already are. So it would be a similar thing. That's why I asked for the fiscal note, because it was paid out of emergency funds.
Senator Petty.
I'm sorry. Good point. We have not seen the guardrails.
I'd be glad to be a point of contact with this piece of legislation, along with Senator Gossage.
Mm-hmm. Fine with me.
Senator Erickson.
Thank you, Mr. Chair. I was wondering, with Representative Carpenter second to the last item, if that could not also be included in an effort to honor Representative Ballard's request to leave.
I think you are spot on. I think we could.
Mm-hmm.
Very appropriate. So. Okay, so, and I just want to make one comment before we go to what the motion actually is I am really not a big fan of rules and regulations, so anything that we can do statutorily, I would prefer to do it that way instead of leaving it up to an agency. Eileen, you have a distressed look on your face.
Thank you, Mr. Chair. I'm not sure it's a distressed look so much as a really confused look. So with regard to the TNA bill, it was a recommendation to draft a bill. And this is the request to draft a bill versus a recommendation to draft a bill, because the difference is that if it's going to be a bill sponsored by the Bethell Committee, then either it waits to be approved by the committee until the next meeting, or it's sponsored by one of the health committees, or it's sponsored by a budget committee or something else and approved that way as a recommendation by the Bethell Committee to be drafted as such. So I'm a little confused as to what the request is.
So the initial one on the TNA was a request to, or recommendation.
Correct.
And this one is a recommendation or a request?
Not either.
Is this the same as the TNA?
I think that's what we're trying to decide.
I didn't see it that way.
It would be a request made in the Health Committee as a bill to be drafted that way. So the report from the Bethell Committee would be, it is a recommendation that a bill be requested, so on and so forth, in, one of the health committees that addresses
Thank you,
whatever.
if I may, Mr. Chair.
Senator Gossage.
The way I read the request, my request and Representative Landwehr's request is not including a bill. That would let us determine if a bill should be requested. Yes, I think that under Senator Petty's, which was pay family providers, that would have to require a bill, correct?
I'm sorry, may I answer, sir?
Eileen, go
Thank you,
ahead.
Mr. Chair. If the directive were to recommend that family providers be paid, it would depend on if it were a recommendation that a bill be drafted or just a general recommendation that family providers be paid a certain amount. It's dependent on how the committee phrases whatever recommendation is made.
Like I said, I can only speak for myself, but I was requesting a fiscal note on doing that before recommending a bill be written. And I think that Representative Landwehr is doing the same by saying, we want to see those guardrails, we want to research those guardrails. That was the only recommendation that I would like to see made to.
I think I got confused when I think Representative Landwehr said staff and guardrails and someone has to work with staff, and I got all flustered and.
Okay.
Right, and I keyed on bills because I'm like a hunting dog and my ears pricked up and.
And I have, if I may, I can't speak for Senator Petty, but when she said I'll write the bill with Senator Gossage, I think that would be like after, should that be in place, after the requests were made, we got back the information, decided that was the way to go, then we could work together on that.
Perfect, thank you for the clarification. Things can get confusing with all the discussion that goes on, and I appreciate the clarification. Thank you.
Okay, before we move any farther, I apologize. We have bounced off of so many different walls. I want to make sure we're all on the same page. Connor, would you tell us where we're at, where you have us being at this particular point in time?
Connor Stengler, KLRD. So going back to the previous one, to the TNA, I had right now recommend codifying in statute. Is that still where it stands?
Correct, yes.
Okay. Number 3, the family care providers. I have simply recommend look into paying family care providers if they meet the requirements of any other care providers within industry standard guardrails, and authorizing family caregivers with pending background checks to be paid. Then direct KLRD research to produce a fiscal note.
All right, does that sound correct? Okay. It's kind of what I thought, Representative Ballard, so. All right, without objection, we will use that as our next recommendation. Okay, I do not see any, so that will be added as a recommendation. So now we will jump down to Representative Reese and Senator Petty, allow outpatient clinics and home health agencies to hire speech language pathologists while their license is in provisional status. Representative, before we move on, Connor.
Thank you, Mr. Chair. Just a quick note, a note from our fiscal staff that I received is, as a general rule, fiscal notes are only written for legislation that has been proposed, fiscal notes formally, and they suggested referring to requests for fiscal notes as requests for estimated costs in the recommendations, if that pleases the committee. Okay.
I think everybody's in agreement. Schematics. Okay, Representative Reese.
Thank you for that clarification. That's great. Okay, looking at the allowing outpatient clinics and home health agencies to hire speech language pathologists while their license is in provisional status. And right now, I believe it was only hospitals and one other agency that the pathologist could could work in and receive supervision at the same time. This would open that up so that the outpatient clinics and the home health agencies could also provide supervision for the pathologists until they receive their provisional license, or till they receive their license. This would also help to increase being able to keep those speech pathologists working within those agencies and clinics or home health agencies.
Ditto.
Representative Landwehr.
The information that I had on this is it was something that KDADs had to look into and see how they could actually do this.
I believe I heard the same thing.
So we would direct KDADs to come back and report to the legislature on what the process they would see and what that fiscal would be on it.
Yeah, if it's possible, then, and
Right.
now, yeah.
Okay. Any further discussion on this? Senator Gossage.
Just to answer Representative Ruiz's question, it's nursing homes and hospitals. There you go.
Okay. Senator Petty, did you have anything on that one? That recommendation? All right, committee, do we have any discussion or objections? Senator Gossage.
We were just discussing, rather than the word allow, which says you have to do this, basically, or we're recommending that you do it, would be recommending that they report back to us on, KDADs would report back to us on.
What the mechanism would be and what it would cost to make.
Right.
Connor, did you get that? Okay.
Thank you.
All right, any other discussion? Senator Petty.
So after I looked at this again, because it's the only places that can currently bill for speech therapy during this status are nursing home and hospitals. So we're talking about a billing issue. Does that fall into that same category that we earlier put the 3 other items in? I'm not sure.
It's just only certain 2 can do it right now.
I know, but we're making a recommendation to expand that other. I'm just asking this question. It's an academic question for somebody to ask.
Representative Landwehr.
The issue is that currently they cannot allow the provisional while their license is a provisional status, they're not allowed to do it. So they're asking them to be able to do it in advance of actually being officially licensed is all they're doing. So they're not expanding facilities or anything like that. They're just saying, and I believe that was part of the emergency action actually was there were nurses and different healthcare individuals that as they were coming out of their schooling before they could actually get their licenses in place were allowed to go ahead and practice. So they're asking here is while their license is in provisional, which then would give them some additional people so that they can stop a delay.
Senator Petty.
But part of the reason why they're not being used at these other locations is because they can't bill for that supervision. They can't bill for it. So it's a billing issue.
Representative KanCare.
You heard me mumbling. I think you've combined a couple of issues. I think the provisional one was for the background checks to be able to start working, or am I confusing it now even more? No, I know there wasn't one on that one, but that was the one where they wanted to be able to go ahead and start working. And this one, you're right, they wanted to be able to be paid to work in other facilities.
Well, that's not what this year says.
Okay, sorry, I'm not looking at it, so I need to keep my.
No, you may be right.
There were two issues. One.
Representative Reese.
Thank you, Mr. Chair. I don't remember the billing piece. What I remember is not, you cannot employ them because if you are in a clinic or in a home health agency, you has to be pathologists who could be supervisors, but you're not allowed to do that. Your agency's not allowed to do it. You can only supervise if you're in a hospital or in a nursing home. So you can't employ them during that provisional period. Or not, well, it is a provisional period, I guess. It's a supervisory period.
Senator Gossage.
This is from Minds Matter, and the way they state it is speech language pathologists must complete a one-year supervision phase after getting their degree while their license is in provisional status. The only places that can currently bill and then being reimbursed by Medicaid, if that makes sense. Not just they can bill, but they can't be reimbursed for a speech therapy during this status are nursing homes and hospitals. It only needs to be changed back so outpatient clinics and home health agencies can hire these well-qualified therapists too. So we're just asking them to review if they would allow these other facilities to do that. What does that look like?
Senator Petty.
I guess I'm just slow at this, but my question is still the same because it is a billing issue. And so we talked about with those other three items, because those were billing issues, that they were going back to Sarah. So that's my question. Would this need to be included in that?
I don't believe it would be a Medicare reimbursement rate challenge, but it might be a CMS challenge with KDADs, so KDADs might, so a review would probably be appropriate in this case, so they could review it, make sure CMS will allow it.
So a review from KDADs? Is that what you're saying?
I'm sorry, can you repeat that?
A review from KDADs, is that what you were? Yeah.
Correct, yes.
Thank you.
Okay, so that motion then is a review, to review outpatient clinics and home health agencies to hire speech language pathologists while their license is in provisional status. Correct? Okay. So that is a recommendation. Any more proposed recommendation? Is there any more discussion on this? Okay. Without objections, then that will be considered a recommendation. Not seeing or hearing none, that will be a recommendation. I would like to okay, we do have Sarah Fertig is on WebEx, and I guess she wants to add something, has something to add to this. So, Sarah?
Hi, committee. Thank you, Mr. Chairman. So I just tuned into the last part of this discussion. I understand the topic is allowing speech language pathologists with a temporary license to be reimbursed for providing Medicaid services. KDADS and KDHE have been working with various providers to try and pick out the right way forward here. We have identified a way that Medicaid will be able to reimburse for services provided by SLPs with a temporary license. We're in the process of doing what we need to do to make that operationalized on the Medicaid side. And I just wanted to let you all know that we have cracked that code. And some of the comments that I was hearing about a CMS issue and if this is a licensure issue, on the Medicaid side, the main concern is that our MCO contracts require the MCOs to be certified by the NCQA. And there was some confusion over whether or not allowing SLPs with a temporary license to enroll as full Medicaid providers could jeopardize NCQA accreditation. And so we figured out a kind of a workaround that will allow those folks to get paid for the services that they provide with Medicaid dollars, but without jeopardizing our MCO contracts or NCQA standards or CMS standards for that matter. So we have identified a solution for the Medicaid payment piece of that puzzle, and we're in the process of implementing it, but it will take a little while for us to be able to do that.
So you just direct the agency to handle it.
Okay, thank you, Sarah. Sounds like that was problem solved, so no recommendation needed on that one. Okay, I do want to circle back to one, and I apologize, I got this note a little bit late, but when we were talking about caregivers, paying caregivers, apparently that is a CMS issue, and we have to have CMS approval before we can do that. So if we pass, even if we did pass legislation, it would not be able to be go in force because we do not have an authorization from CMS. So we probably need to pull that recommendation back off and then reevaluate what we would like to do. Representative Concanon.
Could we amend that to ask KDHE to whatever they need to do, to write the waiver or look into it? Yeah.
Yes.
Well, whatever is necessary is what I'm saying. I'm just making up words.
Okay. Sure. Yeah, that's what Connor, did you get that? Okay. So without objection, we will amend that current recommendation to just recommend that they look into it, so with no bill, but to get the fiscal notes and all the other stuff to us. So the only thing that will be changed is no bill draft requested or to review a bill, but we'll have the agency review and look into it.
And get the cost estimate.
Correct. Cost estimate, not fiscal note. Yes, thank you, Representative Concanon. Cost estimate. Thank you. So, without objection, we're going to amend that current recommendation. Not seeing any and not hearing any, that will be amended. Thank you very much.
Did we want to go back to those Medicaid ones and ask Sarah about this?
Representative Concanon.
Mr. Chair, I don't know where you're at on the list, but just maybe to delay excitement about being done, I'd like to request one more that's not on here. So when you're done, yeah, just throwing that out there ahead of time. That okay, all right, thanks.
Okay, so we are actually on the last page, if I remember right. So, and these are Senator Petty, Representative Carpenter. There's one. Oh, down there. A committee to look at, okay, so we're on Representative Carpenter, establish a committee to look at the funding needs of the IDD community, long-term, and how to achieve that. Okay. Would you like to make a comment on your recommendation?
Probably. I think that'd be the best way, is ask the LCC to, I don't want to do a permanent committee like, many of you guys have it. I think that we could probably get it done in a short amount of time, but we certainly need to look at the funding issues in the ID and DD community and maybe try to formulate some kind of a, what happens is, much like we've been talking about these other codes, we don't fund them for a long time and then they get way behind and then it's a big fiscal note. Just some kind of a regular funding or incremental funding that happens every few years, or whatever at the funding level now that's adjusted for the CPI or anything like that. But we just end up not funding, then it becomes much like we've heard, half a dozen things this year, then it becomes a hot and button issue, and the fiscal note is, 10 times what it would be if you did it annually. And so anyway, just, I know that Interhab and Mitch, Nick Wood and those guys were wanting a complete committee, like a standing committee to address it, and I don't think that's necessary.
Representative Landwehr.
I'd just like to enhance on that, and perhaps staff would, we could recommend that staff set it up to be structured like the mental health modernization, so that you bring the professionals, you bring the people out there that are actually doing the stuff every day to the table. And that format, I think, has just really worked very, very smooth in order for us to advance.
Yeah, I'm fine with that. End result is what I thought we get there.
Representative Carpenter, let me ask, I'm going to defer a question. I've got a question for Connor, because we had the HCBC IDD waiting list special committee.
Mm-hmm.
Was that just for one session, correct?
Right.
So we just finished it. It was 2 days. I will tell you that one of the things that we found out in that committee, that it's not necessarily funding that is stopping that is causing the waiting list. A lot of it has to do with the waiver that we're on, the way that just imagine having, I think there's 6,500 people total on a waiting list, and you own a business, and let's say you have you repair autos, and you have a waiting list of 100 people, but you have 10 mechanics that all specialize in one thing. Well, you might have the mechanic that specializes in alignments open, but you have 1,000 or 100 people waiting. You don't release that 100 people until all 10 or all 5 of your specialists are completely empty. That's what our IDD waiting list does. They have to wait till all those services are available to take them off. They also don't, all they know on the people that are on the waiting list, names, address, phone number, and that's about it. So caution on, we need more money. That might be a possibility, but I think we have to fix those problems first before we go forward on that area.
Well, that's very interesting, because I agree with you 100%. I believe that our answer to the wait list is and that's one of a proposal also, is to look at that, what is it called? The community support waiver. So I figured in that committee we would come up with that, and the answers that that we know about. But you're exactly right. We need, there are 14 services on that waiver, and you have to be eligible for all 14, which is very expensive. So, I've kicked that around for 2 or 3 years, that we apply for a waiver that 2, 3 services, 4 services. I'm sure most of you have heard my spiel on that, but it makes no sense to wait until we have people that and I venture to say we could take half the people off there with even a 2 or 3 or 4 service waiver. So that's part of the process that I visited with the secretary this morning about, we open up the 1115 waiver in 2023, and is that waiver serving our state, well? And we need to look at, a lot of states have been very creative in their Medicaid waiver. The 1915 waiver is a lot more flexible than this 1115. And so it's just part of the answer. Okay. Thank you.
All right, very, very good. So your request for a recommendation is to send a request to LCC to establish a committee to look at the funding needs of the IDD community long-term and how to achieve that. Go ahead,
Maybe
Representative
funding
Carpenter.
problem may not be the correct answer. Maybe it should be just to address the wait list.
Okay.
Just have it, just study that.
Yeah,
The whole thing.
whatever.
Don't
I
put in
mean,
cost, don't put in wait list,
yeah.
don't put in price, nothing, just study that.
Yeah, I don't want to get caught up on funding. I want to get caught up on addressing the wait list, so.
Okay, so the requested recommendation by Representative Carpenter is to send a request to the LCC to establish a committee to look at and studying the needs of the IDD community long-term and how to achieve that. Okay. Do we have any discussion on this? Okay, without objections, we will consider that a recommendation. Not seeing any and not hearing any, that is a recommendation. And the very last one, Senator Gossage, that we have printed is request not a fiscal note, but a estimated cost report on continuing to allow reimbursement for telehealth services. Would you like to?
This came from and it says telehealth needs to continue beyond the pandemic. We've provided teletherapy since the beginning of the COVID crisis. We continue to provide this to people who need it based on medical exposure. So I do have a question if anybody in the staff is listening in that. Is it just for brain injury because that was their request, but that's what they do? But maybe it should be extended beyond that, which is why I left off the for brain injury. If teletherapy or telehealth is not, it was going to end after the COVID crisis emergency situation, that's why I'm asking for an estimated cost to continue to allow that reimbursement.
Okay.
Maybe that could fall within those other three things that we were saying that could continue after the emergency order. Wasn't there a couple of things?
Senator Petty, did you have something?
Well, we're funding telehealth, but this was teletherapy. I know with telehealth, one of the questions has been parity.
I'm sorry, I didn't hear you.
With telehealth, one of the questions has been parity.
Mm-hmm.
So I think this is not, I think you would want to refer to this as teletherapy.
Okay, that's fine. Again, just curious as to what an estimated cost would be to continue the teletherapy. Thank you, Senator Petty.
Okay, so the request for a recommendation by Senator Gossage is to request an estimated cost on continuing to allow reimbursement for teletherapy services. Eileen?
Thank you, Mr. Chair. Representative Landwehr, I believe, and if Sarah Fertig is still on the line, I believe that this was something that she had mentioned during the telehealth working group for the Mental Health Modernization Committee that she had intended, or the government had intended, to continue funding for some of these services, if I'm not mistaken. I might be liberally misconstruing comments, but I don't think so.
Representative Landwehr.
Sarah, are you still there?
I am. Mr. Chairman, I believe the subject is whether or not we would continue covering telehealth services through Medicaid. Yeah, so our response to that has been pretty consistent throughout the pandemic, which is that we understand the value that telehealth options provide to Medicaid beneficiaries, and we have absolutely no plans whatsoever to close the codes that we currently have open. Our huge caveat to that, which is always our caveat, is that if CMS changes the rules on us and suddenly we cannot claim federal financial participation for a particular service, we're going to have to close that for telehealth access because we need to be able to claim the FFP. So that's our caveat. No plans to close any of those codes. We're happy to accept any recommendations that the committee might have in terms of expressing your desire for us to keep those codes open. But, you know, with us, we always have to follow CMS rules.
Representative Landwehr.
Well, and Sarah, along with that, the Medicaid, because there's also been talk about rate parity within the Medicaid telehealth side as well as it is the private sector. And when you get into that, then it's not just about paying for a service. It's about paying for site fees and what's the other one, Sarah? Site fee and origination fee. And those are fees on top of the regular services. So in the private sector, those people that are paying cash because they're high deductible or have insurance then end up paying for all of that. And it's so it's like if your office visit was $50, you're going to be paying $50 plus an origination fee and possibly a site fee. So it's a real complicated issue, and Medicaid has to face the exact same thing as the private sector insurance does. And it's a discussion that the Mental Health Modernization Committee is having, not just on mental health. We're talking about the whole telehealth system itself. And I was trying to pull up our recommendations real quick, and I couldn't get them up here, but we'll be having those, talking about those on Wednesday.
Senator Gossage.
I understand how, Eileen, you're saying that this would fall, and that teletherapy falls under the mental health, and that makes sense. Because it's different than just telehealth in general.
Telehealth is telehealth, whether it's behavioral health or
right.
Mental health or just health.
Mm-hmm.
Eileen.
Thank you, Mr. Chair. I think my point was these services are being covered currently, and as Director Fertig just mentioned, the plan is to continue covering them in the same manner that they're being covered currently, unless CMS decides that there's going to be a change in the program, in which case that's always been the case. If there's a change in CMS guidelines, she has to follow those changes.
So then it's not necessarily the Kansas emergency situation.
No.
Thank you. And then I'm fine with withdrawing that recommendation.
Okay. That is all of our written recommendations. So Representative Landwehr and then Representative Carpenter.
Okay, Mr. Chairman and Connor, where did we end up on the petty recommendation on midwives and APRNs?
Connor, I'm going to defer to you.
Mr. Chair, Connor KLRD. Right now, as the recommendations stand, I have that in the first one with requesting the state Medicaid director to review and report on raising Medicaid reimbursement rates as percentage, et cetera, for various codes, in particular EMS, pediatric primary care, certified nurse midwives. At the time we discussed it, I'll just leave it there. EMS, pediatric primary care, certified nurse midwives.
Okay, but on this written sheet, it says midwives and APRN, so is that two separate issues? Because I think on the certified midwives, and I wasn't here when the midwifery legislation was passed, but I want to say we've only got a handful of them out that are certified right now. So what's the and APRNs is what I'm trying to understand. What's the APRN piece?
Connor, KLRD, I think as I got that from Senator Petty, that might have been just a typographical mistake, not any hint of.
Okay, so it's just midwives in your
Yes,
report?
yeah.
Okay. Yeah, but it's a different issue.
Representative Carpenter.
Thank you, Mr. Chair. So I guess I might have taken a nap. Did we skip over the T1000? What happened to those? So we put that in just request for fiscal notes and estimates and all that.
Connor, correct us if I were wrong.
I didn't hear him say that when
T1000.
he just mentioned that.
Connor, KLRD, I did not put them in recommendation number 1 as it stands now, although I can certainly add them specifically as part of the review from the state Medicaid director.
Representative Landwehr.
I think what we had discussed was, the question was, we had just given them a raise and then they're wanting another raise, and we've got all these other requests out here. So I think it was an item that was going to be left unresolved at this point.
Well, that doesn't take away the need. So, I'm not incredibly concerned that whether the KanCare Oversight Committee addresses that or not, or endorses it. But, we've talked about this T1000. We got an increase last year. We were incredibly low at $31. We got it to 43. They've asked for 47 throughout the whole time. Many of us that have been on the KanCare Oversight Committee have heard Matt with Maxim, and he did it again today, and it's talking about keeping people out of the hospital, and that actually it'll offset, the savings will offset the cost of the $47. We've never raised it to the rate that they've asked for to be able to prove that. And then secondly, last year, the ID and the DD community did not get raised to the $43. They were left out of it. It was only for the TA waiver. So that's fine. We can do it through the budget process.
Well, okay, and then if we go back, then that's what you had mentioned, and I'd forgotten that part. So it was to not make a recommendation on the first one, but make a recommendation on the second one.
Yeah, okay. I mean, I don't know.
But you're going to address it in budgets, what you're saying, so.
We can, and we probably will. I mean, this committee has heard the testimony many, many times about the validity of raising the TA waiver, the T1000. I think that it's valid. I think that his report and his numbers are valid. I've looked at them for 4 or 5 years. I think that those are valid numbers. We just have got to get it where we can hire nurses to keep people out of the hospital. Anyway.
So, Representative Kincannon.
I just want to say ditto. Well,
So, we can add that to amend the original recommendation or make a new recommendation. What would you prefer, Representative Carpenter?
Just add it to the first one. That's
Okay.
fine.
All right.
Not trying to create any problems. It's not going to go away because we recommend it or not.
Okay. So we have a request from Representative Carpenter to add the T1000 language to the first recommendation.
The first one or the second one? Which one on that sheet?
Oh, I think we're talking about.
Yeah, we're talking.
Oh, adding to that one, okay.
Yeah. Yeah.
I would favor that, Mr. Chairman.
Okay.
We do that.
43. Yeah.
So is it two things now? 47 and...
Senator Petty.
Thank you, Mr. Chairman. I totally agree with that, but my question would be, so we don't want to include within our recommendations to look at using American Rescue Plan Act funds potentially first for the $47?
Representative Carpenter.
Well, no, I'm not, these are temporary monies and, yeah, it might be to start it, it's probably going to be, $3-4 million is what this fiscal note will be. I think the fiscal note to raise it from 31 or whatever it was last year to 43, I think was about $9 million. So we're only talking a couple of bucks here and bringing those up, but I've just hesitated to use temporary money for any kind of a thing that's going to be an ongoing expense. You use it that year, the next year you see that in the budget, you're going to have this giant fiscal note that you're going to have to jump through all the hoops again to sell it, and it's artificial money is all I'm saying. But if the committee wants to do that, that'd be great.
Senator Petty.
I just look at it as a way to start, and I don't consider it artificial money. It's real money. It's in our general fund. I mean, we have it, and if push comes to shove, it's certainly a way to fund that. And you're talking about moving to everything to a certain up to 47. So, it would get it into the budget.
So do we have Representative Lynn?
Thank you, Mr. Chair. I would agree with that, but I believe we heard in this committee previously that those providers who were supposed to be receiving the $43 aren't actually getting the $43. It's not actually making it to them. So I would want to make sure that whatever it is we do, that it is actually able to get to those providers. Thank you, Mr. Chair.
Representative Landwehr.
Mr. Chairman, and staff can correct me if I'm wrong, but that's part of the problem in this increase in it. We can't tell them. We can't mandate that that's where they spend the money at. So if they don't go out there and give it to the people that really need it, then that's on them. We cannot mandate that. That's law.
Senator Gossage.
Thank you, Representative Landwehr, and I seem to recall earlier in this discussion why we were going to leave that off of number one, because it is a separate issue. The others are direct providers who receive direct reimbursement through Medicaid, and this is that they get it indirectly from an organization, correct? So this would not be part of number one. It could be a separate recommendation that includes Senator Petty with Representative Carpenter's number two recommendation if they are in agreement.
Representative Carpenter, you want this as a standalone recommendation? So the recommendation request then is to look at increasing the specialized medical care T1000 services codes to $47 an hour. Is that correct? Okay. All right. Do we have any further discussion on this? Connor, do you need to have the TA and IDD waiver listed in there as well, or can you combine those three?
Mr. Chair, so do we have it the same as what's written on the spreadsheet, increase specialized medical care service codes for both TA and IDD waiver? Is that what we're going with?
That's my understanding,
okay.
Yes.
Thank you.
Okay. Yep. Senator Gossage.
If Representative Carpenter is agreeable, as we just discussed, we could add the wording about using the ARP funds, if available, before the SGF funds that were as recommended by Senator Petty.
Yeah, that's part of the number one, so it's already in there. So, okay. Are there any further discussions? Not seeing any. Without objection, this recommendation will be added. Not seeing none or hearing none, that recommendation is added. That does conclude our written. We do have some extra additions first. So I have Representative Ballard, Representative Reese, Senator Petty, Representative Concanon. So we will start with Representative Ballard.
All right, thank you. Mine is very brief. It would be to establish a committee to study the unmet dental needs for seniors and others living in rural areas. It's one that we proposed in social services. It was included in our budget. And I was following up with the presentation today. I think we know that even though I live in Lawrence, Kansas, I get a lot of letters from, as everybody else does, from other places. We know that some dentists in rural Kansas have a 400-mile radius. Some of them are having a difficult time even selling their business to people because they're out so far. But we also know that Medicare does not provide dental needs, Medicaid, excuse me, for seniors. And so that creates a real big problem. So what we wanted was to have them look at what are those unmet dental needs for seniors and others that are living in the rural areas, because we know that dental health really contributes a lot to their physical health and everything else. And we just want them to just look at those unmet needs and give us a report.
Representative Ballard, would this be an LCC request?
It's an LCC request, yes.
Representative Concanon.
Thank you, Mr. Chair. And I absolutely agree with your concern. I just want to throw out there again, though, that the Senior Care Task Force is addressing that as an issue in the working groups. And we did add Tanya Dorf-Bruner to a working group. And that group is working in the next year. I'm not going to disagree with that, but I think we might be duplicating.
Okay. You mentioned part of it yesterday, but I didn't get the full, I didn't get the full scope of that. If that is being met, then I can withdraw this one. I just want to make sure that since we had proposed it before and nothing really happened with it, that it was put back out there again, because that is a tremendous need. But so if that's being met, then I can just withdraw mine.
Representative Concanon.
I hope it's being met. I mean, my plan is for that it would be met, and the vice chair would I hope agree with me on the Senior Care Task Force, which is Senator Hildebrand.
It will be met. Thank you. Okay.
Okay, so that is withdrawn. Representative Reese.
This might be another LCC request. We've all have heard and seen there's such a shortage on direct support workers and personal care attendants. I recommend the formation of a direct care workforce initiative to focus on what kind of training is needed to work within the mental health, IDD, and with seniors. The worker could then focus on a specific service and work with children, adolescents, and or adults. So it's kind of looking at all of these service areas all use direct service workers and or they're called personal care attendants. They're kind of interchangeable. And I wonder if we can, add to our workforce by taking a look at what are maybe the criteria that is needed for each one, what are the specific training needs of each one, and could we train people to be able to go work with folks that are maybe in the mental health side and with the IDD, or work only with seniors. It's just a way in my head that we can try to, beef up our workforce.
So your request for a recommendation is to send a request to LCC to form a working group?
Yes.
To look at the staffing shortages for,
To look at a specific group of workers. They're either called direct support workers or they're called personal care attendants. Those are interchangeable.
okay. Did you get that, Connor? Okay. Representative Carpenter.
I applaud Representative Reeves for that. I tried it a couple of years ago. It is such a big, I mean, and this was before the crisis that we have now. I don't know where you start. I don't know how you even address direct support. You know, I think KDAS has worked on it and are still working on it. I don't have a problem with doing it. I just, I struggle with where do you start addressing these workforce shortages in that it's very difficult. So, thank you.
Any further discussion? Okay, not seeing any. Without objection, Representative Reese's recommendation will be added. Not seeing any and not hearing any, that would be added to the recommendations. Senator Petty.
Thank you, Mr. Chairman. Well, we had two presentations today, one from the Kansas Kids Map on pediatric mental health and the other on from the Kansas Connecting Communities. And I would just make a recommendation that we, particularly from the perinatal behavioral health, that we monitor, that the legislature monitor, we ask the appropriate legislative committees to monitor the funding source for the current funding source for the perinatal behavioral health for Kansas Connecting Communities. I guess that's the actual name, since they're grant funded, and potentially those programs will go away along with the hotline that provides peripartum psychiatric care to Kansas mothers. Maybe you want to rephrase that for me, since you've done a great job of rephrasing things.
Okay, so if we understand it right, Senator Petty would like to recommend that the legislative committees that have that deal with what was the group again? I'm sorry.
Well, I guess it'd be the legislative committees that deal with health and funding.
Right. I apologize, but
it's the Kansas Connecting Communities.
Okay.
Perinatal behavior for health.
Okay, the Kansas Connecting Communities Behavioral Health. Monitor their current funding source. Do we have any discussion or comments on this? Okay, not seeing any. Without objection, this will be added as a recommendation. Not seeing any or hearing any, that will be added as a recommendation. Representative Concanon.
Thank you, Mr. Chair. I am looking at on our chart for specific issues resolution number 32, where this was regarding the bed tax. And when the nursing homes decertify beds, they are not allowed the money back. And in their response, they said it would just require a statutory change, quality assessment language that would need to be changed, and they listed the site there. It looks like it would be fairly simple fix, and I talked to Janice DeBoer when we were finished, and there's not an issue with CMS at all with fixing this, and they're supportive.
So do we have any discussion on the recommendation to look at a legislative fix for the bed tax?
Yeah.
of being prorated on bed cans decertifications. Okay. Do we have any discussion? Okay, not seeing any. So without objection, this will be added as a recommendation. Not seeing any or hearing any, that will be added. Do we have any further recommendations from the committee? Not seeing any. Committee, thank you very much for your work. Connor, go ahead.
Mr. Chair, did you want to raise the recommendation on certified medication aids that we had discussed?
I did. Thank you, Connor, for reminding me of that. There was a lot of discussion on the certification for certified medical medication aid. And Eileen, quit laughing. It's schematics. It's all schematics at this point. So, and if you remember, I had to do with insulin and that. So I know there were some concern from KDADs, but we would like, my recommendation is to have KDADs look into that further and see if there is a fix that we can fix that on that part of the, so they can have that education to where they can do that, put those insulin shots. So do we have any discussion on that motion? Okay, not seeing any. Without objection, that will be added as a recommendation. Not hearing any or seeing any, that will be added. So I believe that is definitely the end of recommendations. So committee, thank you very much. Staff, thank you very much. We couldn't do this without you and your help. And Eileen, thank you as well for your help. And committee, next session, the chairs will flip. So I would be the vice chair and Representative Landwehr will be the chair. So
I just wanted to say Merry Christmas to everybody with my holiday mask. Mr. Chair.
That should be her picture for be hung up in the gallery. So. So everybody, we are adjourned. Have safe travels and thank you very much. Have